chairpersons of the first session to come on the stage and take over the proceedings for today. Dr. Arvind Kanchi, Dr. Smriti Sinha, Dr. Ashwini Gade, and Sandeep Kumar Panda. We have a mix of the young and the not so young. And we have an eminent panel led by none other than Dr. Vivekanand Jha, who would be in the best possible position to teach us what is the way forward for the new nephrology, early career nephrologist or final year residents. The panelists for Dr. Vivekanand Jha would be Dr. Vijay Kher, Dr. Pallavi Prasad, Dr. Arup Datta, and Dr. Sachin Soni. Over to the chairpersons to start the discussions.
संदीप पांडा कल आया और निकल गया.
Life that really makes things go.
This is a session to get lessons from. कल के एक भीष्म पितामह थे, एक आज के भी हैं.
So I think I was approached, and I think there was conversation in between the members of the panel also as to what is this going to be about, right? What are we going to do? And so this is not going to be a real heavy, content-heavy type of presentation where you have PowerPoint slides and so on, but more like a discussion as to what do we think and where we have reached to where, how and why have we reached where we have reached, taking experience from one's own life and basically discussing them out. And sharing some of those with the group here. So the title of the session has been, the path less traveled also is the road less traveled is included in the title. So I think let's just focus on that a little bit. And as is very obvious is that this panel represents in both in chronological order but also in order of experience a whole range of, I think, 40 to 50 years, I guess. I think Dr. Kher, you started your nephrology career, I think, in the late 70s, and many of you have started your careers in the last 5 to 10 years, right? So there is a big range of 50 years or so. So I think the opportunity in the 1970s, nephrology was a curiosity more than anything else. The Indian Society of Nephrology had just been established in 1970. Dialysis had just started in the late 1960s, etc. Transplantation started in the early 1970s. And so to think of taking up a career in nephrology itself was a leap of faith, right? And that was truly the road less traveled, which included around the time, about 10 to 15 years later, when Dr. Arup Datta and I think we are next in order of, if nothing else chronological, how we entered nephrology, and then perhaps Dr. Arvind, and then Sachin, and all of you here. So, Dr. Kher, maybe I ask, can I ask you and take the, yes. So in the 1970s, you have to keep it pressed. That's the way it works.
The side of it also, even switching on doesn't work.
It is not switched on.
Yeah, I think what Vivek has said is right, that when I started nephrology and why I chose nephrology at that point of time was basically that both D.S. Rana, and we were class fellows in internal medicine, so we did internal medicine in PGI Chandigarh, and those days PGI also used to have these guides. They would put faculty members as guide, and Dr. Chugh happened to be a guide when we entered as undergraduates, as just early postgraduates in PGI. And it is Dr. Rana and myself, both of us decided unit 1 was Dr. Chugh's unit and Dr. Datta's unit. He was a liver unit. And we both decided that we will stay in Dr. Chugh's unit and we would do nephrology. So we had started.
Why did you decide that?
Why was basically mentor. I think Dr. Chugh impressed us tremendously during our early sort of presence in the case presentations. He was very vocal. He was inspiring kind of a personality, and that's
bring in the value of mentorship.
Yeah,
when does mentorship stop?
No, when does it stop?
Yes.
No, it never stops.
It never stops.
It never stops. It never stops. And Dr. Chugh continued to inspire till his last breath, and he continued to mentor also and guide all the time.
Would you advise everyone seek out
No,
a
I
mentor?
think if there is an advice that I would want to give to a younger person would be to pick up a mentor, whether you decide to go into a private practice or you want to go into an academic medicine, it's always good to have a mentor. Work for some period of time, maybe 3 to 4 years after your post-graduation, say in nephrology, you've done your DM or DNB or you are preparing in the final exam. I would think that it would be good to pick up a mentor at that point of time. Maybe 1 or 2 also, you can use them and talk about how to develop that career. And mentoring for 3 to 5 years with a mentor probably will make you much better clinician, maybe a better thinker, even a researcher, whatever you want to do in life. So I think it's very important to mentor.
Yeah. And so, Dr. Datta, next, if I can come to you, you also come from the same stable of nephrologists, as do I. And in terms of, Dr. Kher mentioned about private practice, and often people say private practice, government practice. I would like to say that there is only good practice and bad practice. There is nothing like, I think you practice nephrology well or you don't practice it well. Those are the 2 things. So in terms of going into this bucket of private practice, you were senior to Dr. Kher, I think. So you also came out of PGI, which was an intensely academic environment, and you decided straight to go into a non-academic at that time, which were very few at that time in the late 1980s, early 1990s. There were very few opportunities available. So how did you navigate yourself? And you would have had to set your own rules of navigation. So how did you do that, and what are the lessons out of those?
So, when you finish your training and you begin your career, there are 3 ways you can do it. One is academic, and academic can be teaching as well as research, and the other is obviously practice. Now, academic and research, you have to be in a government institution. In my case, the situation was that there was no vacancy even in West Bengal, where I wanted to settle back, because I'm from city. And also in Chandigarh was obviously kind of locked at that time. And in fact, when I passed, the next PSC intake was 2 years after that by an exam, and you would have been posted in a primary health center as a medical officer. So that was the scenario in West Bengal. So you kind of by default, you have to join private hospitals. So the situation was very peculiar at that time, in the sense that there was a huge dearth area, very few hospitals doing nephrology and dialysis centers, but you have to be attached to one of them in order to practice the specialty. Otherwise, you will forget the specialty. So, and you will have to take whatever is offered, and which was not very good, I must say. After so many years, it doesn't matter, but it was really not so nice at that time. You could practice elsewhere, but you're not in a hospital. But if you're not in a hospital, you don't practice nephrology, because it's a very high-end subject at that point of time. And mind you, I was very young, and with this kind of a scenario like dialysis, transplants just was taking place, who would trust a 30-year-old person at that time? So you have to be in a hospital, and the hospital will give whatever it wants to sort of give you. But it is a dearth sector, and there are enough people, but there are few hospitals with dialysis. It's kind of a locked situation. But you do that in order to remain in this specialty, which I did, and then things fall in place gradually. in 2-3 years' time, things start taking place. I was lucky in the sense that there was a few new things were coming at that time. So my real, I would say, the purpose of doing nephrology was kind of being an early adopter to whatever was coming and becoming, state of the art elsewhere. So I am wistful that I have not been part of the science, which I would have very much liked to, part of the science which kind of developed those treatments, but I'm kind of satisfied because I was an early adopter of that, and I brought that into my place.
Yeah, thanks. So again, a number of lessons there. One is obviously the role of opportunity. What is the opportunity that you get? You said that those doors are not open when you were starting out, and so you regret having missed that opportunity. Maybe regret is not the right word, but you would have taken that opportunity had it come along. So please do be on the lookout for opportunities. And those opportunity windows sometimes may open for a very short period of time, and you need to really make sure that you make the best use of those windows. The second, Dr. Datta, as you said that I think being on the lookout for what is going on around you in your own field and trying to be an early adopter is something that you described, is that we often like to operate in safe environments. We want to continue to do what we have been doing for some years, and if something new comes, then we are somewhat diffident in seeing what might it hold for us. But I think using it, perhaps what you would also like to add, I think, is that using it judiciously. Anything that you adopt and look at it from all sides and then adopt it judiciously. And while you are using it, also continue to evaluate how it is doing and make your own experiences.
Vivek, can I?
Yes, you are the boss.
Sometimes, no, not the boss. Sometimes I just wanted to make a point that it becomes so difficult in life that you don't get a teaching hospital attachment, you don't get a corporate hospital attachment like me. I had nothing in hand, and you may have to take the road less traveled or sometimes make your own road to reach there, in which case I had no dialysis attachment, no hospital attachment, and yet when you start your practice, maybe I initiated this aspect of setting up in a very small unit or a satellite unit a dialysis setup, and yet you could probably build on it. And as you said, no teaching hospital, but yet you can teach maybe MD physicians or MBBS people and things like that, or the paramedicals, and yet move on further. So there would be opportunities.
Right, absolutely, Umesh. And as you said, you have been a pioneer in the kind of model of practice that you set up. Multiple units and using those units to create a network, and using then that network to become a force multiplier at multiple levels, at the level of primary care physicians, etc. Now, coming to you, Dr. Arvind, you trained here, and then you went overseas, right? And you spent how many years overseas?
I was there for 3 years in the UK and 5 years in Singapore.
So, good 8 years, and then you decided to come back. That's also something that Dr. K did, and I also did at one point. So what made you decide to come back at that time? It would have been relatively easy for you to find a career in those days in one of those Western countries, high-income countries, etc. And when you came back, what challenges did you face in terms of having a cultural, technological adaptation to the Indian healthcare system? You came to Bangalore, and at that time, if I might be so bold to say, Bangalore was relatively backward in terms of nephrology setup compared to some of the other cities, even in southern India specifically. So what was your experience and the lessons that you drew?
So as far as education in the West goes, be it in the UK or otherwise, I would say it is good to have a different perspective. Going abroad gives you a different perspective of looking at the patient. They have a different way of dealing with the patient. We have a sort of, possibly, at least in India, a way of looking clinically at the patient. They have a different way of analyzing the patient, and that's something that, is good in the sense that we tend to imbibe new things when we go abroad and get a bit of experience there. Coming back to India was a decision I made because in every, perhaps not for many of you, but in every sort of society that you live in, there is a hierarchy. And there are advancements that are possible only to a certain extent. And when you realize that the advancements are not occurring according to your plan, you realize that perhaps, it is better for you to be in your country. The other thing was my children, education of my children. I was definite that I wanted that to happen in India. And those were the factors that led me back to Bangalore. And as I said, when I came back to Bangalore, the scene was such that if you wanted to practice nephrology, something akin to what Dr. Khanna said, you needed to go to hospitals, break open doors to set up dialysis units, and actually physically get a dialysis unit installed and start dialysis. That's just what I did, because you had to go to smaller hospitals. There were only a few institutions practicing nephrology and dialysis when I went back. The others were smaller hospitals. Corporates were yet to come in. And that was the situation where I had to actually physically speak to people and say, look, we'll start dialysis. We started transplant units also in these hospitals. So it is a road less traveled, there's no doubt about it.
Yeah, so that would be something which perhaps the nephrologists of today, fortunately or unfortunately, won't have to go through that kind of experience, right?
Sure.
There were those days, some of you described, and Dr. Khanna, and also Arup and Professor Kher, is that in our days, we knew everything about a dialysis machine, right? What are the innards of the dialysis machine, how to fix it if it breaks down. And now, if I might again say this, if you make a trainee stand in front of a dialysis machine and ask them to start the machine and operate it, they will perhaps get paralysis of some sort. I think it's really important. I don't know how many trainees are here, but I think it's really important to know the technology that you use, because you can get the technology to do what you want to do only if you know it. Otherwise, technology can become your master, which is not the goal. And that goes also to the point that Dr. Datta was making, is if you are an adopter, you have to know that technology, or whatever you are adopting, you have to know it well. Now, if I can come to you, Sachin, you also, after your training, you did a fellowship, and then you came back to, and that's the other thing, you came back to Aurangabad, right? Not really a top tier city at that time, I would say. And that's something, if people have to set up something, they have to go to lower tier cities. But there is no shame in going there. I think the infrastructure has improved quite tremendously. And you started a number of new things in Aurangabad. So what experiences did you have, and what lessons did you draw from there?
Yeah. So Aurangabad was one of my choices even when I was doing my nephrology. I got into nephrology because during my MD, I did from GMC Nagpur, and we had a kidney unit there which used to perform only stick PD. There was no hemodialysis in Medical College Nagpur, but that kidney unit, there was one resident posted, and he always used to be in demand. So kidney unit resident was always known, and I got fascinated with that, and that time itself I chose to get into nephrology. I did nephrology from Hyderabad, and then, as you said, I got a fellowship. And when I came back, I had two options, because I wanted to remain near to my parents. Of course, I am from a taluka place originally. My parents were there, but I couldn't go to a taluka place. So Aurangabad was a social decision or a family-oriented decision to remain in Aurangabad.
But
and
you
when
did set up the unit, and what was your experience?
I wouldn't say exactly I set up the unit because I think I represent a generation maybe 20 years later to all Kher sir, Datta sir, and I came to Aurangabad in 2009 after all my training. Units were there, but there were very few, and there were limited choices to join the hospitals. So of course I was offered kind of inferior job, or not to my expectation, but still one has to start work. So I joined a place where already there was a transplant program and there was a dialysis unit, but subsequently we could kind of take it to next levels, introduce many things in Aurangabad. Aurangabad, I just want to let you all know that for reasons of my seniors like Dr. Bhavikar, is known for kidney transplants. If I would say in Maharashtra, if you look at the density of population and number of transplants, Aurangabad may be leading. And I got opportunity to work in that kind of atmosphere. Another thing peculiar about Aurangabad is like some nephrologists were already doing vascular access surgeries, Dr. Bhavikar included. So that also made me get into vascular access. So these 2 points I picked up, transplantation and vascular access surgeries.
What is the value of a nephrologist? What is the importance of a nephrologist now being proficient with these access procedures and some bits of intervention? What is the importance of a nephrologist knowing all of this, especially if they are practicing in tier 2, tier 3 cities where an extensive support network is not available?
Right. To answer this, I may take little more time because
we don't
many
have
times
a lot of time. You have to be very concise.
So many times it is necessity is kind of drives you to do all these things, and probably that was the reason our seniors started, and I took it forward. And you said why it is important, because now, like if even in Aurangabad, a new nephrologist doesn't have attachment, as Dr. Khanna said, like there is no place, no vacancy. So now every new individual has to identify himself or project himself with something. And I kind of been successful in projecting myself with transplant and interventional nephrology. And interventional nephrology is important for all incoming doctors.
So you established a niche for yourself using, so I think that's the other thing. You try and find a niche for yourself. The opportunity for that becomes smaller and smaller as more and more people emerge. Now, if I can pass on to the three of you, the millennials, if I might say, Ashwini and Pallavi and Smriti. So you've trained in the 21st century, right? Late in the, by the standards of 2025, relatively late in the 21st century. And you've started your careers where at a base which had been set up by a number of people. So what are the challenges that you are, I wouldn't say challenges, but what are the life lessons that you have learned? Starting from training, I would say, because training is an important one. And please consider this a safe space, so please say whatever you think is right. Is what gaps did you experience in your training which you had to later on compensate by other methods, etc. And what is the support that you have got, and what advice would you have for people who want to start nephrology at this time? So maybe starting with you, Smriti.
Thank you so much. I trained at Medanta with Dr. Kher, and it's been only 4 years since I've passed out. And when we came into nephrology, when we were passing out, we had a lot of questions looking at our seniors' career. Should we go abroad for training? Should we go for fellowships outside? And I remember talking to Sir once, and he said that currently the scenario of nephrology, thankfully in India, is such that most of the, at least the good training institutes, offer you an exposure to almost all the setups and the latest technology in transplant, in intervention to some extent in some centers, and general nephrology, of course. Yes, we do lack in the dialysis aspect, I'm sure, because for us, when we trained, there were other things.
So identify 2 gaps in training that you see all around you in the Indian nephrology training centers.
So I think currently the main identification for all of us is which area we want to actually work in, because like Dr. Sachin said...
But when you train as a nephrologist,
yes,
right? So what are the 2 gaps that you identified during your training which you would have liked to have experience to know more about?
So in corporate setups, peritoneal dialysis is something that is severely lacking. And in some setups, interventional nephrology is also, like for us, we were exposed to one aspect of it, but other things I had to pick up when I went out and trained with other people.
So as a result, do you think now in your practice, are you confident in managing patients on peritoneal dialysis?
No, sir. To be very honest,
so that
no.
is a gap that,
yes,
that you hope. So how will that kind of gap be covered, if I can come to you, Ashwini? What is the advice you have now for program directors, right, people who have those programs?
So our teachers in that era most likely are in comparatively a steady state career. They joined the setup and continued as all the aspects of nephrology. And in current era, people to have the work-life balance, try and choose the profession, a transplant nephrologist or an interventional nephrologist.
Is that a bad thing?
No, that's a good thing. That's a good thing to have a good balance, as in to achieve the good balance. But for that, I think henceforth we only have to choose our area of interest and build upon that. See, we have already received all the basic knowledge. Obviously, after that, it's our job to build upon whatever our interests are. Your interest may be Now, my interest because of the case I developed in transplantation, and in Medanta, I had lots of exposure to it. Now that I have changed my working area, I'm finding new opportunities. Like there are lots of onco patients, and I'm getting interested in it. So according to whatever is available, you can build upon that, I guess. And you have already achieved a basic knowledge in terms of training, but henceforth job is ours only. Try and find out where you can get, and there are lots of like these platforms. There are many platforms where you can gain access to. There are many nephrologists who are doing similar work which you are interested in, and you can easily get
All
in
right,
touch
thanks.
with
So then coming lastly to you, Pallavi, again, if you can expand on some of those points, and the last question I would ask you specifically to address is the three of you who are relatively young, right, are as it turns out, Dr. Umesh Khanna selected you are females. So females have a particular, especially of the age that you are in, they have a particularly challenging job in any profession of medicine of making sure that you balance your family lives with your professional lives, still try to advance in your careers as much as you can. So what advice do you have for other colleagues? So if you can add that also into your response.
Thank you, sir. So, first of all, addressing your last point first, as we haven't discussed that earlier. So, all three of us are women nephrologists, and I think at least in this era, I do not think we have as many barriers to development of female nephrologists as we might have had in the earlier years. There's, of course, women in nephrology, but even without it, at least in my experience, I did not feel as if I was differentiated from my male colleagues. But yes, there is a work-life balance which all of us are expected to manage. So I think what is most important is for all female nephrologists that they have to, again, identify what is their priority and choose their niche area. Choose their niche area according to their work-life balance. So if they are interested in one particular topic or field and they choose a mentor accordingly, I think it's easy for them to navigate the time right now. And apart from that, like, so you were talking about the gaps. So I did feel some of the gaps during my training, but what I would like to say is that once your training is finished does not mean you stop learning. So you can, you have to accept you don't know certain things and learn from others. They might be your juniors, they might be your colleagues, or they might be your seniors. But you have to be ready to learn them.
Yeah. Great, thank you. I think we have covered a range of issues, and the last point is extremely important, that learning is lifelong. It doesn't stop just because you finish a particular training program, etc. And I think these kind of sessions are really very, very important for it. So I know we are close to over time, but I've taken permission to go a few minutes over, and I'll return back to Dr. Arup Datta and Dr. Vijay Kher in kind of summing up what we have all heard, and ask again a couple of other specific questions. Dr. Kher, you have the unique distinction, if I might say, of having traversed the entire circle of professional careers, right? Having trained overseas, then having worked in an academic institution, setting up an academic institution, working in India, and then coming into the private sector. What is the lesson that you would like to, again, in the next 2 minutes or so, would you like to? And one more question, if I might say. Also address how can some of these gaps, because you will be in these national board curriculum development committees, etc. These gaps that young colleagues are identifying, how should we address that as a community?
Yeah, I think what you said is important. For a young person, I think looking up at an opportunity and a niche area is something that they must identify during their training itself. They must get exposure to every aspect of training, and I feel that if there isn't a specialty which is existing, say peritoneal dialysis, I think we should rotate these students into hospitals or departments where these facilities are being done. And I think as a core curriculum for national committees and all those organizations and examination boards and all, I would feel that probably in sort of auditing as to whether these things have been provided to the student as a wholesome kind of a training, we should be sort of looked at by these boards. I guess that would be my recommendation probably. I think
What is the value of going overseas, these kind of rotations, etc.?
Overseas is exceptionally good, and I think Arvind talked about it. I think exposure and even thinking in a different plane, different aspects, learning to see same thing in a different fashion. And I think that increases the horizon of your thought process tremendously. I got exposed very early to basic sciences when I worked in the lab itself, and that increased my overall understanding of nephrology, the clinical fundamentals of how clinical medicine would get improved on totally. So I think exposure to some of these areas is extremely important for your development as a whole. And I think that's very, very important. So exposure outside, I would think, has a positive impact.
And anything that you would like to reflect on through your career trajectory from academic center to private sector?
I would think that some period in academics, if one can get an opportunity, everybody will not get an opportunity. But if there is an opportunity for some period of time, I think one should spend 3 to 5 or maybe some more years into academic medicine, and then get into a private practice will become something very, very ideal. So I must consider myself very, very fortunate to have many of these opportunities, and therefore probably that has helped me to be a better nephrologist as well as be a better person.
Can I ask Vijay one question?
Yeah.
So you have just passed from, say, a government teaching hospital, done your DM, and you have an opportunity to continue there, and there is a corporate job waiting outside, and that's a kind of dilemma with many of the early career nephrologists will face. Is there something which could come from you to help them in making this choice?
Yes, I would think that if, especially, even if he wants, ultimately the person wants to get into practice at some point of time, I would still feel that experience of 3 to 5 years, probably, maybe 5 years would be an optimal kind of an experience for him or her to gain that kind of experience of research methodology. Even looking at, in a government setup you will have, or in academic institutions, the number of patients are fairly large. So for you to get exposed to a variety of nephrology problems, which as a trainee you may not conceive or may not understand that well. After your training you will be able to understand that much better.
We'll come to you. Dr. Datta, your reflections.
So I also agree that an exposure outside is important. And as I think Dr. Kher has been extremely fortunate to have done those sequentially outside and then in a government sector. So probably this is kind of a model career, if I may say. Very few people will have that actually. So, and I think an outside exposure, whatever be the time, the third opportunity, the third possibility would be at that point to go out for an exposure. That can also be considered. Few years, it opens up completely. And that kind of a global view is important nowadays. Yeah. You can't be restricted to our own kind of place.
Just, you said early adoption. So for early adoption, you have to be on the lookout for something new coming up. How do you do that? How do you really see that you are at the forefront of new knowledge, being in a private sector?
Firstly, you have to be up to date. That's number one. It's easy now. It was not easy in our times. When we were out of PGI, there was no journals. The journals stopped. I mean, we could not afford them. We used to go to conferences in trains, stay in 100 rupiah day rooms and attend the conferences, and we could kind of devour everything that's been spoken there. And if somebody gave a journal, it was good. But you are always on the lookout and things what is happening, and then as soon as you get an opportunity, you just start using it in the private sector, and then build from there, basically.
Good. Thanks. We are over time, but I'll go just once more round the panel and ask you to summarize in 30 seconds your final reflection, starting from you, Smriti.
So I'm just going to take on what Dr. Umesh Khanna said. Since most of the trainees passing out nowadays are DNBs as compared to DMs, I went back to Nair and did a 2-year course in government hospitals, and I think that was the most holistic kind of training that currently India can offer. You can pick up on whatever you want because the patients are so much.
Great. Thank you, Arvind.
Apart from, being a nephrologist, you can during your nephrology career, look at other options to try to improve yourself. Look at medical writing, look at research, look at social media, look at IT in medicine. There's so many other things that you can branch out while being a nephrologist, and that's something that you may want to think about.
Ashwini?
Just prioritize yourself, specialize in some specific way, and also be in touch with academic, be it you are in private or public, doesn't matter. The academics will keep you inspired because that's how you grow in your field also.
Pallavi?
Sir, I think just to sum it up what everybody else has said, that you should know your priorities. And secondly, I think you should not be hesitant to reach out to others and to collaborate, because I think it's a specialty where working as a team is going to really help. You cannot work as a standalone, although a lot of people are doing that, but I think that really helps you a lot.
Sachin?
Identify your strength, project your strength, practice ethically. There is no need to practice unethically, and remain dedicated to your patient. Your patient is your property, and that identifies you. If you have a patient, your existing hospital wants you, another hospital demands you, pharma is behind you, you will get research, you will get everything. So be patient-centric, remain dedicated to your patient.
Great, thanks.
Vivek, can I take the opportunity of being the organizer, one question to him?
Yeah, you always have.
Sachin, if you were given a second chance and there was an opening in Mumbai, would you have taken Mumbai or continued in Aurangabad?
No, he came to Aurangabad for personal reasons, he said.
Oh, okay.
So that's the end of story.
I would still go to Aurangabad because I get to experiment in Aurangabad, which I wouldn't do.
Now he has found gold in Aurangabad. So obviously it's a retrospectoscope that he has put on. So look, let me take the privilege of moderating to summarize a few things and also to add a few, really. I think I am very glad that Sachin brought in the word ethics towards the end. It's really important that I said there is good practice, there is bad practice, and good practice has to be ethical. So don't forget ethics. Unfortunately, there are a number of colleagues who are being identified in some way or the other associated with some unethical practices. I think it is our responsibility as a community also to discourage that wherever we find that it is happening. That's number one. Number two, I think the one point I would like to plug to all of you, because all of you here are, most of you at least, are very senior people, and you run training programs, etc. And the point that was made by Smriti and Dr. Kher before that is the value of not just plunging into practice right after you finish your training. So spend a couple of years, because there is still a lot to be learned, especially for those who train in DNB programs in a private hospital. In the West, there is this concept of doing PhDs. So a lot of students, after they finish their clinical training, they go to PhD programs. And those PhD programs are an opportunity really for you to, one, discover some bit of research. You may decide whether to or not to pursue that later on. But secondly, also to work in academic settings. And doing PhD doesn't mean that you don't do clinical work. You will do clinical work, but at the same time, you are also identifying a question, clinical question, and going in depth on those issues. I think we must promote that. And if you talk to your DNB students and are able to sort of interest even a small proportion of them to do this, I think that would be a success of our training, and there will be more holistic nephrologists coming out in the future. And as the only person making a strong plug for research, I have to say that research should be an integral part, no matter where you are. And don't think that research requires some special knowledge, special skill, etc. Even counting your patients is research. You know, counting your patients, describing the variations that you see, writing case reports also, but write case reports which are truly educational, not just a routine case report that this is the first case report from Nagpur or this is the first case report from Chhattisgarh, etc. Those sorts of things, because writing helps you think more than anything else. Writing is not writing. Writing is to stimulate your brain. It helps you think as to your thoughts get clarified while you write. And when you write, you are also forced to look into new developments that that are taking place. And let's not kid ourselves. Many of us who are in private practice, when you get into the jet stream of private practice, I think the time to update yourself, as Dr. Arup Datta was saying, it becomes deprioritized. The updating yourself becomes deprioritized. The last thing I would say is, and if that happens, then the only opportunity you have is to come to meetings like this. So when you are here, please don't go on the beach. It's good that the time was given in the morning to go to the beach, but when you have the sessions running, please come to the sessions. I have noticed, at least in some cities in India, and one big city, it is not Mumbai, it is not Kolkata, it is not Chennai, but it's a metropolitan city which will remain unnamed. You go there, you will see no nephrologists coming for sessions. They will come only to sessions that they have to speak in or chair in, right? And so that's really bad, that's sad, and that indicates a degradation of the culture of knowledge, education, and research in those places. Whereas where that doesn't happen, there is always success. So I would just conclude with those remarks, and I would request all of you to give a big round of applause to our panelists.
And thank you, Vivek, and I think he deserves a big round of applause for bringing into focus something which is not discussed in meetings and conferences, and I thought it would be a good idea.
The one more plug I would make is, please read the editorial coming out in the next issue of the Indian Journal of Nephrology.
Right, we will. And I must announce that at the Mumbai Kidney Foundation, we wish to set up a mentorship program for which I will need the help of all these people and all of y'all. And let's see how it shapes. But this is my dream, and I would want to try and set it up in whichever way possible.
Thank you very much, sir. And we move on to the next session for today. May I invite the chairpersons for this session, Dr. Sanjeev Gulati, Dr. Sukanya Govindan, Dr. Manisha Sahai, and Dr. Jeetu Kurian. And the speaker for this session is Dr. Nivedita Kamath from St. John's, Bangalore, who's going to take us through navigating the journey from CKD to successful transplantations in the pediatric patients.
So good morning, everyone. Welcome to this session. And it's a very important session because, after all, children are not miniature adults. And transplant in children is really challenging, much more than in an adult transplant. Right from the disease, FSGS, CACET, which have their own problems, recurrence, bladder problems, the problems of growth, the problems of family dynamics, the problems of growing up. In addition, transition from, I think, a pediatric nephrologist to an adult nephrologist, from teddy bears to suddenly into an adult world where care is maybe a little bit less personalized, and following transplant, problems of immunosuppression, and then marriage and pregnancy, so on and so forth. So I will welcome Dr. Nivedita, one of the best speakers, passionate about pediatric transplant, to introduce us to the topic and take us through it. Over to you, Nivedita.
Thank you, ma'am. Thank you so much for those kind words of introduction and also for putting a huge burden of expectation. I'm very grateful to Dr. Umesh Khanna, sir, for giving me this opportunity to be standing here in this conclave and talking about the journey from pediatric CKD to transplant. And I have taken the liberty to borrow the other half of the sentence from the previous talk, because unfortunately, this is also a road less traveled. So let's see why. And I'll divide my talk into three aspects: the access to transplantation, and when the patient finally reaches you, and okay. Is it better? Yeah. When a patient finally reaches you, what are the medical and surgical issues? I think Manisha ma'am has given a very nice summary, and I'm going to definitely cover some aspects of it. And finally, looking at the outcomes. So we know that preemptive kidney transplant. Kidney transplantation is the best form of renal replacement therapy for a child with kidney failure, and preemptive kidney transplant is definitely the best option. This systematic review and meta-analysis put that in the form of data and showed that there was a significant improvement in graft survival and a significant reduction in acute rejection when a child had the opportunity to get a preemptive kidney transplant as opposed to a non-preemptive. But where do we stand when we are in what we are able to offer to our patients who come with kidney failure? And if we are not able to live up to the standard, what are the challenges? So the first challenge is that children with chronic kidney disease present late to us, and they come with a very high burden of complications. You can see this severely emaciated child with significant bony deformities, and in addition, he had a lot of laboratory abnormalities as well. When we looked at a study from our center of children with CKD stages 2 to 4 and compared it to the CKID database, which is the largest study of chronic kidney disease in children from North America, we found that the median GFR of our population was in the range of CKD stage 3B, whereas in the CKID study, it was in CKD stage 2. Also, you can see that the burden of comorbidities or complications of CKD was several-fold higher than in the CKID study. Among those who present late, about 25% were diagnosed to have kidney disease for the first time when they presented with kidney failure. And among these, about 1/3 of them had presented with life-threatening emergencies requiring urgent initiation of dialysis. And in our study, we found that these children had a high risk of loss to follow-up and mortality. And this is also supported by studies done in similar settings where they found that children presenting with life-threatening emergencies had a high risk of mortality and loss to follow-up, and a systematic review showed that this was more prevalent in low and low-middle income countries as opposed to high-income countries. In our center, we did a study to look at what are these barriers to kidney transplant and why are children not getting transplanted as much as we would like them to. This study looked at all CKD patients registered with us about a couple of years ago, and we found that we had 155 children registered with kidney failure, but a majority of them were either lost to follow-up or died. Among those who continued treatment, only about 30% were transplanted. So even after 2 decades as a referral pediatric transplant center in India, we transplant only about 20% of all children who present with kidney failure. Loss to follow-up is common and results in presumed death in the majority. The barriers, mainly looking at the socio-economic barriers and the logistic barriers, we found that the education level of parents, the occupation, the income, and access in terms of distance and the time taken to reach the hospital were important, significant barriers. Were there any medical barriers? Of course there were, and when we compared our data to the study from the UK, we found that the disease factors, the availability of donors, and the size of the child were what was reported in the UK, and we found similar problems of inadequate access to deceased donor program, unresolved bladder issues, the lack of facilities for a multi-organ transplant, high risk of recurrence, and inadequate expertise for transplanting little children, that is below 10 kgs. Beyond these medical and financial barriers were also barriers of attitude and awareness, denial and poor awareness about chronic kidney disease in children, the primacy of paternal decision-making, difficult choices, negative attitudes about organ donation were all coming in the way of transplanting our children. Is this only in our center or our country? No, this systematic review of outcomes of children diagnosed with kidney failure requiring RRT from sub-Saharan Africa also showed that only about 20% of their patients were transplanted. And you can see that the mortality without dialysis was as high as 95%. Even with dialysis, 1/3 of the children died. Those who were initiated on dialysis, only 50% remained on dialysis after 1 year, and about 1/4 of them were lost to follow-up. And more dismal results were published in the recent study from Nigeria. So the ISN Global Kidney Health Atlas data of 2023 shows that the incidence of kidney transplantation is definitely low in India and countries of similar category. And when we look at the South Asian data, we see that though kidney transplant is available in most of the countries, there is no funding for medications, which makes it a problem for continuing this, and also no official registry to get data on what the challenges are. This survey done by Dr. Sethi from Medanta on looking at the pediatric kidney transplantation services in India found that about 2/3 of the adult and pediatric nephrologists that responded to the survey undertook transplantation in children, but there are only 3 government institutions offering pediatric kidney transplants, saying that most of the centers that offer are in the private sector and are naturally expensive. There are very low rates of preemptive transplants and very few centers undertaking more than 5 transplants in a year. If a patient fortunately manages to overcome all these barriers and lands at your doorstep and is willing to undergo a kidney transplant, what are the steps that we need to take to make sure that we have tackled all the medical and the surgical issues that may arise in the peri and post-transplant period? The most common roadblocks would be the kidney failure complications itself, because we've already discussed how the burden of them is so high in our population. A hostile bladder, which is quite a frequent problem, risk of recurrence, risk of thrombosis, and the need for nephrectomy. Going through a few case scenarios of our own patients, a 10-year-old girl presented with bilateral hypodysplasia has been on CAPD for 6 years. Because of the non-availability of a compatible donor, she's registered for a deceased donor program. She's had multiple admissions for fluid overload, uncontrolled hypertension. We have attempted medical nephrectomy, which did not work, and she has left ventricular dysfunction. So the issues are the complications of kidney failure, uncontrolled hypertension, and cardiovascular complications. Hypertension in children on dialysis with the ABPM or ambulatory blood pressure is found to be close to 100%, left ventricular hypertrophy in 50%, and in our own database we found that about 30% also had left ventricular dysfunction. In addition to the metabolic problems that we all know, the vintage of dialysis, the episodes of fluid overload, intradialytic hypotension, and inflammation are important to tackle. The most important tools for clinical screening and monitoring on a regular basis would be ambulatory blood pressure and echocardiography to look at the left ventricular mass index. And the goal would be to optimize the metabolic parameters and the dialysis-associated parameters to reduce cardiovascular disease-related mortality and morbidity, because it is the most common cause of mortality in children on dialysis and the second most common cause of mortality in children post-transplantation. This girl finally got a deceased donor transplant and is doing well. Coming to a 16-year-old boy who is currently 16 years, but he was referred to us after he was underwent a fulguration for a posterior urethral valve that was diagnosed at the age of 6 years. When he came to us, he had severe bony deformities, hypotonia, he was wheelchair bound. His bladder had showed a small capacity, high pressure with a high-grade reflux. He underwent an augmentation cystoplasty and was on intermittent catheterization. CAPD for 4 years, shifted to hemodialysis because of recurrent peritonitis, and he's on hemodialysis for 5 years. Finally, the family has come around considering transplant, but you can see that there are multiple issues here. Even after the augmentation cystoplasty in the voiding cystourethrogram, you can notice that there is still a bilateral high-grade reflux. So in addition to the severe complications of kidney failure itself with the metabolic bone disease and the debilitating deformity, which may be corrected partially post-transplantation, and the impact that that would have on his quality of life. He's undergone multiple abdominal surgeries, so risk of adhesions, risk of difficulty during the transplant surgery. But what we will focus on is the risk of urinary tract infections post-transplant because of the abnormal bladder and the need for lifelong CIC in addition to other lifelong immunosuppression and medications. If we look at the nephrotics data, among the 5 most common causes, 3 of them, that is acute obstructive uropathy and reflux nephropathy, could be associated with issues with the bladder. So the bladder cannot be overlooked in a child prior to transplant. This is data from our center which looked at the outcomes of children with lower urinary tract dysfunction looked at their graft and patient survival post-transplant and compared it to those who had a normal bladder. And we found that definitely there was a reduced graft survival as well as patient survival, which was statistically significant. And similar data has been reported from large databases, the ANS data, the Argentina database, as well as, comparing to our own. Now, lower urinary tract dysfunction can has damaged the native kidney and can damage the graft by recurrent UTIs as well as the high pressures in the bladder itself. Simple tools that we need to use for every child would be avoiding diary, looking at the ultrasound, and the avoiding cystourethrogram in those who have a higher risk. But definitely pre-transplant, we would like to do a urodynamic study to look at what is the pressure during the storage of urine, what is the pressure during voiding, what is the capacity of the bladder, and is there a detrusor sphincter dyssynergia, which puts this patient at additional risk. The goal is to provide a bladder that stores at low pressure, empties completely with social continence. And the line of medications, the first line would be the use of anticholinergics. The clean intermittent catheterization is a simple but not a very easy to perform, in the sense that it is required lifelong. It has to be done every 3 hours. So it is something that the patient needs to be trained, and we should do it before transplant itself. Bladder augmentation is required in those who have the worst bladders, and though there is a controversy of whether it should be done pre or post-transplant, in our center we routinely do it pre-transplant, ensure the initiation of clean intermittent catheterization, and ensure compliance to CIC before we venture into transplant, because this can be one of the very important causes of a subsequent risk of UTIs as well as graft loss. Coming to our next patient, a 3.5-year-old boy, 12 kgs, primary steroid-resistant nephrotic syndrome, who was also CNI resistant, but surprisingly was genetic negative. Biopsy showed the expected FSGS. The parents wanted a preemptive transplant, but he rapidly progressed to kidney failure and was initiated on PD. He's been on PD. He got transplanted about 2 weeks ago. Pre-transplant had massive proteinuria, so the issues in him are the high risk of recurrence, the risk of thrombosis, and his low body size. Recurrent disease is one of the important causes of graft loss in pediatric transplant, and the most common conditions, of course, are FSGS, which is the second most common cause of kidney failure in children requiring transplant. In addition, atypical HUS, typically the genetic mutations of factor H and others. Primary hyperoxaluria, of course, we know has a almost 100% risk of recurrence, and dense deposit disease. What you may note is also that not only is recurrence high in these conditions, but also the graft loss that is attributable to the recurrence. So in children with FSGS, which is probably the most common thing that you will see with recurrence, is the need for a risk stratification prior to transplant. A genetic evaluation is a must. Donor selection based on the risk stratification. Estimation of proteinuria at baseline to have to know what is it that would raise a red flag about recurrence post-transplant. Post-transplant, they need intensive monitoring, doing urine protein creatinine ratios on a daily basis for the first 4 weeks, because that is the period of maximum risk. Plasma exchange and rituximab as saviors here. This boy had a recurrence and is on plasma exchange currently. Thrombosis is children less than 2 years, donors less than 5 years, a donor-recipient size disparity, prolonged cold ischemia time, and massive proteinuria are the risk factors. It is the second most common cause of immediate graft loss. Coagulation profile and a detailed evaluation for any coagulation disorders, attempting to reduce the proteinuria by maybe a unilateral nephrectomy, and Doppler imaging as early as in the intra-op period itself. We could use prophylactic postoperative anticoagulation to prevent thrombosis, but they require intensive monitoring. Low body weight or size is reported in Western literature mainly as infants and toddlers who present with kidney failure, but in our scenario it also includes older children who are severely malnourished. The most common indications for transplant here would be congenital nephrotic syndrome, CACUT, ARPKD, and neonatal cortical necrosis. The patient-related challenges are optimizing growth and nutrition. They wouldn't have reached the age to receive all the vaccines. They are usually CMV, EBV, naive, putting them at a risk of these infections infections. Syrup formulations are not available for some of the immunosuppressants, so you need to look at alternatives. From the surgical aspects, having adequate space, vessel size discrepancy, intraoperative blood pressure monitoring, and from the kidney disease, massive proteinuria, risk of thrombosis, and need for nephrectomy. The outcomes, however, from Western literature have been very encouraging. A 10-year-old girl, ARPKD, severe hypertension, chronic liver disease with complications. So in addition to extra-renal complications that we need to handle, the need for a liver, kidney, or multi-organ transplant and native nephrectomy. Liver kidney transplant, of course, the standard is the primary hyperoxaluria, but also autosomal recessive polycystic kidney disease forms another important group. Native nephrectomy may be required in children who have significant proteinuria, a non-functioning kidney with high stone burden or recurrent UTIs, intractable hypertension, polycystic kidney disease, a risk of future malignancies, or just to create space to accommodate the adult big kidney into the little abdomen. Though there is a controversy about the timing of nephrectomy, and different centers have their own protocols, we usually prefer to do a pre-transplant nephrectomy or an intra-op nephrectomy. Infections and vaccinations, so live vaccines should be given 4 weeks prior to transplant and are contraindicated post-transplant. The interval between the pre-transplant immunosuppression for the glomerular disease needs to be kept in mind, and monitoring of titers and booster doses whenever required in the post-transplant period. Some perioperative, mainly anesthesia issues we should be on the watch out for. Look at cardiovascular function, associated comorbidities, especially the upper respiratory tract, and lung issues. Native output, because children can be anuric or polyuric, and that may come in the way of fluid management. Maintaining maps of at least 70 millimeters of mercury to and allow perfusion to the adult kidney. You may need to use vasopressors to do this, use of bicarbonate and blood transfusions to maintain hemodynamic status, intensive monitoring, need of mechanical ventilation post-transplant, and pain management. Though adherence is typically a post-transplant issue, one needs to identify those at high risk, like adolescents and other socioeconomic or therapy-related factors, and address them in advance. The outcomes of pediatric transplant have been very promising. This is a little older data from the NAPRETICS database, but even more recent data shows that the 5-year survival for deceased and living donor transplant is somewhere between 95 to 97%, and the 10-year is 85 to 90%. The most important causes of mortality are infections and cardiovascular complications. The most important causes of graft failure are chronic rejection, acute rejection, vascular thrombosis, and recurrence, and death with a functioning graft has been reported in 10%. Transplanting a child is a huge team effort, and we have been very fortunate to have a team of dedicated doctors, nurses, and the transplant team, but also support from the ISN through the Sister Transplant Center program, which has definitely helped us give our donors and recipients a better experience with transplant, but we do acknowledge that there are miles to go before we can rest. Thank you.
So I think that was an excellent overview, Navita, and as far as pediatric transplant is concerned, I mean, this remains the gold standard of therapy, but years back when we did our study, our penetration rate was about 14%. This was in 1999 when we prospectively looked at over a period of year, and you have reported 20%. So obviously a lot more needs to be done. And children often suffer from a double whammy. You know, first and foremost is the attitude. The first point of contact is a pediatrician, and sometimes even a nephrologist, who discourage transplant in children. Although what they forget is that the long-term outcomes are actually better than adults. The survivals are better than adults. And the second major issue which I have found is the access is limited by financial constraint, because children are not, they don't have any insurance or from either the employer, or none of them are medically insured. So it's an out-of-pocket expense for the family. And that, I think, is one of the major barriers. In the same family, we have found that a 70-year-old has had no problem getting a transplant, whereas 11-year child, then come the medical and surgical challenges. So I think there's a lot more needs to be done. I think we need to highlight the success stories so that we can change the attitudes.
Sukanya?
So, great talk. Just wanted to know, about preemptive transplant. We know that's the way to go, but in India, I mean, what's your experience, preemptive versus when they really need a transplant? That's question number one. And do you feel the gender disparity exists in pediatric transplant as well? Have you seen that in your practice? And I mean, answer these questions
yes,
first.
thank you, ma'am. Thank you, sir, for your comments, and I think you have brought out very important points that we see on a day-to-day basis. Answering ma'am's questions, I think the preemptive transplant in our center, we have done very few preemptive transplants, and like I said, most of our patients present with kidney failure, I mean, at least a good 25-30% present for the first time diagnosed to have a kidney failure when they come with fluid overload, severe acidosis requiring ICU admissions. So there the whole opportunity is already lost. When we do see them in CKD, or when we are initiating dialysis, or before we want to, when they are in that kidney failure, stage 4, stage 5, they are going towards, a lot of other barriers that we spoke about, that parents are not willing, they have negative attitudes, they talk to hundreds of people who give them what is the long-term outcome, is it really worth spending so much time? The child will have to be on lifelong immunosuppression. And lifelong means completely different for a child as compared to an adult. For an adult, it may be another 20 years, but for a child, one thinks that it may be for the next 50 to 60 years. So all these are the barriers that we face. So even in our center, though we try and push and try and counsel our patients while they are in stage 4, preemptive transplant rate has been very low, and that is also noted in the study by Dr. Siddharth from other centers in India. Regarding gender disparity, definitely there is a gender disparity even in children. It may not be as obvious, or the reasons may not be as obvious, but both in terms of the donor and the recipient. Like if we look at our data, majority of our donors are mothers, very few fathers, and very few other relatives who come, because ours is predominantly a living related donor transplant. From the recipient point of view, the people who are lost to follow-up are mostly girls as compared to the boys. So for the boys, though it doesn't come out obviously, there is a sense we can get that if it is one male child or one male child among several female children, definitely the family will go all out to try and do their best. But that may not be so for the female children. So definitely we see that in our practice.
Nivedita, excellent talk.
Thank you.
And I have a question for you that in our state, access to dialysis has improved tremendously because of the availability of schemes and free dialysis for patients, and a good number of centers do have pediatric dialysis. But over the years, and this is a trend that is more likely to increase because the dialysis is free. Many patients are comfortable on dialysis.
Yes,
and that sort of puts transplant at the very back in the list of priorities that the family has, because dialysis is taken care of.
Yes.
And more we see patients starting dialysis as a kid and going on to become young adults on dialysis. So how much of that do you see in your region, in your state? And also to the members here, what do you think as a community that we should be doing to address this? Because there are certain centers, say in Singapore or anywhere, where the dialysis program is funded for regular patients only for 2 years.
Yes.
And after that, they have to get means to transplant. So, of course, we also have as a community to produce the data and take it to health policy decision makers. But what are these suggestions from the chairs also, suppose?
Yeah, thank you. Thank you for the comments and for your question. And that is really a very important question, and we do see that
because the last lecture we may not be able to take because I allowed Vivek Jha.
I think so. Okay. So what we do see this happen very often in the sense that
probably more than.
So when patients come when a child comes to and is admitted in the ICU with a life-threatening emergency, the parents want to do everything because they know if they don't, the child will not survive. So at that time, they are ready to pool resources. Probably people are also, like we also are able to provide them with some financial support. Organizations are ready to support it. So, it is easier to manage that situation. But once they are started is eating well, to them all seems okay, and they get into the routine of sort of doing dialysis. So we have internally discussed this point several times that should we, at some point in time, obviously we can't do it when the patient comes in very sick, but at some point in time start telling the family that, if you're not considering transplant, then dialysis is of no use. But since most of our patients are spending for dialysis from their pocket, if they want dialysis, we have to do dialysis. This is not funded by an insurance or by the state program. So in that sense, there is no way that we have control on or we can push them towards transplant. So that is one thing that we have noticed. And we've also tried the other way around, interestingly, that we have said that we will support transplant. The major chunk of expense comes during the transplant surgery, right? So we will find, and donors are ready to support transplant. They are not ready to support chronic dialysis. They are ready to support AKI. They are ready to support a child in the ICU. They are ready to support transplant. They are not ready to support chronic dialysis. So we have said we can support, give you financial support for the transplant. You have to bear the cost of immunosuppression thereafter. Even then we have found that there is a lot of lag. So I think the problem is not just financial, but also the attitudes, not just of our patients, but of the community that is influencing them, of, like sir rightly mentioned, we have had people come back and say, no, but our pediatrician said, no use, just let the child, be on dialysis or just leave it. It's not really worth spending so much time, energy, and effort on this child. So I think it's attitudes also.
So just last question, and can I step back and ask a question that as a adult nephrologist, early career nephrologist, when we see, even in spite of being trained in SGPGA, one of the fair institutes in India, I feel very jittery in the middle of the night when a 3-year-old or a 4-year-old child comes to me with probably an AKI or CKD. So my question is that, from the pediatric nephrology group, what can we do with respect to us as a society to incorporate some kind of a basic training during or after the course, so that we as early career nephrologists are a little more equipped, that we don't feel jittery with respect to the small numbers of the catheter, the blood flow volume, or suddenly when the child develops a complication, what next to do. I have been fortunate that I'm from St. John's, and I had the in the middle of the night, I call up Dr. Nivedita or Dr. Arpana, and they come up with suggestion, and I'm courageous enough. But we don't have the liberty, everybody doesn't have the liberty, and we don't have a pediatric nephrologist at our call or at a referral distance. So as a society, as Indian Society of Nephrology and Pediatric Nephrology, I think we should come forward with a program, probably in a 1-month program or a 6-month program, in which an early career nephrologist can go in and get ourselves trained so that we don't feel jittery. We don't want to be an expert in it, but we don't feel jittery to start an order and put forward. And my second question is that, should we give a priority for the pediatric recipients with respect to the deceased donor? And in Karnataka, do we have a priority listing for the pediatric patients to be taken up?
Yeah, yes. Answering the first question, I think we've had, of late in the last few years, more and more adult nephrology trainees coming to our institution for a 1-month observership, like an external posting. Like when we do our pediatric nephrology training, we go to the adult unit, and so the vice versa happens. And now we have had several trainees coming from different centers, mainly from Tamil Nadu. We could get feedback from them to see how much it has helped them. A few of you here also have come to our institute. So I think that sort of gives you a sensitization to this thing. But of course, procedures and all that may be difficult, but at least you know what to do and how to calculate per kg doses or something of that sort. So some basic information. So that may be a good idea to incorporate in the nephrology training for adult nephrologists. Given your, sorry, what was your second question? The deceased donor, absolutely. I think they should be a priority for pediatric transplants. Unfortunately, currently in Karnataka, it's not, there's no extra weightage that is given to children. It was given before. Currently, it is not, but I think that definitely should be the way forward. Thank you.
I think a lot of pediatric nephrology has been taught by Nivedita. The rest of it will have to be learned by ourselves later on. Thanks so much. I think we have no time for that.
Thank you for that session. So for the next session, which is Oncology, Drugs and Acute Kidney Injury, I'd first like to invite the panelists, Dr. Urmila Anand from Delhi, Dr. Edwin Fernando from Chennai, Dr. Bhavesh Vora and Dr. Alex Suratkal sir on stage. Dr. Shruti Gupta has sent a pre-recorded talk. She is from Harvard, Boston. She's the director of onconephrology program, and she has her clinical focus is on onconephrology and research focus is on nephrotoxicity of cancer therapies. The questions will be taken by the panelists.
I don't think we'll have time for question answers.
At Brigham and Women's Hospital and Dana-Farber Cancer Institute in Boston, Massachusetts. I'm so excited to be giving this talk to you today on onconephrology. This is such a rapidly growing field, and nephrologists all over the world are soon going to be charged with facing increasingly complex patients with cancer. Here are my disclosures. All right, so my objective today is to present 3 cases. One case is going to be AKI related to the cancer itself. One is going to be related to the treatment, and one form of AKI can be seen with both cancer and its treatment. So let's delve right into the first case. So this is a 76-year-old female who presents with bilateral lower extremity edema, hypertension, acute kidney injury, and 9 grams of proteinuria. Her serum creatinine was elevated to 2.3 milligrams per deciliter from a prior baseline of 0.8 milligrams per deciliter. Her SPEP with immunofixation is negative for an M spike, but her capital lambda ratio is notably low at 0.01. So my next step here was to get a kidney biopsy, and it showed the following. You can see this amorphous pink material in the mesangium and peripheral capillary walls. This is a Congo red stain that shows orange-colored positivity by regular microscopy. And if you looked at this under polarized light, you'd see this apple-green birefringence. On immunofluorescence, you see positive stains for immunoglobulin. And also on immunofluorescence, you can see that lambda clearly stains brighter than kappa. On electron microscopy, you have evidence of these fibrils that have deposited in the kidney, and these fibrils are organized and they range in size from 8 to 10 nanometers. So what is the diagnosis here? This is a case of AL amyloidosis. So what is amyloidosis in general? So amyloidosis involves the misfolding of soluble precursor proteins that form these amyloid cross fibrils that then deposit in tissues and cause organ injury. The amyloid deposits, as you saw, are Congo red positive and have this characteristic green birefringence under polarized light. At least 31 amyloid precursor proteins have been identified. And while amyloidosis, cardiac and renal involvement are by far the most common. Now, amyloidosis is very much a systemic disease. And as I mentioned, the heart is the most commonly affected organ, but the kidney is really not far behind. And patients, when they do have kidney involvement, they usually present with nephrotic syndrome. Although occasionally, if they have more vascular involvement than glomerular involvement, they may not, and the predominant manifestation may be AKI. Also, patients can have involvement of other organs, like they can have liver involvement, GI involvement, they can have macroglossia, and dysfunction of both the peripheral and autonomic nervous system. The graph here in the upper corner shows that patients with AL amyloidosis have much better renal survival and overall survival since the advent of both clone-directed therapy and an increase in the number of transplants that are being performed. When you are faced with a patient like this, you want to work them up by sending an SPEP with immunofixation. An SPEP will tell you the quantity of an M protein, and then the immunofixation will be able to characterize that M protein further and help subtype it. Serum-free light chain is by far the most sensitive test, and so you always want to send that as well. And the combination of these tests, the sensitivity is essentially 100% for myeloma and Waldenstrom's and 97% in AL amyloidosis. Especially in a patient with suspected AL amyloidosis, you're also going to want to send a 24-hour urine protein electrophoresis. A spot UPEP has essentially little to no utility, so you want to make sure it's a 24-hour collection. Now, you always need to confirm the diagnosis with doses. It's reasonable to start with a bone marrow biopsy and a fat pad biopsy. And together, that will help identify around 85% of cases. But if these are negative and you're concerned that the patient may have a so-called monoclonal gammopathy of renal significance, then you want to proceed to a kidney biopsy, which is what I did here. It's also important to consider the importance of mass spectroscopy. And the reason for that is accurate subtyping is critical. So there are numerous subtypes of amyloidosis, and it's important to remember that 10% of systemic amyloidosis is genetic or hereditary. And so an important mantra to remember is that having abnormal serum free light chains, having MGUS, and having a bone marrow and renal biopsy showing amyloid doesn't mean that all of these things are related. And in fact, you can have an unrelated MGUS that can coexist with a hereditary amyloidosis. And there's this fascinating case of a patient that's actually published in the New England Journal many years ago. This patient had wild-type transthyretin amyloidosis and a concomitant unrelated MGUS and was misdiagnosed as having AL amyloidosis. And as you can imagine, that has major treatment implications for the patient. And how do you do subtyping? Well, without getting into the nitty-gritty of this, basically you do tissue sampling by laser microdissection, and then you do this tandem mass spectroscopy based on proteomics analysis. This technique is able to identify pretty much all types of amyloid, including some of the rarer subtypes. But unfortunately, it's not widely available, and even we at the Brigham, we have to send out our tissue elsewhere. Now, our patient was indeed confirmed by mass spectroscopy to have AL amyloidosis, which is the most common type of immunoglobulin-associated amyloidosis. So how do we actually treat and manage these patients? Well, the first thing that we do for our patients when they're diagnosed with AL amyloidosis is we want to assess their eligibility for transplant, which is based on their age, their troponin levels, their performance status, and their creatinine clearance. If they're deemed eligible, then they're usually induced with bortezomib, and then they undergo autologous stem cell transplant with melphalan conditioning. If they're not deemed eligible, then they're usually just treated directly with a bortezomib-based regimen. And you can see here that regardless of whether they get transplanted or not, hematologic response is assessed based on the reduction in light chain levels. Now, cardiac involvement is one of the biggest predictors of overall survival, and that's based on NT-BNP and troponin levels. Renal response is also super important, and it's based on improvements in proteinuria and GFR. And these are also the best predictors of risk of progression to end-stage kidney disease. And so not surprisingly, patients with higher eGFRs and lower amounts of proteinuria are much less likely to progress to end-stage kidney disease. Now, one thing I want to highlight is that AL amyloidosis is an example of a monoclonal gammopathy of renal significance. And these MGRS lesions encompass a very wide spectrum of renal pathology, as you can see here. And it includes lesions like monoclonal immunoglobulin deposition disease, proliferative GN with monoclonal immunoglobulin deposits, or so-called PGN-MID, C3GN, and more. The key is that MGRS differs from MGUS because the kidney is involved, and they otherwise don't meet hematologic criteria for treatment. This is increasingly being recognized as super important in both the nephrology and oncology world because these patients, if they're left untreated, they have a very high risk of progressive kidney disease and progression to end-stage kidney disease. And these lesions can also recur post-transplant. And so that's why it's becoming important for us to work with our hem-onc colleagues to identify these patients early and treat them aggressively. Okay, so let's segue to case number 2. So we have a 63-year-old female that I saw in clinic a couple months ago. She's got adenocarcinoma of the lung with metastases to the brain, lymph nodes, and bone. And she's on treatment with pembrolizumab, an immune checkpoint inhibitor, and pemetrexed maintenance therapy. And she came to my clinic for evaluation and management of AKI. She had previously been on triplet therapy with carboplatin, pemetrexed, and pembro, and then she was transitioned to pemetrexed and pembro maintenance therapy. And her serum creatinine had unfortunately risen from a baseline of 0.7 prior to starting all therapy up to 1.4. Her urinalysis was notably negative for blood, protein, any sort of abnormal cells. She did admit to taking ibuprofen regularly. She notably did not have any extrarenal immune-related adverse events, and she was not on a proton pump inhibitor. And we'll talk about why this is important in a moment. So which of the following do you expect to see on biopsy? ATIN from the pembro, tubular injury from the pemetrexed or acute tubular injury from the carboplatin. This is a little bit of a trick question because the answer could also be A, B, or C, but we'll come back to the quote-unquote answer in a moment. But first, let's talk a little bit about the data for treatment of patients with metastatic non-squamous non-small cell lung cancer, because it's really evolving a lot. And the addition of this immune checkpoint inhibitor, pembrolizumab, to standard pemetrexed and platinum-based chemotherapy has really improved survival in these patients. The problem for us nephrologists is that each drug in this triplet therapy combination has nephrotoxic potential. And in this Keynote 189 trial that you can see here, they compared pemetrexed and a platinum-based agent with versus without pembrolizumab in patients with non-small cell lung cancer. And not surprisingly, AKI occurred more commonly in the triplet therapy group. So let's talk about these agents individually. So pemetrexed has been around for a while. It's an antifolate agent. It's actually derived from methotrexate, and it's used for cancers like non-small cell lung cancer and mesothelioma. It inhibits enzymes that are involved in purine and pyrimidine synthesis, and so it blocks DNA and RNA synthesis that's needed for cell growth. There's a wide spectrum of nephrotoxicity, and patients can get ATN, interstitial fibrosis, nephrogenic DI, distal renal tubular acidosis. Some of the known risk factors for nephrotoxicity are higher cumulative dose and prolonged exposure. Unfortunately, the kidney impairment is not always reversible, and some patients have progressive CKD. Here are some biopsy specimens from patients with pemetrexed nephrotoxicity, and you can see the tubular atrophy as depicted by the white arrow, and then there's chronic interstitial inflammation pointed out by the black arrow. And then the bottom panel shows that these patients can actually have progressive interstitial fibrosis as well. I probably don't need to tell you all about the nephrotoxicity of statins, and despite efforts to find less toxic but equally effective alternatives since cisplatin was introduced over 50 years ago, these therapies are actually still very much used for bladder cancer, non-small cell lung cancer, mesothelioma, head and neck cancer, and much more. AKI is arguably the most serious toxicity caused by cisplatin in particular, and it can occur in up to a third of patients. And it's a big deal because it can jeopardize eligibility for other treatments and predispose to toxicities from other chemotherapies. And when it occurs, the AKI predominantly manifests as proximal tubular injury with ATN. Now, the mechanism of cisplatin-induced AKI has been studied for years and years, and it's multifactorial, probably consists of inflammation, vascular injury, oxidative stress, direct toxicity from reactive oxygen species. And interestingly, there are some data from preclinical models that suggest that magnesium, mannitol, metformin, statins, and some other drugs may reduce the risk of cisplatin-associated AKI. And I mention this because this is one of my prime areas of study. I'm going to be actually looking at some of the mechanisms to reduce nephrotoxicity from cisplatin, so more to come. Now, our patient was receiving carboplatin, not cisplatin. And carboplatin is structurally related to cisplatin, but it's better tolerated and has lower rates of AKI. And though it has inferior efficacy in some cancers, it actually has comparable efficacy to cisplatin in advanced non-small cell lung cancer. Now, I'm not going to go into a ton of detail about immune checkpoint inhibitor-associated AKI because it's beyond the scope of the talk, but this is one of my areas of interest. I could talk about it for hours. Immunotherapy is predominantly associated with acute tubular interstitial nephritis. The AKI occurs at a median of 16 weeks, and we actually identified some key risk factors for immunotherapy AKI, including having lower baseline EGFR prior to starting therapy, concomitant or prior PPI use, and prior or concomitant extrarenal immune-related adverse events, referring to inflammation in other organs like hepatitis or colitis, thyroiditis, among others. Now, one interesting thing to note, our patient did not have any of these risk factors, and her urinalysis and her urine sediment were completely bland. So I know I have you on the edge of your seat now, and so let's come back to our case and think about what could be going on, and what would you do? So the only way to really figure out what's going on in a case like this is to get tissue. So tissue is the issue. And without tissue, it's really impossible to figure out what's going on. So that's what I did. I got a kidney biopsy. And this is a low-power view of the biopsy specimen. The top is a PAS stain. The middle is a silver stain, and the lower is an H&E stain. And you can basically see here that there's just mild to moderate chronic changes in the parenchyma. You go closer up, and on this PAS stain, you see flattened tubules. You see tubular epithelial loss of the brush borders. And there's also a focus of interstitial inflammation that's surrounding these non-atrophied tubules. On higher power H&E stain, you actually see the interstitial infiltrates more close up. And you see a lot of mononuclear lymphocytes, and the arrow here is pointing out a rare eosinophil. And so the final diagnosis here was acute tubular interstitial nephritis, likely from the pembrolizumab. So coming back to our question, while the answer in this case was likely A, acute tubular interstitial nephritis from the pembro, the reality is that you can see A, B, or C, and in some cases you may see A, B, and C if there's cumulative nephrotoxicity from all of the drugs. And this case just highlights some of the difficulties that we encounter when we're taking care of patients with cancer who have multiple nephrotoxic agents on board. So with the findings from the KEYNOTE trial that I mentioned earlier and the fact that these patients are increasingly receiving triplet therapy, that actually led us to study AKI severity and recovery among patients who are getting triplet therapy versus those patients who are not. And we actually looked at this in 2 cohorts. And we actually found in 2 separate cohorts that AKI was not more severe in patients who were getting combination therapy versus monotherapy, and that the renal recovery was also equivalent. Now, our data has limitations. These were observational studies, and so there could be some unmeasured confounding, but these data were a little bit surprising and maybe a little bit reassuring that maybe the triplet therapy patients don't do worse. All right, so let's delve into our final case, which is a 52-year-old man with relapsed AML. He's got a white count of 129,000 with 74% blasts, and he's admitted for treatment with venetoclax, a BCL2 inhibitor. One day after he starts treatment, his creatinine rises from 1.1 to 3.2 milligrams per deciliter. On exam, he is tachycardic and he appears ill. His labs are notable for a profound metabolic acidosis, this AKI, hypocalcemia, hyperphosphatemia, hyperuricemia, this profound leukocytosis, thrombocytopenia, anemia, and a very high LDH. So this is a classic case of tumor lysis syndrome, which all nephrologists should be aware of. So TLS is a constellation of clinical and lab findings that results from the rapid release of intracellular contents from dying cancer cells. And this includes hyperuricemia, because uric acid is actually metabolized from xanthine, which is a byproduct of DNA and is released during cell breakdown. With lung depletion actually leads to AKI. And as you can see here, AKI is just one complication of TLS, but some of these patients can also develop life-threatening arrhythmias from the hyperkalemia. They can develop volume overload, leading to respiratory failure. And so this is truly considered an oncologic emergency. Now, the Cairo-Bishop definition for TLS was proposed in 2004, and it helped provide specific laboratory criteria for diagnosing TLS both at presentation and after treatment. And laboratory TLS is defined as any 2 or more of normal serum values that are present within 3 days before or 7 days after starting chemotherapy. Clinical TLS is defined as having laboratory TLS and then any one of the following: AKI, cardiac arrhythmia, or some of the sequelae of hypocalcemia like seizure or tetany. This table shows that the risk of TLS is higher with certain malignancies, particularly hematologic malignancies like lymphomas and leukemias. And it's less common with solid tumors, but there is a higher risk with some of the certain types like small cell lung cancer or treated breast cancer. There are also a number of targeted therapies that are so you can see from this table, there are a number of others that are implicated, like the anti-CD20 antibody obinutuzumab, CD kinase inhibitors, and CAR T therapies. Given that the risk of TLS is high in patients getting venetoclax, it's actually recommended that the dose be ramped up slowly and in a stepwise fashion. And in particularly high-risk patients, the 20 milligram and 50 milligram doses should actually be given in the hospital with hydration and potentially even nephrology consultation. What about TLS prevention in general? So all patients should get fluid regardless of their risk. And those who are at moderate to higher risk, you also want to give allopurinol or febuxostat. And then in particularly high-risk patients, you consider rasburicase. In those with established TLS, you need very close monitoring, maybe even in the ICU, fluids and rasburicase. What about urinary alkalinization? This has actually fallen out of favor. And the reason for that is even though it helps lead to the conversion of uric acid into a more soluble metabolite that can be excreted into the urine, it can actually promote further precipitation of calcium and phosphorus and lead to more tubular obstruction. And so that's why we don't do it anymore. You're probably familiar with the mechanism of action of a lot of the hypouricemic agents that we give. Allopurinol importantly decreases uric acid production, but does not clear existing uric acid. Rasburicase can control uric acid levels really rapidly, and the way that this works is it converts uric acid to allantoin, which is a more soluble metabolite. A couple of important things to remember about rasburicase, though, is there's actually very limited data on whether rasburicase improves renal outcomes in patients with established TLS. It's contraindicated in patients with G6PD deficiency because it can cause methemoglobinemia, and it's also very expensive and not always widely available. So in terms of the treatment of established TLS, so I mentioned that intensive supportive care is important, continuous cardiac monitoring and frequent monitoring of electrolytes and labs, reducing dietary phosphorus and K in the diet, and then rasburicase, as we mentioned earlier. Now, renal replacement therapy and the timing of institution, this is something that comes up quite frequently, and there's actually very little data on it. But anecdotally, a lot of us feel that early initiation of RT may be of benefit in these patients because it helps increase the clearance of potassium, phosphorus, uric acid, and it also helps correct acidosis and hypocalcemia. So my goal with these three cases, in summary, was just to show you that AKI in the cancer patient is common. It's varied in terms of its causes and presentations. It can be related to the treatment. It can be related to the cancer, as in the case of amyloidosis, or it can be related to both, like the TLS case. So we just barely scratched the surface in terms of causes of AKI. Excuse me, and there's so much more we're learning about onconephrology every day. So I want to thank you for listening, and I want to encourage you to join the American Society of Onconephrology if you haven't yet. Thank you very much.
So I think we have some time for discussion, and maybe we could take it.
Thank you. I think, first of all, I'd like to thank all of us. Would like to thank Dr. Umesh Khanna for this conversation on onconephrology, and I think most of us sitting here who are dealing with this kind of patients realize that we need to learn more, because there are sessions after this on pathology of malignancy diseases and MGRS. So we'll just discuss a few things about one that was taken care is the immune checkpoint inhibitors and acute kidney injury. We have actually reviewed our data on 1,000 patients in our hospital. It's not as important or as significant and noted worldwide. We're looking at 25 out of 1,000 patients actually had some form of renal involvement. That included proteinuria and acute kidney injury. So I would like to know if there is anybody who has an experience similar or otherwise. And second area which we always feel is the AKI or progressive kidney disease. We see with our patients who have undergone a stem cell transplantation. I don't know, I am privileged in a hospital which has a very big oncology department, and every day we see transplants done outside in Delhi coming with progressive renal failure. And the question arises whether it is the treatment or the initial disease which caused. Like I have a patient yesterday with AL amyloidosis with creatine 5, with the transplant doing very well. There is no problem with his light chains, his monoclonal proteins, but creatine just went on. Whereas pre-transplant his creatine was 2, which came down to 1. So I leave it to the chair and others to let us know how do they face these drugs and issues with onconephrology.
in addition to the conventional chemotherapeutic agents that we all know and the AKI associated, there has been a lot of talk in the literature, of course, about immune checkpoint inhibitors, and as more and more targeted therapies come in, I think we are going to face this problem. But the issue is, as Urmila mentioned, that the prevalence of renal-related problems with these group of drugs is less. Probably we aren't biopsying enough, or maybe that's the reason, because in our country, how cancer is looked upon is entirely different. Though we have now targeted therapies and longevity is definitely better with cancer. But then unless there's some very, very specific issues or the patient is critically ill, the oncologist does not really refer this patient to us, and we would also take a more sympathetic view and probably not biopsy these patients. And that's the reason why we are not seeing this in large numbers, as you mentioned.
Yeah, I think we are not seeing because we aren't probably, our antennas are not up to pick up these onconephrology related issues.
There are 3 papers from India on this, sir.
Yeah, I agree.
And they did, and I do agree, because they don't biopsy. Like, the reason what we see in India, which is being done, we had a patient on daratinib, 7 grams proteinuria. The oncologist just withdrew the drug. The issue with pembrolizumab and nivolumab, they just withdraw the drug. Whereas I think in the rest of the world, they continue it despite a little bit of kidney involvement here and there.
Right. And the other thing is there are a lot of other areas like hypertension, electrolyte abnormalities, which we do not specifically pinpoint it towards the reason being the onconephrology drugs.
I would beg to differ here. Our oncologists are very proactive, and they want to refer the patients much earlier, thinking that there will be problem contemplated, and at creatinine of 1.1 also and urine protein of trace or 1+ also, they would refer the patients because they think they want to continue with the therapy, and for renal cause it should not be discontinued. So if we can do something proactively, and we do get involved early, we make sure that the diuretics are at their minimum, dehydration is not an issue which is causing the AKI, and of course prevention of tumor lysis and all those things are helping make the therapy lasting and more effective.
So Bhavesh, I think the AKI gets picked up much earlier, but the other issues of onconephrology which a nephrologist should pick up are probably not. Yeah,
are not picked up.
That's what I'm saying. Electrolyte imbalance, maybe hypertension.
Acidosis.
Yeah,
acidosis also.
I think the question would be when to biopsy some of these patients. We are quite hesitant to biopsy these patients. Many of them would have even TMAs, So to pick up these patients and whether even plasmapheresis helps in any of these cases. And some of these like cisplatinum, methotrexate, some of them can go into CKD in spite of our best efforts also. So
they use pemetrexed now very frequently, and it is notorious to progress to CKD if not taken care. So my oncologists ourselves tell us.
Hello. Yeah. Yes, ma'am. So I have, in oncology, we cannot take the decision of that the problem is caused by drug, you take out the drug. This is not that easy. But there are few things, as in for the management-wise, we add ARBs, ACE inhibitors for proteinuria. But if we don't have that, the SGLT2, which we routinely use, there is a dilemma whether to use it in an oncology patient or not to use. So what's your take on that? And second thing is, any experience with bevacizumab related biopsies? Because I have a couple of patients and I'm in dilemma what to do with them, because theoretically they increases the risk and I don't have personal experience.
We had one TMA with bevacizumab. One TMA we saw, and we have not done. The proteinuria which happens with these NIBs or other drugs.
We can continue the drug with it till the nephrotic range.
Actually, we did continue. But the
so that is what
did not come down. Then the oncologist got another investigational drug and removed daratinib, and you'll be surprised the proteinuria came down to almost normal. By just it was like, So there are drugs which are causing various other effects which we are missing. It's just not as simple as with the conventional platinums and methotrexate. Things are very different. So we need to actually work together and find out.
So did you use SGLT2 inhibitors in them?
We did ACE inhibitors, ARBs. We did not use SGLT2.
Unfortunately, my patient, I can't use that.
I have been using and being more cautious about the hydration part and the acidosis part, and I have got a fair response, though select a few patients, but I have been able to let them continue with bevacizumab
And
with SGLT2 inhibitors on board.
any bevacizumab related bleedings, histories and anything? Okay, thank you.
Excuse me. Sir, I did not realize as to why would we think differently for using an SGLT2 in this case. I mean, why are we worried about SGLT2 in onconephrology?
Because in some malignancies they say that SGLT2 increases the progression of malignancy. So it's been dilemma. It's been in dilemma. As in the literature I had gone through, that's what they says. The in pancreatic malignancy, in bladder malignancies do increases the risk of progression. In few there are other reports also that it in fact slows down the progression. So I don't know.
That was a literature which was long time back when it came with canagliflozin with bladder cancer. That is not there anymore. We were part of the earlier studies. It was never there. I don't know, Dr. Vivekanand Jha may see, but those cancer concerns of bladder and all is, I think, not there.
Bladder, pancreas.
There was some concern raised about it, but I don't think it's been really proved.
I think we're going to now move to the next session. Thank you very much. So for the next session, which is Oncology, Drugs and Hypertension, I'd first like to invite the chairpersons, Dr. Alan Almeida, Dr. Dilip Kripalani from Mumbai, Dr. Avinash Ignatius from Pune, and Dr. Manjusha Yadla from Hyderabad. For this talk, we have all the way from Cincinnati, Ohio, a Mumbai boy, Dr. Prakash Gursurkar, who's got a special interest in oncology, drugs and hypertension. He's already online.
So Dr. Alan Almeida is joining us, sir. Sir, please.
Yeah. Alan, you can start.
Yeah. Hi, sorry.
Prakash is online.
Yeah, Prakash is online. I can see him. Hi, Prakash. Well,
hello, sir.
Prakash is the leading light whom we exported, and he went via Canada and now landed up in Cincinnati, Ohio. And he's selected a niche for himself, where he's now gone into onconephrology. And I'm sure that you don't want to hear me. So I think we'll start off with Prakash's talk.
Kim, it's 1 p.m., right? Is it? What's the time, Prakash?
Prakash,
Actually, I miscalculated all my time when I was talking to Dr. Trivedi. And right now it is approaching 1 o'clock at night.
So special thanks to you for all that.
But my excitement was to be more in-person talk and see everyone around and have a live discussion, which is a topic which is close to my heart. And we have so many hypertension experts here. So this would be a lively discussion, hopefully.
Thank you.
So I'm going to just pull up. I hope you can hear me clearly.
Yes.
I'm going to pull up my slides and let me know if there is any technical issue with that. Can you see my slides now?
Yeah, we can hear. We can see it.
Perfect. So I'm not going to waste too much time, and then I'll just kickstart the talk. So thank you so much, the organizing committee of this event, Dr. Khanna, Dr. Trivedi, and everyone, all my seniors, mentors there. Really excited to talk about this topic. No, I don't really have any conflict of interest related to this talk. These are my disclosures. These are the objectives, what I'm going to talk about. So we'll talk about a brief just overview about the epidemiology of hypertension in patients with cancer. How cancer and hypertension, they share a cause and effect relationship. We'll identify some salient contributors to hypertension in patients with cancers and survivors. We'll specifically talk about certain specific drugs, and in the previous discussion, so many of you have already highlighted those specific agents, and we'll talk a bit in details about them, and then just try to have an it's not a consensus, but just an outline as to how to monitor these patients and how to strategize the treatment for these patients. So I'm just going to pull up some data which is more US centric, and this is more of an updated data from the cancer.org, which just shows the estimation of the burden of the cancer which is present at present. So the most important leading cause of leading cancer in males is obviously prostate. Females, it is breast. But what I want you to draw your attention is to the second figure. So you see the trends in the cancer incidence. So actually, if we were back in 1980s and we were still doing the same things as what we were doing in 1980s, the trends would have been following the red line, which just goes upward in an exponential way. But with the advent of the new diagnostics, cancer targeted therapies, screening, surveillance, everything, we are able to avert several thousands of deaths, but at the cost of the increased survivorship, which is good. But we are now facing the increased burden of cardiovascular morbidity, mortality, as well as, most importantly, hypertension. But I also wanted to bring up this data from the Indian Cancer Registry or the National Cancer Registry Program. The current cancer incidence is 1.4 million. Most common cause of cancer, in males, or cause of death in males is lung cancer. In females, still breast cancer. But over till 2025, there is going to be 12.8, close to 13% rise in the incidence of cancer itself. And resultantly, we are going to see an increased number of other chronic conditions, which is similar analogy to what happened in HIV. HIV used to be a big killer, and then with the advent of new therapies, the chronicity and the chronic conditions associated with that. So similar thing is probably going to happen with the cancer, or is happening with the cancer. So let's build up a case as to why really this is important, and let's look at some prior studies which have been conducted in this. So what I'm going to show you is a childhood cancer study which comes from 3 or 4 centers, one of them being the St. Jude's, the Children's Hospital in Seattle, and the University of Calgary. So it included 10,000 childhood cancer survivors. And what they essentially looked at, by the age of 45, and these kids or children who have survived cancer are being followed, there is an increased incidence of coronary artery disease, hypertension, valvular heart disease, and arrhythmias. And one of the common risk factors which was observed in all these was incidence of hypertension. And as you really follow these patients till the age of 45, patients who were treated with radiation therapy, and those patients who got anthracyclines as their cancer chemotherapy. Now, bear it in mind that most of these kids who have been receiving anthracyclines may have had acute leukemia as their initial diagnosis. But you can see the incidence of the cumulative incidence of the cardiovascular disease per se significantly goes up. Now we'll talk about in adults. So this was a retrospective study which featured in 2013, which looked at patients with solid organ malignancy. What they looked at was the incidence of hypertension in them. So when these patients were followed, 30% of these patients developed hypertension, and the median time to onset of hypertension was 96 days after the first cancer diagnosis. So they looked at what are the predictors of hypertension in these patients. So they found certain cancer-specific predictors are there, that is kidney cancer, underlying bladder cancer, and gynecological cancer. These are the cancer types. And the therapies also determined. So cytotoxic therapies, targeted therapies, or a combination of these therapies were predictors of developing hypertension. So how do we strategize? How do we prioritize these things? So in the early stages, when the patient is being treated for the cancer, the focus is always on curing the cancer or maybe getting control over the cancer. But as the patient survives and as the years pass, the focus shifts over to more managing the chronic condition and, most importantly, hypertension in this context. And survivorship essentially begins. It doesn't mean that the patient is cured and then the survivorship begins. Survivorship stands. It basically starts when the patient is diagnosed to have cancer and when patients initiate on therapies. So how is cancer, hypertension, cardiovascular disease, and chronic kidney disease, everything interrelated? And it is a more of a multidimensional relationship. So we all know smoking, diabetes, and obesity are important risk factors. We all know smoking and obesity are independent risk factors for cancer itself, which predisposes to cancer, which predisposes to hypertension, kidney disease, and heart disease. So this is just like a vicious cycle or a multidimensional relationship between all these entities. So now I just want to drive your attention to anti-cancer therapies and what the impact is on blood pressure. So this is a busy slide, and I really apologize for that if you're not able to see it clearly. But what I want to drive your attention here is go back to 2001, when there was only a single agent, that is your imatinib, which was approved for treatment for CML, which was a targeted therapy. But then as years pass by till 2020, there has been a boom in these agents. I mean, most of these agents, I don't even know how to pronounce them most of the times. I have to go back before I see a patient to try to rehearse how to pronounce these drugs, because patients always know what they're getting. So there has been an increased number of these altinibs and mAbs and all those agents. So it's always important for a nephrologist to understand what the driving mechanism or the basic mechanism or what the class effect of these drugs is. So when we talk about hypertension, we all talk about the US or the American Heart Association guidelines. We talk about the European Heart Association. We talk about the NICE guidelines. But when the cancer therapies are being administered and when the National Cancer Institute, when they study these clinical trials, they look at what they called as the adverse events in the cancer criteria, which categorizes the hypertension in 5 grades. And these 5 grades of hypertension may not always equate to our existing hypertension guidelines. So we really see, so the places where you see not applicable is where our knowledge gaps are. So we really don't know yet, should we use the same guidelines as what we have been using in a non-cancer patient to determine the goals and the targets for the therapies. And this research is in progress, and hopefully we will have some answers. We are also working on a position statement where we can have a consensus amongst not just onconephrologists, but nephrologists who manage these conditions, to have some consensus guidelines as to how we set up targets for patients who are being treated for cancer. So this cartoon actually just shows various drugs and various mechanisms by which certain chemotherapeutic agents, be it conventional or certain targeted therapeutic agents, cause hypertension. So Vinca alkaloids, they induce autonomic neuropathy, they cause hypertension. Agents like vascular endothelial growth factor, Burton kinase inhibitors, even gemcitabine for that matter, it causes vascular injury and produces hypertension. So there are certain agents like anti-androgen agents, glucocorticoids, which are administered. It causes sodium retention. So various mechanisms operate, and some of the drugs may operate through multiple mechanisms. So it's important for us to understand what mechanistic pathway these drugs are causing to induce hypertension. So now coming to the elephant in the room, the vascular endothelial growth factor. My talk is going to be concentrated more specifically on this particular agent, and I heard the questions which were being asked by several attendees there about treatment with various tyrosine kinase inhibitors or Avastin. Somebody brought up bevacizumab. So I'm going to address those same issues in my few slides from now on. So vascular endothelial growth factor inhibitors, they have really changed the paradigm of treatment of so many cancers. They are being used in thyroid, brain cancers like glioblastoma, renal cell cancer, colon cancer. Actually, Avastin was FDA approved back in 2003, 2004 for treatment for metastatic colorectal cancer, then liver cancer and gynecological. So you name it, all cancers, there is some protocol somewhere where they are either treated with immune checkpoint inhibitor or a vascular endothelial growth factor, or maybe a combination of these agents. And when clinical trial data was being published, it was evident that the hypertension incidence was between 20 to 90% in these patients, which is a big range and it's a big burden. And a meta-analysis which was published from the Euro cancer data, close to 29,000 patients which were there in that, they looked at the tyrosine kinase inhibitor induced hypertension. The relative risk for developing hypertension was 3.78 compared to placebo. So that's a big burden. So whenever I talk to even my trainees or other nephrologists about approach to hypertension, I like to bring up a few prototype cases which are more of the real cases which I have encountered in my practice. So let's talk about the first case, which is a tyrosine kinase inhibitor induced hypertension. So this was a 60-year-old female who was being treated for gastrointestinal stromal tumor, was treated with sunitinib. Nephrology was consulted because of new onset hypertension and proteinuria. Blood pressure shot up to 170 over 100. Creatinine was reasonably preserved. Urine analysis showed +4 of protein on dipstick. There were no RBCs, so nothing like a nephritic picture. A 24-hour urine protein was done, which showed 3.5 grams of protein. Now, I think everybody in the room will agree that whenever safe, this patient needs to proceed with a kidney biopsy. There was fortunately no evidence of peripheral hemolysis, so platelet function was well preserved. There was nothing to suspect a systemic TMA or a TTP-like pattern happening here. But we did proceed with the biopsy after adequately controlling the blood pressure. And this is what the biopsy showed. So now, in the constraint of the time, I'm just going to run down the pathological image. It basically showed somehow my arrows did not pop up here. I'm sorry for that. But if you can see the pointer, you can appreciate the fibrin deposits which are there in the kidney, and that's quite florid fibrin deposition. You can also see the endothelial swelling here, and you can see the concentric hypertrophy of these arterioles. So this is a very classic injury of thrombotic microangiopathy, per se, a renal limited thrombotic microangiopathy, which can happen in patients who get treated with sunitinib, which is a tyrosine kinase inhibitor. So what was done? We started the patient on lisinopril. Fortunately for this patient, the cancer was well controlled. So the oncologist was bold enough to stop sunitinib, and the 24-hour protein, after that, it decreased to 0.5 grams. Patient unfortunately expired around a year ago because of the progression of cancer, and there were no basically developed metastatic disease. but at least for 2 years, we could keep her, give her a good quality of life. So the proteinuria reasonably came down. Another set of patients which I see very commonly in my practice is just probably because of our neuro-oncology division, and that feeds a lot of patients to me, especially patients who are being treated with all these newer agents, that is bevacizumab. And the sad part of the story is that most of these patients are so young, so productive in their life. So I know somebody brought up a question, how do we manage between the oncology and nephrology? When do we stop the drug? Let's talk about those things here. So we have 3 patients who range between 30 to 40 years who have been diagnosed to have glioblastoma, are treated with Avastin. So patient 1 is a new onset hypertension and develops proteinuria with very well-preserved renal function. Patient 2 develops new onset hypertension but no proteinuria. And patient 3 has a pre-existing hypertension, and now the hypertension is being worsened. So these are the typical scenarios which I encounter. The common thing which I face is the first one, the new onset hypertension and proteinuria. So how soon proteinuria can develop and hypertension can develop after VEGF inhibitor? 55. So this is a case in which a 55-year-old female was treated for recurrent meningioma. She was not a surgical candidate. First dose of Avastin, within a week, blood pressure shot up to 190 over 120 and had dipstick proteinuria, and the 24-hour urine protein was 2.1 grams. Another case, 48-year-old male who was treated for grade 2 WHO grading of oligodendroglioma, not a surgical candidate. First dose of Avastin, blood pressure shot up to 160 over 100. So these are very distinct cases which I have seen in the practice, which probably were like first dose effect. One dose, within a week to 10 days, you see this florid presentation with significant proteinuria and hypertension. Looking at some clinical trial data, which I have already mentioned about, that these 2 drugs which really stand out, the sorafenib and the cediranib, is in one study, it showed 93% of these patients develop elevation of blood pressure by sixth day of treatment. And 67 of the patients had persistent blood pressure elevation. And nearly 43% of these patients had grade 3 hypertension, like patients also presented with hypertension crisis. So pretty much a notorious drug to cause hypertension. So how does these agents, both these tyrosine kinase inhibitors and Avastin, how does it cause hypertension? So it is more of a class effect. So all these agents, they act somewhere on the VEGF pathway. It could act on the VEGF A, VEGF C, VEGF D, or it could directly block the VEGF receptor. So if you look at the downstream pathway of these agents, they typically reduce the endogenous nitric oxide. They increase the endothelin levels. Endothelin is a natural vasoconstrictor. It also increases the systemic vascular resistance. It can also cause podocyte damage and cause endothelial rarefaction, thereby causing an endothelial dysfunction, plus podocyte injury, protein leaking, hypertension, and it's just a vicious cycle. And endothelial, this is more on in the mice model. Endothelial rarefaction can happen as early as 7 to 14 days after the treatment with any of these agents. So, which kind of proves the concept with the previous 2 patients which I showed, who presented with hypertension within a week to 10 days of the therapy. Now, these are more of again mice model, experimental models, but how does really the hypertension happen at the tubular or the nephron level? So it's a very interesting concept which even I recently learned, was the sodium chloride co-transporter on the distal convoluted tubule and the ENaC channels. They actually share a close association with the vascular endothelial growth factor receptor 2, so that they are very in close proximity. So whenever these receptors are blocked, it somehow blocks these other receptors also, which actually causes the sodium reabsorption, and there is decrease in urinary sodium excretion, thereby causing the blood pressure to go up. More of a mice model experiment, no human studies to back this yet. But if you look at in general, the table, if you look at all these drugs acting at various pathways, like I showed, the incidence could be anywhere from 40 in certain drugs like cabozantinib, it could be 30 to 60%, and lenvatinib 70%. So very important drug class effect of hypertension in these. How do you really treat patients who develop VEGF inhibitor induced hypertension? So now there is no real data to support which drug is better. But what we always do is we already try to extrapolate all our data from the diabetic nephropathy or glomerular disease world and try to use it here. So if there is a podocyte damage, what we are talking about, why not use RAS inhibitors? And RAS inhibitors do help in controlling the proteinuria as well as the hypertension. Calcium channel blockers like the dihydropyridines, especially nifedipine, amlodipine, can be used. They are smooth muscle relaxants, as well as they enhance the vasodilatation, especially to counteract the vasoconstriction which is happening from the endothelium. Long-acting nitrates have also been used. You give nitrates, it ramps up the endogenous nitric oxide production, thereby causing mitigation of the endothelium-induced vasoconstriction. So what should we not do? Not to use the non-dihydropyridine calcium channel blockers, because these are enzyme inhibitors. It just messes with the drug, the cancer drug. Per se, diuretics are not contraindicated. I do use diuretics occasionally, but you have to always be cautious, especially with the patient's nausea, vomiting, and volume depletion like scenario. Just be careful. Per se, no, not contraindicated. Previously, when I mentioned that there is no data to support, no particular robust study to support the use of RAS inhibitors. This study, this is a very small study which was conducted out of Vanderbilt University, and they presented this data at the American College of Cardiology conference when they looked at RAS inhibitors in reducing systolic as well as the diastolic blood pressure in patients who were treated with VEGF inhibitor, and did show decrease in the blood pressures in the patients who were treated with RAS blockers. So yes, there is a benefit. Do we have enough data to support that yet? No, but this is the best thing what we have for now. So this is a more of a concept map what we had constructed for one of our review articles, and it is just a mental checklist, not a perfect thing to do, but try to go through a checklist, try to do some risk assessment, like what we usually do for hypertensive patients. Risk assessment, look for the cardiovascular burden, pre-treatment labs, make sure you get a kidney function test, check urine protein, check urine analysis, measure the baseline blood pressure, try to stratify where they really fall into, whether they are high risk, high normal, if they have pre-existing hypertension. And when they develop hypertension, do encourage them to monitor their blood pressure at home, which is easy to say than really do. Ambulatory blood pressure monitoring always helps. We don't have the luxury of doing that. It's not reimbursed by the CMS, so it's very difficult to get it. But this is how I approach these patients, is to start them with ACE inhibitors, ARBs, or calcium channel blockers if they are not already on. If the blood pressure is not controlled, add in second agents like beta blockers, mineralocorticoid antagonist, diuretics. And if still the blood pressure is not if the blood pressure is not controlled, we go into this box where the discussion with the oncologist really helps. Now, if a person is a young person with a cancer like glioblastoma, but is dependent on Avastin for the therapy, and that's the only drug which is available, then the real-time discussion has to be there between you, patient, and the nephrologist as to what are the risks of stopping the drug, because that may just kill the patient. So with adequate RAS blockade and all the antihypertensive agents, we try to control the blood pressure. I have a patient who is a 30-year-old executive, bank executive, who has glioblastoma, and he is non-operable, but doing excellent, but has 3 grams of protein. So we just continue the drug, adequately manage, and just pray. So what are other targeted cancer therapies we have which can induce hypertension? And this, I just given you a list because I didn't want to go into details about all these drugs because it just opens up a Pandora's box. But a few agents like the Burton kinase inhibitor, that is the ibrutinib, which is being used in the CML, mTOR inhibitors, sirolimus, everolimus. Important to address is the proteasome inhibitor. Sorry, I'm just going to pull up the incidence of hypertension here with each of these agents. Proteasome inhibitors, which have become the frontline therapies for multiple myeloma. The bortezomib and the carfilzomib, the clinical trial data actually showed 15 to 25% incidence of hypertension, with through various mechanisms. It could be probably direct endothelial toxicity. So these are just some newer targeted therapies or targeted agents which are being used, which have a pro-hypertensive mechanism. Just to summarize what we have done so far, we have seen a few molecular targeted therapies, the VEGF being the most important one here. It induces hypertension. It is important to recognize it early and treat appropriately. And the final downstream pathway for most of these agents is endothelial dysfunction and podocyte injury. I'm just going to briefly highlight, though it is not a drug, but I just wanted to highlight hypertension from radiation because sometimes I do see these patients coming to the clinic. But this was more of a patient whom we saw in the hospital. A 48-year-old, not a hypertensive female, underwent a total abdominal hysterectomy for adenocarcinoma of fallopian tube. Pre-op creatinine and urine analysis were fine. Post-operatively underwent radiation therapy for 8 weeks. And after 12 weeks of completion of the therapy, patient developed blood pressure rise to 190 over 120 systolic and diastolic, blurring of visions, proteinuria, and severe AKI, more so presented with a hypertensive crisis. Ultrasound did not show any obstruction. CT abdomen did not show any cancer recurrence. So what was the diagnosis here? So what we did is we quantified the proteinuria. Patient had 2.8 grams. Patient had microscopic hematuria. Hemoglobin was 7. Patient had cystocytes, low hapto, and high LDH. And for the audience here, it is a no-brainer. This probably sounds like a thrombotic microangiopathy-like picture, or probably a systemic TMA or a TTP-like picture. Fortunately, the platelet count was not too low. We went ahead boldly with a kidney biopsy, and kidney biopsy did show significant concentric, like the typical onion peel appearance of the arteriole, and thrombotic microangiopathy. And it showed severe endothelial injury, endotheliosis, which is classically described in pre-eclamptic state as well. So the similar analogy was seen here. So what we did, we aggressively managed the patient's blood pressure. Creatinine did come down with the blood pressure management in 6 weeks to 450 milligrams. The peripheral TMA did resolve. She did have some residual thrombocytopenia. But always I like to send, whenever there is a suspicion for TMA-like process, we always send for a workup for atypical HUS upfront. You never know whether these patients may have an underlying genetic predisposition, and things like radiation therapy or even Avastin or these tyrosine kinase inhibitors could act as a second hit to these patients and cause the cascade activation for the complement breakdown, causing thrombotic microangiopathy. So this was a very prototype case which we saw a year ago with radiation-induced hypertension. But when you talk about radiation and hypertension and kidney disease, it's basically a spectrum of injury which happens, which can happen as an acute radiation nephritis, which presents with severe interstitial inflammation and acute tubular injury. Hypertension can present as malignant hypertension. And it all depends on the timeline from the radiation exposure. But malignant hypertension could present even after 12 to 18 months after the radiation has been given. So it's important to understand where in timeline the radiation was given and when did the hypertension really start. Just a few considerations I'm just coming to the end of my talk. So just a few considerations in management of hypertension in patients with cancer. Beware about white coat hypertension and masked hypertension in these patients. This is a very sick population. They are extremely worried. Many of them, they don't have jobs. So white coat hypertension is a big thing. Bone and neuropathic pain, stress, these all contribute. Adjuvant therapies, important to pay attention because they are pro-hypertensive. Accurate blood pressure management is very important. Always ask the patients to monitor the blood pressure at home. And if you can get an ambulatory blood pressure monitoring, well and good. And avoid RAS inhibitors especially on the days when they are sick. I tell them to stop it for 2-3 days if they're throwing up or they are having diarrhea or feeling nauseated, just to avoid any hospitalization with AKI. What are we looking at beyond the horizon? What more needs to be done? So we need to define hypertension and its targets for this very specific population. We need more data on the cardiovascular outcomes. Most of the data has been retrospective, which I outlined previously. We need some prospective studies on that. Childhood hypertension and an adult survivorship program is very important. Actually, we have started the survivorship clinic where from the Children's Hospital, the patients get, when they graduate, they become 18 years, they get transitioned to our care. So there are very specific things which need to be seen from adult, pediatric to adult transition. Then we need to have certain consensus guidelines as to how effectively manage. We know RAS inhibitors we can use, calcium channel blockers, when to biopsy, when not to biopsy, what are the bleeding risks with these biopsies. So we need a position statement on these things as to address, just to provide everyone a rough guidance as to what to do and what not to do. These are the two institutes which are closely associated with our university, the Barrett Cancer Center, the UC Gardner Center, Neurosciences Center, which I get most of my patients from. Just to give you some resources, recently we published 2 back-to-back issues on onconephrology. We have a few authors probably sitting there in the audience, and it was very well received. It's an excellent compilation of close to 25 manuscripts, and nearly 70 plus authors really contributed to that. And let me know if you need probably not everyone does have an access to this journal in India. So if you need, just send out a message to me on Twitter, or you can take my phone number, text me. I can share all the articles to you. And what Shruti Gupta mentioned about join ASO, and a very active group. A lot of discussion happens. We have a chat group, WhatsApp chat group, where we post questions. A lot of discussions happen on them. Journal of Onconephrology, which is an upcoming journal, and which publishes peer-reviewed manuscripts specifically on onconephrology. This is just recently published, maybe 2 months ago. You can go through that scientific statement as well. And thank you so much for the patient hearing, and I'm happy to take questions and try to answer them.
Thank you, Dr. Prakash. It was an excellent talk. Excellent talk. Good to hear on such an interesting topic. Of course, not much of exposure to most of us. But then, as you said, how to define cancer-related hypertension, what are the targets are yet to be known. As you said, there's been a recent publication in the journal Hypertension by the AHA, the scientific statement, though we are yet not clear how to define hypertension secondary due to the cancer drug, and of course the targets. What we need the most important is the focus is on the oncologist referring the patients before the initiation of the therapy as to just not evaluating the creatinine alone, but then if hypertension is there, referral to us, and if proteinuria is there, referral to the nephrologist. I think that area should be strengthened. What I mean to say is a pre-initiation of the cancer therapy should be one of the areas which needs to be strengthened. And of course, during the cancer therapy, if the patient develops hypertension, proteinuria, as to how to go about it, as you said, in one of the patients, you had to stop the chemotherapeutic drugs because of the development of hypertension. Does it happen always? Is it the only way that we can overcome the severe hypertension apart from the usage of the drugs, or probably severe proteinuria sets in? Do we need to stop the drugs? when the patient is on the course of the therapy. The other area of focus needs to be post-chemotherapy, especially with the drugs such as, which are related to the platinum drugs such as cisplatin, which are known to be there in the blood for such a long time. The long-term implications of the usage of the cancer drugs with respect to just not the hypertension, but then the cardiovascular events as well. So these are the areas, if you can just put in your thoughts as well on this.
Definitely. So taking your first comment on the oncologist should involve a nephrologist beforehand and prime us. I have been struggling to convince them these things, which is extremely difficult. It took 2 years for me to convince them that, hey, I am interested in pursuing this specialty. You send me patients and we can co-manage them. So it was a very hard sell. It is getting better now. Sending it to you or a nephrologist beforehand is still going to be a hard sell for it seems. But ideally, that should be the case scenario where I mentioned about the checklist. It should be done before the therapy to risk stratify these patients. Yeah.
The other thing is during the surgery and during the chemotherapy and post chemotherapy, what should be the surveillance and all this?
So what I do is during so these patients, especially on tyrosine kinase inhibitors and Avastin, I see these patients every month. They come for infusions every 2 weeks. I see them every month with a set of labs, with a set of urine analysis and a urine protein to creatinine ratio. And there is a very low threshold for the nurses on the oncology division to call me with the surges in the blood pressure. Because what happens is the patient comes to the infusion unit while having the infusions for the targeted therapy. And invariably, the blood pressure is 160, 170 systolic while the patient is there in the hospital. So they get worried and they don't land up not giving the infusion. So sometimes more of a reassurance is very important at that point of time. Or what they do sometimes is they just randomly give a hypertensive agent, say a clonidine spot dose or 1 dose of lisinopril. So there should be some protocol. So I have advised them not to worry, given them some blood pressure targets, when to treat, when not to treat. Yes, if it is 180 systolic and above persistently during the infusion, I tell them to stop the infusion. Again, these are just opinions and there is no hard evidence to support what I'm talking about yet. Hopefully we should have some evidence for that. And this is more of during the infusion or actively being managed patient. But those patients who have finished their therapy, so I have a few patients who have really completed their therapies and the cancer is in remission. I typically follow them every 3 to 4 months if they are very significantly proteinuric, or maybe once in 6 months. But I always have my phone. I'm on hot call with any of the oncologists in my division. They just send me a message and then I try to accommodate them sooner in my clinic.
Dilip, your thoughts? Yeah.
Thank you. Dr. Prakash, thank you. Excellent talk. I have seen a couple of patients with Avastin-induced hypertension, which can often be very labile. So when they're off their chemo cycles, I've seen patients when they're on the cycle, they need 5 drugs, 5 agents to control their blood pressure. And I'm talking of patients who've never had hypertension or any kidney disease before, new onset hypertension. And when they are off the cycle, their requirement of medicines comes down. So this is a very important thought. I thought I'll take your take on this. How closely do you need to monitor them, and how do you, which drug do you take off first, and how often do you want to monitor them? Do you put them in hospital because they could suddenly go into hypotension? So how do you manage this sort of clinical scenario?
Excellent question, and a very, very practical thing which you have asked. And I do encounter these things. Fortunately, I have had a patient with a labile hypertension who is on lisinopril, spironolactone, nitrate, beta blocker. And what I usually do is I try to keep them when the blood pressure has been tanking down. So you're right. So what happens is as the drug effect goes off over 2 weeks, when they're due for their next infusion, the blood pressure starts to go down. When they get the dose, again, the blood pressure starts going up. Now, there is a lot of variation in this response. And I've spoken with my pharmacist, and they don't really have a definitive answer, because it all depends on how the cancer is responding, what's the penetration of the drug into the cancer. So the bioavailability of the drug fluctuates quite a lot. But if I were to, so what I have done in that particular patient is stop the nitrates, stop the calcium channel blocker, keep them on an MRA and the lisinopril, and then gradually add. Patients is given specific instructions to add that drug based on the home readings.
Yeah, so my advice to my patients here is that they should be monitoring at least 2 times a day at home, daily. And that I actually give them cutoffs, and I tell them omit your CCB being primarily the most powerful drug if your BP is below this, and then I keep them on a very close follow-up. Thank you.
We'll request Avin for his closing remarks. Yeah.
Yeah, a very insightful talk, Dr. Prakash. Just a thought here that I think we need to send this message to especially our oncology friends, is that hypertension is also a marker of kidney injury, and not just wait for proteinuria. And especially in the specialty where significant weight loss can happen over a period of weeks. And today we are looking at EGFR which are not weight based. So looking at a reported EGFR can be a falsely marker that everything is fine, whereas actually a person has lost a lot of muscle mass and is creatinine remaining stable. Can be an underlying progression of CKD which we don't pick up. So probably this worsening hypertension as a message that it is kidney injury and it's not our cardiology colleagues may not be happy with that it's renovascular and not cardiovascular. So, but I think that message might help a little getting a focus onto the kidneys.
Absolutely, absolutely. So in fact, a lot has been published by the cardio-oncologist in this area, but not by onco-nephrologist in this area. So we are trying to push the boundary for that.
Thank you very much, chairpersons. And thanks a lot, Prakash, for that talk.
Absolutely. My pleasure. Thank you so much.
Yeah. We
Afternoon. Thanks, Dr. Umesh Khanna, sir, for giving me an opportunity to present on this August forum. So, transplantation with abnormal bladder in 10 minutes with cases. I'll do my best. Principles of management, it's no longer a contraindication to renal transplant. So allograft outcomes of various studies nationally and internationally are similar. Slightly higher incidence of UTI, especially if the clean intermittent catheterization is not done properly. The goals of management is to ensure the safe urinary tract, address the bladder issue prior to transplant, keep them free from infections, and try to establish continence. So these are the list which all of us are aware. Where do we see bladder dysfunction? Not going into the details. So the International Continence Society has divided voiding dysfunction into the following types: overactive bladder, where there's a filling phase defect; dysfunctional voiding phase defect; underactive bladder, giggle incontinence, and detrusor sphincter dyssynergia. So basically what we should try to understand in the clinical is what we encounter as a spectrum of both. Sometimes it can be a mixture. The overactive bladder will eventually die out to be an underactive bladder. The underactive bladder has loss of bladder contractility, is seen in elderly patients and late stages of overactive bladder, whereas the overactive bladder or a hostile bladder is more dangerous, common in younger patients associated with hydronephrosis, again lead on to CKD. So as I told you, the underactive bladder or the lazy bladder. So the urodynamic shows a typical large capacity bladder with low detrusor pressures, low pressure despite high volume filling, and there is poor emptying and diminished uroflow. So how do we preserve how do you manage the underactive bladder? The upper tracts are usually preserved, so that's a big plus point for us. Basically, we need effective bladder emptying, schedule voiding, double voiding, clean intermittent self-catheterization, and you have incontinent and continent drainage. This has been emphasized by Dr. Nivedita in her lecture about clean intermittent self-catheterization. The lack of education post-transplant of the parents and the children, we have to encourage them to do it to have a long-term improvement in the graft outcome, and it should be done in the sterile technique. CISC per se has not been linked to increased incidence of UTI. It's only if done improperly with a break in the sterile precautions. So we all are quite familiar about this NEPHRO fan-off procedure, where it creates a continent low-pressure reservoir for external drainage through the skin. And normally, traditionally, the appendix is used. There have been a lot of case reports of fallopian tubes, the native ureter being used, and let's see what we used in our patients. So as I said, these are the various urinary diversion procedures which are available. Let me not go into the details as it is self-explanatory. What is dangerous, as I mentioned, is the hostile bladder, where there is bladder overactivity, impaired compliance, and there is a leak point pressure of more than 40 centimeter water, DSD, associated with secondary VUR and incomplete bladder emptying. In the urodynamic, you can see that there is an increase in the detrusor pressure and the abdominal pressure. Concomitantly, you have the EMG, or the pelvic, that is the external urethral sphincter contracting these solid arrows, and this represents DSD, detrusor sphincter dyssynergia, associated with hydrouretronephrosis. So the goals in overactive bladder is give anticholinergic medications. Botulinum injection has been tried in various case reports, and we should always consider to surgically enlarge the bladder. So how do we enlarge the bladder? As we all know, it's bladder augmentation, urinary diversion procedures. A very young child who presents after birth, we do a vesicostomy and sphincterotomy. Moving on to our experience, we have done 9 pediatric transplants in our unit from the last 6 years. 5 of them had vesico-aortic reflex and an abnormal bladder. The rest were all bilateral small kidneys with CKD with no hydronephrosis or bladder dysfunction. So this was a boy, he had posterior urethral valve, which was diagnosed antenatally with hydrouretronephrosis. There was intrauterine vesicoamniostomy was done, and there was valve fulguration, which was done 3 days later after his birth. He was lost to follow-up, and the doctors outside did not educate them, and he voided normally. But he had nocturnal enuresis till 6 years, as all parents think that this is normal, and they did not bring the child to the doctors later. At 4 years of age, someone had advised him to get an MCU done that showed an altered bladder shape with trabeculation and diverticuli with grade 4 to 5 VUR. And there was a significant post-void residue of 35 ml. Don't know why he was not advised CISC, or no corrective surgery was done, but the doctor there had given deflux gel, and then he said it will be all right. As you grow up, the reflex will go off. So there was no breakthrough UTI in this patient, but he was fully evaluated. He did have a DTPA which showed CKD, reduced functioning kidneys both sides, ultrasound, there was gross hydronephrosis on the left side with parenchymal thinning, and right kidney was also showed altered CMD. So he came to us when he was 7 years of age. He did have some mild uremic symptoms, and he was counseled for transplant. So the pre-transplant, we had evaluated him, and the urodynamic study, which showed now surprisingly a normal capacity bladder, filling pressures normal, but he had a very poor flow. So MCU was done at 7 years. Now there was no reflux, and the renal transplant was done at 7 years of age. He was 18 kg. It was a preemptive transplant. All our pediatric transplants were preemptive. We did not have a single pediatric transplant taken up for dialysis. So the father was the donor. The mother had diabetes, so the father was the donor. This patient, we decided to do the left nephrectomy to avoid risk of pyelonephritis after transplant, as it was grossly hydronephrotic. And we had decided to do a left native ureter NEPHRO fan-off. The patient had no induction was given, normal post-operative transplant course, normal renal function. Initially voided through the NEPHRO fan-off. that is he was doing CIC, then voided normally with nil PVR over the next 1 year, and he's not using the metrophenol anymore. He voids normally per urethral. So we had a midline incision in this. So post-transplant, the child never had UTI. Probably the bladder urodynamics were normal, but it was poor flow. Probably it was not a contracting bladder, but it was never it was not an overactive bladder causing upward changes or graft changes. It was an underactive bladder which required CIC temporarily. Post-transplant, uroflow was normal after 4 weeks. There was post-void residue was nil. He was on temporary clean intermittent self-catheterization and later off CIC. So the unique features in our patient was we used the native ureter mitrophenol. It's always better than the appendix because there's no new anastomosis which is needed. And we have a natural urothelium which is already there, so it becomes easy for adaptation. This patient had a midline incision and we had to anastomose the renal artery to the common iliac artery and the renal vein to the IVC. There are reports of 40 to 50% of urinary leak after using the native ureter for mitrophenol, but our patient did not have any urine leak. There are very few case reports published on the use of a native ureter mitrophenol. I'm sure other people would have had various experiences, but I could find only 1 or 2 on the PubMed. Most cases used appendix or colon as the conduit. There are rare reports of the native ureter being for mitrophenol procedure. As I mentioned, there's no new anastomosis. It can be done only if there is a bladder capacity which is normal, and if at all you have to do an abnormal overactive bladder, the bladder has to be reconstructed. So this is, we do have permission, so he was presented in the public and all, and this is how the, sorry. This was post-op day 2. He's enjoying. Doesn't seem that the surgery is done also. A very cooperative child and very happy, and at the end of 2 years after transplant, we did organize a World Kidney Day program when we felicitated our pediatric transplants. That's the father and the son. The second case is another PUV, diagnosed 2 months of birth, no antenatal diagnosis. He underwent a valve fulguration and vesicostomy in 2003, and later there was a closure of the vesicostomy after 6 months. The patient had a left cutaneous ureterostomy due to a pyonephrosis on the left side for 3 years, and then the pouch closure was done. The urodynamics was a small capacity hostile bladder. This patient did have an augmentation cystoplasty with an appendicular mitrophenol in 2006. He was voiding normally per urethral and through CISC 4 times a day and at night. He did have CKD from 2015, hypertension, recurrent urinary tract infection. The bladder had evolved. What was initially a hyperactive bladder, by the time he came to us 5 years later, was an poorly contractile bladder. So, and we had to do a transplant to him. Just before the transplant, the MCU showed no vesico-ureteric reflux, and there was significant PVR, possibly due to hypocontractile bladder. There was, this was the Euroflow recording from the urodynamic study, and it showed dysfunctional voiding. Either the patient had a lot of cough or raised intra-abdominal pressure, or he had some feature like a staccato flow or a dysfunctional voiding. So he underwent a live-related renal transplant at 15 years. Donor was his father. Mother had diabetes. Haplomatch, 3% cross-match negative, no induction. Ischemia time 1 hour 10 minutes, slightly more due to double artery. The main artery was anastomosed to the recipient internal iliac, and the accessory artery was anastomosed to the inferior epigastric artery. He received the standard triple immunosuppression, normal graft function. Initial output was more in the Foley's through the mitrophenol than the urethra. Later he voided normally, but he had multiple episodes of urinary tract infections, graft pyelonephritis, requiring antibiotics up to colistin. So he was put on antibiotic prophylaxis. We had changed mycophenolate mofetil to azathioprine. He did have, on a repeat urological evaluation, a post-void residue was 150 ml. Underactive bladder, he is on CISC 3 times a day and 1 time at night. So this is the patient. We can see the stoma on the left side and the bladder incision on the right side. Follow-up of our pediatric transplant patients, only 1 patient had a recurrent graft pyelonephritis. He was not on regular CISC after proper counseling, and he was on regular CISC and graft function became normal. All the other 5 patients are doing well. Serum creatinine settled at 1.3 after multiple episodes of pyelonephritis for the above case, but the other 2 are less than 1 with no breakthrough UTI. Thank you.
Thank you very much. Our next speaker for this session is Dr. Ajay Kher from Delhi. He's going to teach us about CNI conversion to mTOR protocol.
The question answers would be at the end of the. Otherwise, timekeeping becomes difficult as we always exceed in the question answers.
Thank you. While the slides load up, so I'll be talking about CNI conversion to mTOR. The talk says protocol, but I don't have a protocol per se, so I'm just going to talk a little bit about my experience and kind of how I think about it. So while we wait, can I get a show of hands as to how many have a standard conversion to mTORs or start de novo with mTORs here? So at 3 months or 6 months, routinely convert to mTORs. Anyone? None. Okay. None. Okay. Okay. So, what I'm going to talk about is why would you want to consider conversion to mTORs? Some benefits and pitfalls, how to convert if you are planning to convert, and then some conclusions. And as this is Mumbai, we will do it with cases. So I'll start with a 76-year-old male with a kidney transplant from February 2013. His end-stage disease was due to ANCA disease and had been treated with Cytoxan and prednisone. He also had inflammatory bowel disease with Crohn's, treated with infliximab and prednisone, and had undergone a colectomy, at which point he had been thought to be ulcerative colitis, but turned out to be Crohn's post-op, and had ileoileostomy as well. He had also had a stroke with right hemiparesis in 2005 and had aortic stenosis with a valve area of 0.95. With all his immunosuppression in the past, he had also had history of CMV, PCP, and C. diff as well. So he received an ECD expanded criteria donor in February of 2013. His donor and recipient typing is here. He had a PRA and he had gray zone DSAs to DQ7 and DQ9. He received induction with Solumedrol and Simulect. Even though he got a cadaver because of his past immunosuppression and infection history, we decided to give basiliximab. With an expanded criteria donor, he did develop delayed graft function and perinephric fluid collections. And by protocol, every 2 weeks, 1 to 2 weeks, we do biopsies till the graft function recovers. His first biopsy showed a 2A rejection for which he got steroid pulse. His second biopsy showed ATN with some hyaline arteriolopathy, which was thought to be due to tacrolimus, which is why the question of conversion from CNI to sirolimus was proposed and why we converted him to sirolimus. Post-conversion to sirolimus, a month later, he was able to come off dialysis with a creatinine of 3.7. So, these creatinines are actually off dialysis. So his creatinine came down, 3.7, 3.9, started coming down. And then in 2 to 3 months later, we had to convert him back to tacrolimus due to severe proteinuria and severe pedal edema and nephrotic syndrome. So he then was continued on prednisone, tacrolimus back with MMF, developed problems with MMF due to diarrhea, had to get converted to AZA, and also required a TAVI for his aortic stenosis. But his creatinine post conversion back to tacrolimus remained stable, and he did well. So another patient, an 18-year-old male with an ABO incompatible transplant in September of 22, with mother as a donor, ABO to B, rituximab Simulect induction, baseline creatinine of 1.27. That increased in February, so about 6 months into his transplant, to 2.8. Biopsy showed ATN with no signs of rejection, C4D was negative, and he was switched to everolimus from tacrolimus. And now, a month and a half later, creatinine has decreased to 1.6. So what are the benefits of where or how do you want to consider mTOR inhibitors? So the first and foremost is that it gives you options and alternatives. So you have something more in your armamentarium to use when you run into troubles or toxicities. So as an alternative to calcineurin, if you have delayed graft function, or you have ATN, or you have TMAs that you are due to calcineurins or toxicities, you have an option to consider as well. The data does show that when you switch someone from calcineurin to mTORs, your eGFR does go up by itself. Whether that's helpful or not, the outcomes are not great on it. In theory, we've all seen the glomerulus on calcineurin and that grape, and so there's always that anxiety of putting people on calcineurin. So sirolimus and mTOR doesn't have that. The additional advantage is that it is an anti-proliferative, so its effect on skin cancers, Kaposi and RCC, where it's used for treatment as well. And so this is a picture from NEJM about a Kaposi on the first one is Kaposi on CNI, and then the Kaposi disappears on sirolimus. So those are kind of the benefits. What are the pitfalls? So the pitfalls are that you have a drug discontinuation rate of 30%. So anyone who's done protocol conversions of CNI to mTORs, whether at 3 months or 6 months, or even those who have done de novo, 30% of your patients who you converted from CNI to mTOR will come back to CNI. And the reason may be either proteinuria, edema, wound healing, lung disease, oral ulcer, cytopenias, or diarrhea, or a combination of these. And there is, whenever you convert someone to an mTOR, all studies have shown that there is a higher rejection rate. So those are kind of the pitfalls, which is why everyone in the audience is not gung-ho about it and hasn't been doing this as well. However, if you do have to convert someone, how would you want to convert it? So there are 2 ways of conversion. One is a gradual conversion, which is what I tend to prefer, unless you are forced with a TMA to do it in an abrupt manner. So usually I'll half the CNI, and for sirolimus, I'll use the same dose. So if you're on 1 mg BD, we'll start with sirolimus 2 milligram daily. If you're on everolimus, you can do 1 mg BD, or others can kind of do a lower dose than that as well to start off. You check a level, and for toxicity as well, you'll want to monitor them. The half-life for sirolimus is 60 hours, so you want to do 8-10 day kind of levels rather than doing it too soon before the plateau has happened. If the level is at goal, then you can stop the CNI, and you will need to monitor them clinically for edema and other side effects, as well as for proteinuria, kidney function, lipids for triglycerides especially, and CBC, because if you're on sirolimus, MMF with steroids, you are at a high risk for leukopenia as well. If you are planning to switch someone in an abrupt manner, you would want to maybe consider doing a load of sirolimus at 5 or 6 milligram, and then put them on 2 to 4 milligram daily dosing to kind of convert them quickly from a CNI as well. So how do I think about it? I don't plan for any conversion because of the toxicities that we've discussed and the fact that going back and forth really doesn't do good for our patients. Converting their immunosuppression back and forth gives us more headache and doesn't help the patient. I switch only if there is toxicity or intolerance for CNI, and if there are cancers where I think a sirolimus conversion would be helpful. Do prepare the patient for the possibility of conversion, because at 30%, this is not a small percentage. And you may want to either plan ahead and start them on a statin or an ACE inhibitor or an ARB in anticipation of the proteinuria or hyperlipidemia that they may get. Monitor closely post-switch for the steady levels and ensure stable kidney function and outcomes as well. Thank you.
Thanks, Ajay. The next talk is by Dr. Vinan Bhargava from Delhi. He's going to speak to us about inexplicable graft dysfunction without rejection.
Yeah, so good afternoon, everybody. At the outset, I'd like to congratulate Dr. Umesh Khanna sir, Dr. Mayuri, and the team for getting this sorted out in such a lovely manner. It's always refreshing to be here in Goa and to be part of this august audience over here. And I can see very, very learned people sitting over here. And it gives me great pleasure to actually be on the dais here and to present with my teachers here, Dr. Ashwini Gupta, Dr. Vijay here, and many teachers here in the audience.
Because of his kind words, we have decided to give the book in which he is one of the principal editors to all the delegates who took pains to come here and be a part of this Goa conclave. So thanks all of you all, but I think
You're totally humbled, sir, by your gesture. In fact, that was, you broke the suspense. I had a suspense in my presentation today. So anyway, I'm still going to keep it. I pray to everybody that please do not just rewind your life last 1 minute and pretend that you never heard anything, okay? So before I begin, let me just tell you, I was given this talk and I didn't know what to do about it, because when I looked up this word inexplicable, I tried to find out the meaning of the word, because inexplicable, as per dictionary, is something which you can't explain, which you can't find out. Now what has happened is that when I tried to look for literature for this talk, I could figure out that it was very difficult to find out no cause for graft dysfunction. Anyway, we'll start off with saying that what is graft dysfunction actually? So it's defined as an increase in serum creatinine of at least 15% from baseline, which is often the primary indicator for biopsy in all our units. However, as you see with time, if you look at this graph over here, very clearly it mentions, when you look at the charts over there, this is an analysis of about 25 years, which shows that in the Western world, we're seeing very tremendous improvement in graft life. So you have better graft function even at short term, as well as the long term. So you have now technologies in which you can detect causes of early graft dysfunction as well as prevent early graft dysfunction. Nevertheless, when you look at our data here, you'd see over here that you have 65% functioning grafts at the end of 5 years, but the most important cause of chronic graft failure appears to be this, which is rejection. Unfortunately, we're not going to be talking about rejection, because I've been told that we keep rejection on the side, and this is going to be a kind of presentation which is going to be graft dysfunction without rejection, which is inexplicable once again. So since this is Mumbai, I'll quote Ajay here. This is a 28-year-old woman with ESRD, and she has hypoplastic kidneys, and she starts her peritoneal dialysis at the age of 11 years. She has her first transplant from a deceased donor at 14 years of age. At 19 years of age, she experiences graft loss. She goes back to peritoneal dialysis, and for some reason, she undergoes transplant nephrectomy. This was a referred patient to our center, which showed severe tubulointerstitial rejection. She's 9 years on dialysis, and then she undergoes another transplant. And this is, this time, a live, unrelated kidney transplant. She receives ATG induction and the standard maintenance immunosuppressive therapy with tacrolimus, having a target trough of 8 to 10, MMF, as well as prednisolone. So at the time of transplant, her panel reactive antibodies were 7% class 1, 21% for class 2, and the SABs were negative for donor-specific antibodies. The donor and recipient were matched at 1A locus with a shared mismatch with the first donor at A68, which was probably non-consequential. The patient was cytomegalovirus and Epstein virus immune, and her serum creatinine at 1 month post-transplant was about 1.5 milligrams per deciliter. 3 months later, she comes to us with progressive worsening of graft dysfunction, and her present creatinine is 3.2. She has no proteinuria, no sediments in the urine, and she has a well-maintained blood pressure with a trough TAC of 9.9. So what do you think have I missed or have we missed in this patient because of which this patient has graft dysfunction? I will open this, and anybody who can predict this gets a book from Dr. Umesh Khanna. Tacrolimus toxicity, acute tubular necrosis, AMR. I'm sure nobody would say AMR because we're not discussing rejection here. BK virus nephropathy, renal allograft artery stenosis. So for paucity of time, let me just go further. So what we did was, in her post-transplant course, which was complicated by worsening graft dysfunction, we ensured that the drug compliance was quite adequate. However, we just went ahead and we checked her serum BK virus, because I think that's what was probably missed in the pre-transplant workup. And she had a significant BK virus PCR load. And we confirmed it with the kidney biopsy, which showed focal inflammation, tubular epithelial cell nuclear positivity for SV40 immunostain. There was no evidence of any reaction. So we treated her with the leflunomide, replaced the mycophenolate with leflunomide, and 6 months post-transplant, we did another biopsy, and we could not demonstrate an SV positivity in the epithelial nuclear cells. At 14 months post-transplant, when the BK virus resolved, we gave her mycophenolate instead of leflunomide, and at nearly 1.5 years post-transplant, azathioprine was prescribed instead of MMF because she had severe diarrhea with MMF. At this time, she's doing well, and she has a creatinine right now of about 1.6 milligram per deciliter. So with this, I move on to another case. This is again, incidentally, another 28-year-old woman. I've kept the age the same because it's kind of intriguing when you look at the same age, the same kind of presentation, but you take the post-transplant course now over 22 to 28 months. So on routine lab testing, she's showing a gradually progressive rise in serum creatinine, and there is some amount of detectable proteinuria. And when she comes to us, she has a creatinine of 2.3. Obviously, she was not transplanted at a center. Her TAC level was 7, and her physical examination was generally normal, except that she had slightly high blood pressure. So as I commented that the urinalysis did not have any cellular elements, and also her complete blood counts, the CBC was normal. So what do you think has been missed in this patient, or what do you think over here, the audience, is there any suggestion? Oh, everybody is very, very smart here. So then everybody gets a book here. Sir, everybody gets a book here. Okay. So this is what we did. Yes, you picked up the hypertension. I made it very simple. So this is the spectral widening pattern that we got in the post-stenotic segment. And we had a high peak systolic velocity. And it has to be more than 200 centimeters per second if you have to diagnose graft renal artery stenosis. And this is one of the angiograms that we did. And now, you can get 2 books if you can pick up what is wrong with this image here and what is peculiar about this image here. Okay, 3 books. Okay, pass. So that is really funny, but this is an FMD lesion in a renal artery. So it is actually a FMD lesion in this patient. So what I wanted to tell you is that when you're looking at graft dysfunction, always look at the vascular causes. In fact, this is a study which says they tried to look at the histopathology, but what they found out on the retrograde was that most of these kidneys had some amount of infarction in the initial period of transplantation. So that means there was some kind of a vascular abnormality, or maybe some vascular stenotic problem, or even thrombosis at a very micro level, which was responsible for infarction in these kidneys. This is another paper which looked at, this is a very old paper, which looked at 105 renal transplant patients. And the reason I got it here was because they found nearly 2% of these patients had allograft renal artery thrombosis. Some of them were treated, some of them were not treated. But the fact is that this cannot be missed in the early period as graft dysfunction. So this is just a populated list. I can just go through the list because we have to do this for the sake of completion of the topic. If you're looking at the non-rejection causes of allograft dysfunction, especially in the first 1 week or less than 1 week, most important thing is to look for vascular lesions, surgical complications, especially so in patients who have multiple renal arteries, who've had newly started transplantation programs. Also look at post-ischemic acute tubular necrosis, that is in patients who have longer cold ischemia time, prior sensitization in retransplanted patients, and the kind of dialysis, if you've given excessive ultrafiltration just on the date of transplantation or just before transplantation, it could also result in acute tubular necrosis. And the quality of donor obviously is most important here. CNI toxicity in the initial period has to be looked at as one of the causes of early graft dysfunction. When you go further, that is more than 3 weeks post-transplantation, always keep possibilities of recurrent and de novo glomerular disease as well as obstructive causes, apart from viral infections such as BK virus, cytomegalovirus, or even adenoviral infections. What we see in our practice is a lot of graft pyelonephritis in patients who come to us with excessive immunosuppression, especially in the later period, because here the nephrologist is chasing the graft function by increasing the immunosuppression over a period of time. And most of our patients are already chronically immunosuppressed. Other common causes, less common causes, are retained ureteral stents. We've had patients who've come to us with 2 years of ureteral stents with recurrent episodes of UTI, pyelonephritis, and progressive graft dysfunction. So, ladies and gentlemen, to conclude, many patients that undergo kidney transplantation will ultimately experience loss of their allograft. And improving intermediate and long-term graft survival continues to be the paramount goal for the transplant community. However, in the current scenario, patients with a failing allograft often receive suboptimal chronic disease management and dialysis planning as well as poor continuity of care. Important decisions continue to be guided by low-quality data, and if we are to avoid failing our patients, it will be important for the transplant community to recognize these challenges and allocate resources to support the focused, higher-quality research that is required to improve long-term graft survival. With this, I would like to thank you, Mumbai Kidney Foundation, especially the organizers over here. And with this also, I would like to tell you that I would thank everybody here for letting me go out to the beach today. And if you can see in the middle over there, that's a dolphin there. So I've never seen a dolphin from the coast. I've gone in boats and seen dolphins, but I had the opportunity to see that. Thank you very much.
Mike.
Start with the first presentation, and I think it's very important to realize that many patients with bladder dysfunction, when they come to the nephrologist, many times nephrologists disincentivize them for transplantation, and they tell them that transplantation is not a good option for such patients. But I think it's very well presented that such patients, especially, I've been lucky that I've been working with a urologist who's been a transplant surgeon for 35 years and therefore having a urologist on board is an extremely important step in allowing these patients to get into a transplantation. And I can tell you that many patients who otherwise would have been told not to get a transplantation have done extremely well with these bladder surgeries. And I think your presentation was very, very well documented. But I think it's very important for nephrologists to involve urologists very early in their involvement for transplantation and preparation for transplantation. And if it happens that he is the transplant surgeon, then it would always be very, very helpful. And bladder, understanding of bladder physiology is also very important for the younger nephrologists, and I think this is somewhat neglected in our teaching as such in nephrology, and I think it's important that the physiology of bladder is very, very important, especially for the success of this transplant. Very well presented, I would say.
Second, I would like to comment upon Dr. Ajay Khe's talk. He has very nicely summarized in 8 minutes about the conversion from MRIs to, conversion of CNIs to mTOR inhibitors. Actually, the point is which patients and what time. Should it be converted early or late? Late, not much benefit. It should be done before 1 year, especially between 3 to 6 months. And which patients to be converted when they have optimal graft functions, they have no rejection, whether clinical or subclinical, because that you have to see, and they have low immunological risk. But if they have high immunological risk, earlier episodes of rejection, you should not try to convert. And minimization is, I think, it is better than total conversion.
Dr. Ramlingam?
Regarding the transplant in abnormal bladder, first of all, there is adequate literature in pediatrics. And as Dr. Nivedita Kamath madam already commented that the results in pediatric transplants with abnormal bladder are inferior. She showed her own data as well as international data. Secondly, about available of literature in adults, I couldn't find data more than 20 cases in most of the international articles I reviewed. The biggest data rather comes from Nadiad group. It's a 44 case report where they had transplanted either in the native bladder, which is preferred, or in a neocystostomy or bladder diversion of some kind. And this was in 2007. And they had put up that the results were equivalent to that when it's done in a normal bladder. But the results were like patient and graft survival at 5 years was 51% and 60%. I don't know. This is equivalent. I have a very limited experience with doing so. All my senior colleagues must have done it quite in a large number. My limited my limited experience of 4 transplants was a disaster. I'll tell you my truth. One patient, the patient had been detailedly evaluated with urodynamic studies, cystoscopies, MCO, consulting very senior people in this field before we went ahead hesitantly for transplant. One ended up with nephrectomy, one with recurrent pyelonephritis leading to TMA and death. Third developed osteomyelitis. The same organism was found in his knee. And the fourth one, we did an early suprapubic cystostomy. That's the only person who is alive with a functioning graft. I might be totally wrong, but this is my very limited experience. 5th patient, I said, please go to some other center.
Which is the best advice that you gave to that patient. No, and the reason, can I make a comment on that? Yeah, please. Yeah, this is important actually, and this is why I was saying that having a urologist, having a transplant surgeon, being a urologist helps in this kind of a situation. You have a urologist who might correct it, but then the transplant thing is not understood in that fashion. And I'm sure you will agree with me that if you have a urologist, a committed kind of a urologist, with that transplant in mind, then you will feel success in this patient. So otherwise, usually, it would be better to send them to a center where you have this kind of outcomes are going to be poor otherwise.
Yeah. We have had 5 patients, 4 adults and 1 young boy. All of them had near normal capacity bladders, but were not able to void properly. Now, the anatomy of the urethra was normal. So all of them are on clean intermittent catheterization. It must be nearly 10 years to 1 or 2 years now in all these patients. We have never had any major problem except occasional episodes of pyelonephritis treated. They're all doing well. As Dr. Vijay said, I think it depends on a very sort of a sensible urologist to choose and recommend the patient, and also teaching them clean intermittent catheterization and making sure that they follow this is very important, I feel. I don't think it is necessary to be skeptical about taking up patients, adult patients with lower urological abnormalities for transplantation.
Audience, anything?
Yeah, any questions, comments from anybody? Yes?
Take this.
Yeah, so I think Ajay has very nicely illustrated the current, indications for switching over to mTOR, which I totally agree. My comments are a little different. What is your thoughts on the transform trial, where they combined low-dose stack with CNI, and that showed non-inferior results regarding acute rejection and had remarkably less viral infections.
What is it? Low-dose stack with?
Low-dose CNI with mTOR inhibitor, that is everolimus, combination de novo.
There is a paper, 200 people tried.
The transform trial, that is a 2-year follow-up as well.
Yeah, and in that they've combined a dose of tacro and a dose of sirolimus in such a way they get a total 6 to 8 nanogram per ml. They add the level of the sirolimus and add the level of the tacro and get a total 6 to 8 nanogram. And they compared it with a group which is only on tacro. There was definitely more rejection, and there were a lot of dropouts from the first regimen because of various reasons which were indicated, and there was no better creatinine. So no better creatinine levels, more rejections and more dropouts. This is the study. I don't think anyone of us has large experience.
I just, Dr. Sampath here, I just want to highlight that in the last 10 years, we have had occasion to do cutaneous ureterostomy for more than 5 or 6 transplant patients. So I've had a few of them had extrophy bladder, multiple surgeries have been undergone and nothing came out of it. So bladders were very bad. So cutaneous ureterostomy, and I have never had even a single episode of pyelonephritis in these patients, and their grafts are doing extremely well. So that is another option which has not been discussed, which you can think of.
Ajay, your comments on the transplant?
So I'm a simple person, and for transplant management, I try to keep things simple for myself. The main thing in terms of immunosuppression that I think of is what are you comfortable with? What do you have most experience with? And adjusting up and down on that, you will end up doing better for your patients than trying to do something fancy which the book or a journal or someone else's experience is. Everyone here usually has the best experience with tacrolimus, MMF and steroids. Going up and down on it or removing one of them for me is a better choice than doing something with a tacrolimus with low dose sirolimus or everolimus with steroids, where I don't have enough comfort level to be able to adjust them up and down and to manage their side effects. Plus there is a theoretical possible toxicity of the two being additive, tacrolimus or CNI with mTOR. There is a theoretical additive toxicity as well. So again, though it's theory, for me the more important part is getting comfortable with whatever regimen you have and going up and down on it, and that I think is better for me.
Yeah, Vivek.
So just a general comment related to many situations which you have described. I think they're not common, they're difficult, and sometimes we struggle with those, and not all of us have experience in managing all of those. So I think a real principle is the understanding of the situation and accepting that it is difficult, number one. Number two, being humble, that we don't know what is the right way of doing this. Number three, finding out where there is an expert who knows better than any of us on how to do it. And as Sachin Soni said in the morning, that we want to do the best for the patient who is in front of us. And sometimes the best that we can do is actually to let go of that patient ourselves and send it to someone who can manage that patient better than we can do, right? That's number one. Number two is stay away and resist the desire to experiment, something that you have not done, and that goes to the point that Ajay was making. Do what you are most comfortable with, do what you have best experience with, and do for which there is best evidence available, right? So trying to do something just because one trial did it, I would really resist, unless there is real good evidence from multiple sources and you yourself have had experience or someone you know. And the last thing is never be afraid of consulting colleagues. For a number of reasons which will remain unsaid, I think there is a great reluctance on the part of patient or physicians to let go of a patient, right? I think that sometimes can be really to the detriment of good quality clinical care.
Thank you, Vivek, for that. But I would also say that everolimus or mTOR inhibitors are not the best drugs for a long-term management of these patients. They go for surgeries, you have to stop them. They have an acute sickness, you have to stop them. So there are many difficulties. A lady wants to become pregnant, you still have to stop them. So there are issues with everolimus or sirolimus on a long-term basis in these patients. Not easy drugs to use. Withdrawal rates are fairly high. 30 to 40% of my patients whom I put on either sirolimus or everolimus had to be withdrawn from these drugs. So you have to put them back on other immunosuppression. So these are difficult drugs. So go for it whenever it is needed. I use them fairly, but for a particular patient, especially cancer, I think that's a fair indication for using these drugs. Malignancies, that's where I would use it. Yes, yes. Last comment by you, and I think we should stop.
So regarding that talk on bladder dysfunction, you have emphasized on preemptive transplant. Given everything, family is ready and it is our decision, doctor's decision, whether to advise a preemptive transplant. So I find a little bit hesitancy in that, especially in children with bladder problems, because post-transplant the urine volume goes up, and if the child or the family doesn't stick to CIC, again, I mean, it becomes very difficult to manage. So what's your, message to us? We are hesitant and we are not doing that aggressively, the preemptive transplant.
Yeah, it's very difficult for the family to accept that, transplant is the only solution, because they have been told by various doctors that things will get okay, reflux will evolve over time. But the patients whom we transplanted, we had around, I think around 10 counseling sessions before, and there were other problems in between the families. We had to counsel the father separately, we had to counsel the mother separately, the grandparents, and ultimately they do agree. One thing what we did at our hospital was, whenever these patients come for a review and we have another patient, we somehow time both the patients as an outpatient, so that after we counsel them for at least half an hour, we have the patient attenders talking to the other patient's attender, and that gives them a lot of confidence, and they somehow all of them have got back. We don't know. There was only one patient who did not do the CIC properly. The rest all were very meticulous in doing the CIC. Preemptive transplant, of course, we had to lot of counseling. One patient did not agree. I forgot to mention. There was one. He had a very high urea of 180. We had to do just 1 or 2 hemodialysis for him, and then we took up. Maybe that's called preemptive or whatever. Yeah, that's all. Apart from that, routine counseling is what we used to do, ma'am, and it took a lot of time.
Would request the panelists to close the session, because we are already doubtful whether they will serve lunch to us or not.
Thank you very much. Thank you.
Thank you. Thank you very much, sir. We move on to the next session, that is a treatment of refractory anemia in CKD with the HIF-PHIs. And we have Dr. Dinesh Kullar from Delhi, who's going to join us online.
Well, thank you very much for this wonderful opportunity. Am I audible?
You are in Goa and yet you are not here inside the auditorium.
So my on one hand, sincere thanks to Dr. Umesh Khanna for this wonderful opportunity. And Dr. Khanna, please forgive me this time for letting you down because of some compelling reasons I couldn't. But I've tried to give the flavor of Goa to whosoever is watching the proceedings. I think the only mismatch is my tide doesn't probably go with the background, but my sincere apologies once again. So I am going to talk about refractory anemia and where do we stand in 2023. Well, are the slides visible and moving? Yeah. Right. So we'll begin with a case. Dr. Khanna, am I audible? Yes. Okay, great, thanks. So I'm talking about a 20 years old male, 55 kilos, diagnosed as VU reflux, secondary to posterior urethral valves, and got initiated onto hemodialysis in 2020. And sometime back, the lab parameters were not very impressive. He was complaining of symptoms of fatigue, listlessness, etc. And hemoglobin has been persistently low. At this point in time was 7 grams, and there was a history of repeated blood transfusions. He's been was put on erythropoietin, and the dose had been escalated to 6,000 units 3 times a week. And this was the iron profile, where, as you can see, the TSAT was 36%. The serum ferritin was very high and adequate B12 and folate levels. So how do we really proceed in this case? Do we need to give more iron in the face of ferritin levels, which are already very high? Should the dose of ESA be increased? As you can see, he was already receiving more than 300 units subcutaneous of erythropoietin for quite some time. Is this what is referred to as refractory anemia? And well, do we need to give more blood transfusions? Let's recapitulate. And this august audience here doesn't need any further knowledge about the role, the various pathophysiological factors going on to cause anemia. Just to recapitulate, we know there are beyond iron deficiency reasons which have foxed us over the years, especially systemic inflammation. And we have over the years realized the importance of hepcidin, which was not allowing the iron to be effective. And this is what we have realized was the main villain. Well, moving on, it's been a long journey from practically nothing to offer to these patients beyond blood transfusions. We were lucky to have the availability of intravenous iron, and then of course the game changer was erythropoietin. And I still remember when during the course of Asia Pacific Congress of Nephrology in 1992 under the stewardship of late Professor Chugh, the first erythropoietin of the country was launched way back in 1992, and improvements in the form of darbepoetin, in the form of sera. And then finally, we have recently been excited about the potential role which HIF-PHIs can play. Before moving forward, we can't ignore the role played by iron. We know that we have to differentiate between the absolute iron deficiency, where we have to focus on repletion of iron stores, from what is quite common in our patients, and that's the functional iron deficiency, which again could be related to an iron restricted erythropoiesis, which means the ferritins are there, the stores are replete, yet the iron requirement for the kind of erythropoiesis is not available, and we probably would need to maintain higher TSAT in these patients. But what is frustrating and has proved quite a big challenge for us over the years is the iron sequestration and the role played by chronic inflammation, whereby hepcidin acts to sequester iron by inhibiting the absorption of dietary iron from enterocytes or the iron efflux from hepatocytes. So thereby, even though the ferritin levels are normal or elevated, yet the patient has a perpetual problem of anemia. Is oral iron the way forward? Well, we have realized that, well, this was not, and there are, of course, the advantages of oral iron, but the iron transport and storage is dysregulated in CKD, and besides the frequent GI upsets caused by these, the absorption is not what we really aspire for, and hepcidin is certainly another problem which we always have faced and have reiterated. Well, we got excited when we realized that parenteral iron could be the way forward, and that's why we realized its importance, because it eliminates the GI absorption. There's a rapid incorporation in RBCs, and fewer administrations are required to reach the target hemoglobin. But then it typically had its disadvantages. We have improved upon the hypersensitivity reactions, and that's what has really given us the opportunity to successfully use iron sucrose, ferric carboxymaltose, and as well as iron isomaltoside recently. And we have raised the bar, and we have gone higher and higher as far as the ferritin levels are concerned. And we know this pivotal trial, that's pivotal clinical trial, where we tried to see whether we could go as high as ferritin levels of 700 micrograms per liter. And it was concluded that the high dose of IV iron, rather in the proactive arm, rather than the reactive arm, this resulted in a significantly lower risk of deaths or major known fatal cardiovascular events as compared with that observed with a reactive, a low dose regime. So we got excited, and we have, as I said, raised our bar, and we want to achieve a higher ferritin levels to give the maximum advantage to our patients receiving intravenous iron. And that's how pivotal with iron sucrose, and subsequently more and more trials with ferric carboxymaltose or with isomaltoside have shown us that intravenous iron could be the way forward. However, as I said earlier, the game changer, as we all know, was erythropoietin when it first became available to us. And over the years, we have moved on from the original erythropoietin to darbepoetin subsequently, as well as sera. And of course, a few other molecules are going to be available, hopefully, in the future times. And this is how we typically use erythropoietin or darbepoetin or sera in our patients. There are landmark clinical trials which told us that do not attempt to go or achieve very high hemoglobin levels with the help of erythropoietin, because this can give rise to high rate of thrombosis, high rate of strokes, and we can be in trouble if we try to achieve hemoglobins more than 13 grams. So that's why we have our target set between 10 and 12. But achieving that is something which we always want to go in for. But many of the times we simply fail and we are not able to achieve the kind of target hemoglobins which we typically want to. So that is when the concept of refractory anemia comes in, whereby a large ESA requirement is there, which is defined as a requirement of excessive doses during initiation of therapy or inability to achieve or maintain target hemoglobin levels despite the large dose in the iron replete patient. So first of all, you have to make sure that your patient is iron replete. There have been various definitions from the EPBG, the NKF KDOQI guidelines, or the KDIGO guidelines, but we generally believe that if you are having to use more than 300 units per kilo per week of erythropoietin subcutaneously, or more than 450 milligrams intravenously in a given patient, or in the case of darbepoetin, more than 1.5 micrograms per kilo per week, then, and to achieve a hemoglobin level between 11 and 12, you're probably dealing with a refractory anemia. And KDIGO also defines that either the initial hyperresponsiveness as having no increase in hemoglobin concentration even after first month of appropriate weight-based dosing, or an acquired hyperresponsiveness which occurs subsequently, which means that given patient requires 2 increases in ESA doses up to 50% beyond the dose at which the patient had originally been stable, should you be alerted to the possibility of refractory anemia. And there are a whole lot of causes which can actually explain, starting from the inadequate dialysis, the various hemoglobinopathies, so many other factors which are applicable to the general population, but more relevant to our dialysis patients are the things like hyperparathyroidism. But the most important, as we all would agree, is the inflammation or the role played by infection. So with that in mind, let us see whether the unmet needs in CKD anemia can appropriately be addressed by the new kid on the block, that's HIF-PHIs. We know there are problems with ESAs. There's an increased risk because of the increased viscosity, especially if you have to use very large doses of erythropoietin to achieve a given hemoglobin target. You could actually be in trouble. So with that in mind, let's see how can HIF-PHI help our patient. And before that, let's again recapitulate our knowledge of physiology. In normoxic states, as you can see, HIF-alpha is hydroxylated by chloryl hydroxylase, and finally there is a ubiquitination and proteasomal degradation by the Wall-Hempel proteins. Well, in the cases of hypoxia, the chloryl hydroxylase is inhibited. And now HIF-alpha can dimerize with HIF-beta, get translocated into the nucleus, and stimulate or activate the target genes. And in this case, we want the erythropoiesis gene to be activated. But the problem is, this is not going to be the only gene. There could be a few other unwanted genes also which may get upregulated. And that's why we have fear while using HIF-PHIs, which are going to, even in the normoxic stages, going to inhibit chloryl hydroxylase and thereby allow the HIF-alpha and HIF-beta to dimerize. So when we look at the other genes which can get upregulated, we are looking at what can happen to VEGF or the oncogenic potential of the genes, which also can get stimulated. We'll come back to that little later when we try to see the safety of HIF-PHIs. But as far as the theoretical concept is concerned, on one hand, the HIF-PHIs, they improve on the absorption of iron from intestine, both at the level of DMT1, the divalent metal transferase enzyme. At the same time, by inhibiting hepcidin, this allows the ferroportin to cause absorption. At the same time, it helps in the transport of iron to the bone marrow cells, and of course, physiological production of erythropoietin, which is what we want. And that's why we've become excited in these molecules. There have been more than one molecule, including the one from our own country, the new chemical entity in the form of decidustat, and they vary. All these molecules vary in their targets, whether it is the proryl hydroxylase domain 1, 2, 3, and also the enzyme, the metabolic enzymes involved will finally take care of the dosing schedule of these individual molecules. So daprodustat, vadadustat, and molidustat are given once daily, while roxa and decidustat are given twice a week. And as I said earlier, this depends upon the metabolizing enzymes. CYP2C8 is the primary enzyme responsible for daprodustat, roxadustat, and redustat. And while the roxadu and deci are pan-PHD inhibitors, while the other three molecules show relatively higher activity on PHD3.
Dinesh, can you hear me?
Yes, sir, I can.
So there is a request that there are a few questions which are important because of your vast experience of the use of HIF-PHI. So we have chairpersons and we would want to have a little clinical interaction with you. Is it okay?
That's perfectly fine, sir. That's perfectly fine. Can I wind up in 2 minutes?
Sure.
So I think the phase 3 studies of HIF-PHIs in the non-dialysis dependent CKD population showed that you can expect ferritin levels to go down, hepcidin levels to go down, and that's why we are so excited about these. And the summary showed that you can expect significantly higher increase in hemoglobin, and they were found to be non-inferior to ESAs. Similarly, the results were seen in the dialysis-dependent CKD population, and we had a similar kind of experience when compared to ESAs in maintaining the levels between 10 and 12 grams. And these are the various randomized trials which have shown that in these 19 published trials that they ameliorate renal anemia and rectify iron metabolism in the short term without increasing the incidence of AEs or SAEs. Now, coming back to the matter of pride for the country that an Indian company has come out with a drug which we have been able to use for a little over a year now. Decidustat, they had conducted trials in both non-dialysis as well as the dialysis-dependent study population. And in both, it was found to be non-inferior compared to the standard of care in the treatment of anemia in patients with CKD who were either not on dialysis or even when they were on dialysis. So I am cutting it short, but suffice to say that they were found to be non-inferior in all the aspects, but certainly they had a superiority when it came to reduction in the levels of hepcidin or even the cholesterol level. So that's the additional advantage of these. So whenever we set about using a drug, I think the most important thing is to keep in mind the safety. And with these also, as I said earlier, the issues were whether we are going to see more of retinopathy, or more of cancers, or more of liver disease, or more of cyst enlargement. The answer is, so far, we have not really experienced that in the various trials, but trials are trials. They're in more controlled fashion. And I always believe that the real world evidence is going to shed more light. But so far, we have no major concern while using these HIF-PHIs. The problem with roxadustat was possibly dose dependent, but I think the jury is still out. The occurrence of cardiac or kidney-related adverse events in the HIF-PHI groups were not different compared with the standard of care. So that's why these are the recommendations by the Asia Pacific Society of Nephrology, that the strategy is when replacing ESA with HIF-PHIs, you can consider HIF-PHIs as alternatives to ESA in correcting and maintaining hemoglobin levels. But of course, you have to first ensure that the iron stores are replete. So looking at the potential benefits, of course, and this is quite important. On the left-hand side, as you can see, the oral route is a big advantage. It increases or maintains hemoglobin levels effectively, increases endogenous EPO production in physiological range, regulates hepcidin, improves on the iron absorption and the transport. It inhibits HIF-PHD reversibly and transiently. That's the advantage. And of course, the additional advantage that I referred to of lowering of cholesterol and avoiding of supraphysiological or toxic levels of EPO, and one can potentially avoid intravenous iron in these patients. However, the potential concerns have been as related to malignancy, retinopathy, liver function, hyperkalemia. Well, we do come across higher incidence of hyperkalemia and metabolic acidosis to an extent, pulmonary hypertension, but majority of these issues so far have remained theoretical. But as I said earlier, real world is going to give us the actual answer. So, well, what did we do in our patient? We started him on ZYDUS 100 milligrams on alternate days. Over the next 3 months, hemoglobin has improved from 7 grams to 10.5. He's not requiring any blood transfusions any longer. The ferritin levels have come down from 1200 to 550 nanograms per ml. So to conclude my talk, anemia is widely prevalent in patients with CKD, as we all know. The current care has been addressing the iron supplementation and, of course, the ESA injections. The ESA hyperresponsiveness is a big concern in a sizable subset of the dialysis-dependent population. At least there is an unmet need with current therapy, and that is when we have recently become excited about the potential role which HIF-PHIs can play in these patients. So I'll conclude, and I'll be happy to answer whatever little I have learned from my own experience, and I'll also request the others to chip in, sharing their experience as well.
Thanks, Dinesh. May I invite the chairpersons, Dr. Sandeep Mahajan from Delhi, Dr. Anupama YJ from Shimoga, Karnataka, and Dr. Asim Thamba from Mumbai to please come on the dais and take this forward in terms of HIF-PHI and refractory anemia management.
Thank you, sir, for the wonderful talk on HIF-PFI, which is a current new drug which is available for the management of patients with anemia and CKD. For a long time, we know that iron and ESAs were the only two drugs that we were having for the management of patients with anemia, and now the new drug offers some hope, especially for patients, as you rightly pointed out, in patients with inflammation and functional iron deficiency. We can hope some new changes in the new drug may give some new hope to the patients. And I also, as you rightly pointed out, it may take some more time for the other concerns of malignancy to be in the picture, and it might take many years for this new data to come in, whether this can cause more malignancies, as we have already usually see with some of the drugs. It may take many years for the other adverse effects to set in, and as along with the new, when we start using it more and more often, then we'll see the adverse effects. So as regards how do you propose to change over from ESAs to these new drugs whenever we have problems with management of anemia in this patients?
So that's a very pertinent question, I think. Before we jump on to the conclusion that erythropoiesis, the ESAs are not working, I think we need to be fair to them as well. They have helped us in the last 3 decades. So the most important thing is whether the patient is iron replete or not. That's I think point number 1, which is extremely important. And number 2 is if there's an obvious cause of chronic inflammation. Unless you exclude that, there's no point. And we do believe that HIF PHIs will take care of hepcidin, but they are no magic. I mean, obviously, if there's ongoing loss of blood, or if the iron is still not replete, I don't think they will be able to be that effective. But yes, on one hand, having used the drug for in a number of patients over the last more than 1 year now, we're quite excited with what we have been able to achieve with the drugs. Yet, I must confess that there are problems, and there's a learning curve. There would be patients whereby the target would be achieved within no time, and that also scares you at times. In the others, it takes longer, and we are trying to figure out as to what could be the cause. That's on one hand. Then, as I said earlier, you can expect some degree of mild side effects which are easily manageable. Things like mild hyperkalemia or slight worsening of acidosis is something which the nephrologists are best positioned to take care of. But at times, I must confess that even HIF PHIs may not be able to give you the desired results. So that's something which we will need to follow. So I think our first aim at the moment is to look at the safety data. So before we really go get more excited about the drug, they must be safe. And you rightly pointed out the malignancy potential will need a number of years before we are very sure about that. And secondly, is there the scope for innovations? And by innovation, I mean not just a dose of HIF PHIs, but possibly a combination of HIF PHIs and ESAs. And that's something unexplored area. So Sandeep is smiling. Sandeep, please.
Yeah, that's what I wanted to ask Sandeep, whether your take on whether you switch over from ESAs to HIF PHI, taking out all the iron deficiencies, B12, etc. But otherwise, if somebody is not responding, do you switch over to HIF PHI, and whether you add HIF PHI to an existing ESA or not? Your take on it.
As far as the safety concerns,
Mike. Yeah, just talk inside, yeah, loud.
There has been actually no study, there is no data to have a simultaneous use of HIF PHIs with the ESA. As Dr. Kuller would say, unless we have the science behind it, we can't use it. Though theoretically, it looks a very interesting and a very promising option that you give ESA and you remove the functional iron deficiency part and the inflammation part by giving HIF PHIs. But unfortunately, none of us would have experience because that has not been tested, that has not been actually looked at clinically. The other important thing, which is especially true in our country, is the dialysis adequacy. So at times, we are so much concerned about iron, B12, folate, we forget the most important elephant in the room, and that is dialysis adequacy. So unless you dialyze these patients adequately, you won't get the hemoglobin levels up, whatever ESA doses you might use. So the first thing is to look at assess recirculation, to look at the frequency of dialysis, maybe add hemodiafiltration if hemodialysis is not working. These things do actually turn around and increase the hemoglobin. But currently, if you have to use, in my opinion, it would be either HIF or ESAs. It can't be both unless we have a scientific data on that. Dr. Kuller, what's your take on that?
Thank you so much, sir.
Yeah, certainly, Sandeep, I totally agree with you, because when I talked about innovations, and I think I basically wanted to bring up the point that even after HIF PHIs, your problems are not going to end. This is another weapon in your armamentarium. Probably you are better equipped in 2023 to manage anemia of your patients, apart from all the factors which we're already taking care of judiciously. But yes, maybe in future we will probably have to think of combining the two, but please be cognizant of the fact that we are on one hand worried about malignancies, and you could actually be getting in the trap of the same, not just malignancies, but VEGF and other things. So I think let a properly conducted trial address that issue. But so far we are excited because many a patient where we were struggling to treat the anemia of our patients, both on dialysis as well as in a small subset of non-dialysis dependent patients, HIP PHIs have proved to be a boon.
Thank you so much, sir and chairpersons. We close the session for the want of time and move on to the next session. So may I invite Dr. N.C. Ambekar, Dr. Vaibhav Keskar, Dr. Manish Mali, and Dr. Ankit Modi. And the speaker for the next session is Dr. Philip Karla, who is a professor of nephrology from the University of Manchester. And he's been a part of a lot of trials which have been conducted in the UK over the Astral and the Pivotal and the Ironman trials. And we'll hear from him his opinion about iron correction in one visit. Is it feasible?
Is there a pointer?
Yeah, pointer is here.
Does it work?
Yes, it's working.
Oh yeah, good. I'll take it. Okay.
One second.
Ready?
Continue.
Is it on? Good. Right, thank you very much indeed. Thank you very much for the introduction. It's a real pleasure to be here. I'd like to thank ZYDUS and Pharmacosmos for bringing me over to India. I'm going to just show you this picture to start with because it highlights my link to India in many ways. So on the left is my current hospital, but on the right is how it used to look about 30 years ago. And I actually grew up in a hospital grounds a bit like that because my dad was a consultant psychiatrist who came from India. He was from the Punjab. He came over after the Second World War and trained in the UK. But anyway, there's my link. That's where Kalra is from, as I'm sure you will have worked out. So this is the outline of my talk. I'm going to briefly talk about the epidemiology of anemia, safety concerns with intravenous iron, short and long term. I'll emphasize phosphate and hormonal perturbations with IV iron therapy, tell you about the rationale for high-dose iron regimes. You've heard that already from Dr. Kuller before, and give some personal experience of using monoferric as well. And if there's time, I'll just tell you very quickly about the Ironman trial, which obviously involved monoferric, that was published in The Lancet in November. So prevalence of anemia in CKD in India, you'll see to the left here, we have CKD stages 1 and 2. So clearly these patients are not anemic because of EPO deficiency with GFRs of greater than 60 mils a minute. Likely to be iron deficiency for the majority of them, but as we go through the stages of CKD, we're well aware that by the time we get to stage 5, we can see at least 50% of patients who have got anemia, and when we get onto dialysis, of course, we've got 98 to 99% of patients who are anemic, and the cause of the anemia is multifactorial, isn't it, involving inflammation, reduced EPO, iron deficiency, and of course things like advanced hyperparathyroidism. I like this particular slide because it shows that in our body typically we would have 4 grams of iron, about 1 gram of that in the liver, 1.8 grams in our circulating red cells. I'd like to point out a couple of things, though, that are really important. Number one, note that our average intake is tiny. We take about 20 milligrams of iron in orally per day, but only about 10% of that is absorbed, so we actually take 2 milligrams into the circulation. And in the person in balance, we lose 2 milligrams a day. The second thing is transferrin. It's only a small amount of iron within that, just 3 milligrams, a tiny amount in the TSAT, if you like. And finally, I just want to point out this, really importantly. Remember that there is iron in every cell of the body. It's really important in our electron transport chain for the development of ATP. And that's why you often see patients who are not anemic but iron deficient who feel so much better after having been given iron replenishment because of their energy stores. So let's talk a little bit about the safety of intravenous iron. I really think it's helpful to all of us to break this down into 3 areas. Immediate reactions, medium term and longer term. So in terms of immediate reactions, we recognize 2 main areas. There's hypersensitivity and, of course, anaphylaxis, as we heard earlier, with the modern intravenous iron products is very, very rare indeed. We're looking at maybe 1 case per 200,000 to 1 million. So it's very rare. We do see mild hypersensitivity, but more commonly we see what we call labile or non-transferrin bound ion reactions, which is associated with the fairly rapid release of free iron into the circulation. And I'll tell you more about that in a few minutes. Medium-term reactions would be hypophosphatemia. Again, I'm going to spend some time on that. In terms of longer-term problems, we talk about infection risk, and this has been borne out of the laboratory really, because there's evidence that in the Petri dish, when you bathe immune cells, T cells, and phagocytes in high concentrations of iron, they don't work as well. Phagocytes in terms of literally phagocytosing or migrating, and T cells in terms of their cytokine release and calling other cells. So there's a theoretical risk there. And what about the cardiovascular risk? Well, that comes about because of, in fact, have we missed a slide? Anyway, this comes about because of the so-called Fenton reaction, where reducing iron from ferric iron down to ferrous iron leads to hydroxyl radicals, which theoretically at least can damage vascular endothelial membranes. And if you get repeated dosing leading to repeated oxidative stress, there is the theoretical risk of cardiovascular events, atherosclerosis, of course. So this slide is 20 years old. Well, at least the data is from 20 years ago, and it purports to show that we recognize that different iron preparations are associated with different risk. In deep blue, you can see the old-fashioned high molecular weight iron dextrans, which were well known to have a high reaction rate for serious life-threatening allergy, life-threatening AEs, as you can see. Whereas to the right, we see iron sucrose that we now use a lot of in our hemodialysis patients, don't we? Which has a much lower risk. And this is data from 30 million dosings of intravenous iron collected by Glenn Chertow, published in 2006. Concerns about cardiovascular infection risk have been stimulated by studies like this. This is DOPS. You'll be familiar with this. So this stands for the Dialysis Outcome Practice Patterns. And here we compare patterns in dialysis in different countries. And so this is the European DOPS. Within this, the UK contributes, so too does Germany, France, and Italy. And you'll see to the right of this figure that patients on hemodialysis who are receiving more than 300, 400 milligrams of iron per month on average, so we're talking 5 grams plus per year, seemingly were at increased risk of cardiovascular mortality, all-cause mortality, and a signal towards infection-related mortality, causing a big worry for us, really, compared to what we would consider as a typical dosing regime, which might be 100 to 200 milligrams per month of iron. That would be the typical dosing that we see in the UK, and I'm sure it would be very, very similar here in India. And I've mentioned the Fenton reaction already and the oxidative stress. One thing to just demonstrate here is that when we're looking at iron structure, it's really, really important in considering the nature of reactions. So to the left, we see, again, the old-fashioned high molecular weight iron dextran, which had a structure with an iron core, a large iron core with a thick carbohydrate shell. Now the shell had many branch chains with the potential for causing allergy, okay? And also with this iron core, once the molecule gets into the circulation and breaks down, there can be a rapid release of iron into the circulation, hence this non-transferrin bound iron reactions. However, to the right, we see the structure of monoferric, which is more of a matrix with iron represented throughout the molecule. And so when this molecule gets into the circulation, there is a gradual release of free iron into the circulation. The other point is that the sugar chains in iron isomaltoside are very short, only about 1,000 Daltons. They are not branched, and hence the potential to cause serious allergy is also markedly reduced. And this is demonstrated in this slide here. So this is the release of non-transferrin bound iron, free iron, into the circulation. Notice that the fastest shown here is with iron sucrose in green, very rapid, and iron isomaltosode, or monoferric, has the slowest release, and it has a very low peak. In red, we see ferric carboxymaltose. I'd like to point out here that we must be aware of generic compounds of iron isomaltoside, because they're probably going to behave very similar to the iron sucrose here in terms of the release of free iron, because the structure is not the same as monoferric. Now, when we're talking about reactions, we've got to be aware, and our staff have to be aware of the likely time course. So though I've said that, you know, the risk of anaphylaxis is extremely rare, we would always need to be aware of the possibility that it could occur. And our staff need to be trained, don't they? So if someone is going to have an allergy, if they're going to have a labile iron reaction, it is likely to occur in the initial stages of the infusion, certainly in the first 10 minutes or so, or during the infusion. It's unlikely to occur afterwards. To the right, you can see what's called the Fishbane reaction, which is very common. We see this in my practice in maybe 1% to 2% of infusions. And this is not a serious reaction. It leads to flushing. It's due to, we think, non-transferrin bound iron, or maybe a pseudo-allergy. And you see flushing. The patient might complain of slight left shoulder tip pain and maybe some upper abdominal pain. The key management is to reassure the staff, reassure the patient and yourself, stop the infusion, and inevitably, in about 10 minutes, it's possible to restart the infusion at a slower rate, and the patient will be able to accept the iron. And next time that they have an infusion, you'd be able to maybe just start a bit slower, but almost always they'll be able to tolerate this. So I just wanted to show the importance of clarifying the nature of a reaction. This, believe it or not, was genuinely the first case in my hospital who received monoferric. It was one of my patients as well. She was a 35-year-old with focal segmental glomerular sclerosis. She was on EPO, and you can see the parameters there. The key point is that 5 minutes into the infusion of monoferric, she developed dyspnea, left shoulder pain, and a tiny drop in blood pressure. She was very anxious. The staff were anxious. The junior doctor was called. The infusion was stopped. She was given prednisolone. She was given chlorpheniramine. And she was sent home 2 hours later when she recovered, but she was labeled as allergic to intravenous iron. Now, if we actually attach the label allergy to someone who's had iron, then nowadays we should not give them any further iron preparation, even if it's a different iron in the future. That would be our recommendation. Just like if someone has a penicillin allergy, we would not give another form of penicillin. Anyway, I saw this patient in clinic 2 months later, went through the history, and it was pretty clear to me that this was a labile iron reaction, and we brought her back, and she has subsequently had 5 further iron infusions, and I heard actually, and safely, without any reaction, and I heard actually 2 days ago, whilst I've been in India, that she had actually had a kidney transplant after quite a long time, which is very pleasing. So we can be reassured with some data, especially RCT data, about the safety of intravenous ions. be familiar with this paper from Avni, which was published in the Mayo Clinic Proceedings about 8 years ago, where they looked at over 100 RCTs where intravenous iron was involved versus a comparator. The comparators varied from placebo, no iron, oral iron, or some unlucky patients got intramuscular iron, 155 of them. But you can see that overall, in the 21,000 patients, that it was really a null result. Sorry, just get the pointer here. You can see that the relative risk was 1 for serious adverse events in this huge study, this huge meta-analysis. You heard from the previous speaker about the pivotal trial, so I was one of the organisers of this with my colleague Ian McDougall, and this is a study conducted only in the UK, and it came about because of what we heard before, because of studies such as TREAT, which was published in 2009, 4,000 patients, all diabetic, non-dialysis CKD, and demonstrating that with high doses of EPO, trying to push higher hemoglobins, there was an increased risk of stroke and recurrent malignancy, remember that? And as a result, particularly in the United States, there's been a push with bundling to increase ferritin levels. So in the United States, you might typically see ferritins of 900 to 1,000 micrograms per litre in the patients in an attempt to reduce ESA doses. So Pivotal was born trying to actually show whether increasing the standard ferritin, which in the UK would be about 500 micrograms per litre for a hemodialysis patient, to 700, as you heard, versus the reactive level of 200 ferritin, whether this was either harmful or better for the patients. And you can see that the primary endpoint was looking at death and cardiovascular events as well. And the iron involved in Pivotal was iron sucrose, and this involved 2,200 patients, and this is the longest trial of intravenous iron anywhere in the world, with some patients having been treated for 4.5 years plus. This is the primary outcome. You'll have seen this. It was published in 2019, and you can see that using high ferritin levels of 700 micrograms per litre, this was superior to the lower dosing, as you can see. And more particularly, if we look at cardiovascular events, and remember what I said before about this theory of reactive oxygen species being released to repeated dosing with iron, particularly, for example, with iron sucrose on dialysis, we can be reassured that actually the higher ferritin levels were associated definitely with lower MI and lower hospitalization for heart failure, significantly so. And what about that infection risk? Well, again, a subsequent publication in JASON showed any infection, hospitalization for infection, death from infection, again, was null, so the hazard ratio being 1 in those patients. So, you know, with the high dose arm versus the reactive arm. So really reassuring data. So I do want to spend a little bit of time about phosphate abnormalities and hormonal perturbations with intravenous iron therapies. You'll recall that when ferric carboxymaltose, so FCM, was going for registration with the FDA, it was noted that in some of the non-CKD studies, so in patients in gynecology, there was a significant number of patients who were developing hypophosphatemia, so phosphate levels of less than 2 milligrams per DL. And in 2009, in a very tiny study, as you can see, of just 8 patients, it was purported that maybe FGF23 was one of the precipitants of this problem. More of that in a second. So as a result, over the years, there's been 2 studies called PHOSPHARE IDA, IDA standing for iron deficiency anemia, and many of you will know of Miles Wolfe, who is based in Duke, North Carolina, who's really probably one of the leading experts on FGF23 in the world. But anyway, in the PHOSPHARE IDA trials, ferric carboxymaltose was compared with iron isomaltoside or monoferric, and you can see the data here. If we look to the left, at any time post-infusion, 74% of patients receiving ferric carboxymaltose had a phosphate of less than 2 milligrams per DL, but it was only 8% in patients receiving monoferric. And you can see the time course. So this peaked at day 14 and continued with serious hypophosphatemia out to beyond 5 weeks in many of the patients, as you can see. Also, notice that about 11 patients got serious, very serious hypophosphatemia with ferric carboxymaltose of less than 1 milligram per DL, which is, you know, very worrying. Now, how does this come about? Well, it's recognized that FGF23, which is a hormone, of course, that we release from osteocytes in bone and which primarily functions in our body to prevent the reabsorption of phosphate, and hence we don't typically see hyperphosphatemia in CKD until we get down to GFRs in the low 20s, do we? And that's because of the effects of increasing levels of FGF23 as CKD progresses. But unfortunately, FGF23 has other interactions. Not only does it drive phosphate excretion, but it also inhibits the production of activated vitamin D. So 1,25-hydroxy dihydroxy vitamin D being converted from 25-hydroxy D. That leads to hypocalcemia, and also that's a strong stimulus for secondary hyperparathyroidism. And you can see to the top right here, serious hypophosphatemia can be associated with weakness, fatigue, and in extreme cases, respiratory depression. And in people who get repeated hypophosphatemic episodes, typically in GI, then we are at risk of seeing osteomalacia. So looking at the hormone changes, we can see that intact FGF23 increases with ferric carboxymaltose, but not with monoferric. We can see that there's an increased phosphate excretion and a reduced serum phosphate, all demonstrated here. But in addition, reduced vitamin D, reduced ionized calcium, and also increased PTH, which persists for several weeks. And is this a worry for kidney patients? Big question. We, of course, are used to dealing with patients with hyperphosphatemia. Well, there's data from the US RDS. You might be familiar with this. I know it's 15 years old. This is looking at FGF23 in the US dialysis population and dividing them into quartiles according to their level of FGF23. And you can see that the patients with the highest quartiles had something like 6 times the increased risk of mortality compared to those in the lowest quartile. And some very neat lab work in mice has shown also why we might be concerned in terms of cardiovascular risk. And just if you look along the middle here, these are mice hearts in cross-section. These are the mice that have had vehicle introduced into the heart with no increase in hypertrophy at 7 and 14 days. These had FGF23 injected, and there's marked hypertrophy as soon as 7 days. And also a study from the CRIC, you probably know, the chronic renal insufficiency cohort in the United States, took 1,000 patients, looked at their echocardiographic LVH, and showed that LVH co-associated with higher levels of FGF23 as well. So there is a point there about concerns with this.
So can we request you, sir, to give us some concluding remarks so that we end on time?
You'd like me to finish?
Summarize, yeah.
Okay, right, I'll go to this slide then. Okay, so why would we want to choose monoferric instead of other intravenous ions? A few really, this is the concluding points really. First of all, there are several generic iron isomaltoside preparations available in the Indian market. There's a high likelihood of reactions with these, particularly the free iron reactions, because of the limited quality assurance governance. Now, with monoferric, you can be sure it's a high quality product. There's a minimal risk of serious hypophosphatemia with this, and even though there are limited concerns regarding phosphate in our CKD patients, hyperphosphatemia, FGF23 may well be one of the factors that leads to increased cardiovascular toxicity in our patients. We know that patients on dialysis, for example, have a very, very high rate of cardiovascular mortality. We've seen from the registration trials, so the FAIR-1 trials in the United States, that the drug is safe, monoferric is safe compared to iron sucrose, and importantly, there's no upper limit on dose. You can use 20 milligrams per kilogram, so that means if you've got a 100 kilogram patient, they can have 2 grams in sort of 60 minutes, basically. You're allowed to do that. So it's a perfect drug for use in non-dialysis CKD, in kidney transplants, in peritoneal dialysis transplants, where you can give all the iron that the patient will need in 9 to 12 months in one dose, in 1 hour, and saving staff resources. And it might also be something to consider in your hemodialysis patients. You could actually, and we do this with our home dialysis population, we bring them in, we give them a total dose infusion in one dialysis session at the hospital, and then that gives them enough iron for the next 6 months plus, and we don't have to worry about the risks of dosing iron at home. So really, if you'd like me to stop there, I'm very happy to.
So we have chairpersons who would want to give their comments, and if there are any questions, and then we promise to break for lunch immediately after this session and assemble again at 2:30, so that we leave the conference at 5 p.m. as was planned, so that there is no delay in the overall conduction of the conference. Yeah, comments from the chair.
At the outset, on behalf of all the chairmen, I would like to thank Mumbai Kidney Foundation and Umesh Khanna for coming, for inviting all of us here. Cheers to Dr. Professor Philip Kalra, and welcome back to India. My comments are only 3. One is that, will you give any iron preparation at night to any patient who's in the hospital? And second is, has anyone gone above 1 gram? Have you tried to give 1,500 milligram as an infusion? And third comment, I would like to know from the audience also, that unfortunately neither ferric carboxymaltose or iron isomaltose is available in government hospitals where I work. So it's only the iron sucrose that is available. So that's a little bit of a problem for us.
I think,
so third question, I think they will answer.
Third question for the audience. Yes, I get that. So basically, the second question, the answer is absolutely. We typically give always 20 milligrams per kilogram, and we've dosed many patients to 2 grams or more. We've got some big people in the UK, so that's 100 kilograms plus. Typically we're giving doses of 1.5 grams in 45 minutes with monoferric. We are. Okay. In terms of the first question, that was at nighttime dosing of iron. We do have 3 dialysis shifts typically in my hospital, and the evening shift starts around about 7 o'clock. So they will be getting the iron in the last hour of dialysis, just as they're coming off. They would typically get iron sucrose, but they get it at that time. So it could be 11 o'clock at night, which we will have finished the meeting, by the way, before then. Right.
Yeah, one question about the dilution and the infusion time. It is said that if we infuse it as a bolus or as a fast infusion, 20-30 minutes, then the chances of free iron toxicity are less. So,
okay. So no, that's a really good point. So this is true of, I would think, of the generic irons, definitely. I think with monoferric, 2 things really. Firstly, the volume that it should be mixed up in should be kept reduced. So typically we use 100 mils of saline for maybe a gram. You can go up to 500 mils, but no more. Believe it or not, the more dilute the solution, the more chance there is of instability of the iron and greater release of free iron, believe it or not, in that. So, but in terms of speed, the fastest we would ever give a gram is 30 minutes. It's safe at that level, and that with monoferric it shouldn't provoke too many free ion reactions. Thank you.
Thank you for your talk, Dr. Philip. My question is, I'm always hesitant to give IV iron in a patient with an acute infection.
Yes.
Particularly serious infections, life-threatening infections. What is your approach in giving
No, absolutely. So though I've showed you the data, particularly from Pivotal, that, that we saw no signal of worries with infections there, what we would never do is recommend giving an infusion with a patient who, say, is in hospital with an active pneumonia or, say, cellulitis, osteomyelitis, something like this, active TB. I mean, it's just not the right time to give it, is it, at all? So we would avoid it at that time, give it at a later stage when the patient is better.
You showed us the data about phosphate handling, comparison between FCM and isomaltoside. Were all those patients having some form of CKD, or there was?
No, thank you very much indeed. Sorry. So I was speeding up at that point. So that was that was phospher-IDA, so it was iron deficiency anemia of other causes. So it was gastroenterology and gynecology, basically. I think that's the same study has not really been done in CKD.
So is there any experience, published or unpublished, with patients who are on dialysis or have some grade of chronic kidney disease?
There certainly is with monoferric. I was going to just champion India here because two studies. One I was the lead on. Progress was undertaken here. That was a non-dialysis CKD study, but there was also the proposed study, again involving Indian patients. My colleague Sunil Bandari was the first author, where we were testing monoferric in hemodialysis patients as well. So, it's well tolerated in dialysis. But in terms of, are you asking a comparison with ferric carboxymaltose in terms of phosphate?
So do you expect similar degree of hypophosphatemia or rise in FGF23 in patients with renal insufficiency?
So we not hypophosphatemia. I don't think we would be worried about our patients going to the ITU with phosphates of 1 milligram per DL in our CKD population, but it's this theoretical concern that we're pushing up the FGF23. It undoubtedly is one of the multifactorial problems leading to the cardiovascular disease. I've not seen any data from dialysis patients, though, to be fair.
Thank you, Dr. Philip, and thank you, chairpersons. I think we break for lunch and come back at 2:30 sharp. The audience has been brilliant in coming to the audience, to the hall on time, and we expect that the same thing continues. This will ensure that we finish the conference at 5 p.m. as promised. Thank you. still difficult to be inside the auditorium trying to listen to whatever is the deliberation of this NEPHRO conclave. But may I request all of you all to take your seats so that we could start the session and, as promised, finish it on time. Dr. Mayuri, it will be your duty to start the session.
Okay. We'll start. We'll invite for this session on the chairpersons first, Dr. Shri Bhushan Raju, Dr. Abhay Hupikar, Dr. D.S. Baraduria, and Dr. Baduria, sorry, and Dr. Ranjani Muthu. And the topic is managing amyloidosis by Dr. Isha Kaul.
So Dr. Isha Kaul will join us online. Good afternoon, Isha. You could start your presentation. Although this topic was discussed in the morning to a small extent, but I think Dr. Isha Kaul is going to take it in the next 20 minutes. 10 minutes. No.
15 minutes.
15 minutes, sorry.
Dr. Isha, you can start if you can hear us.
Call kar. The symposium is on paraproteinurias and we have 3 speakers. Not audible yet. Shri Bhushan, you can just initiate the discussion.
Yeah, hello, good afternoon everyone. After this post-lunch session, I know that this is a respectable number after post-lunch also still, we can start off. And this is the symposium totally dedicated to paraproteinemias. And the first topic will be with Dr. Isha Kaul, the Associate Director in Hematology Oncology Bone Marrow Transplant at Max Hospital, Vaishali. She'll be talking about amyloidosis diagnosis and treatment, the disease-modifying drugs to antifibril therapy. And Dr. Isha Kaul, please. Dr. Isha.
Good afternoon. Am I audible?
Yes.
Yes, please go ahead, please.
So a very good afternoon to everyone and thank you for this invitation to participate in this very wonderful program, and wonderful to see an entire session dedicated to paraproteinemias, which is a very, very important and now more recognized cause of renal failure. And as part of this session, my brief was to talk about amyloidosis, and that's what I'm going to do. And I'm going to talk about the diagnostic and therapeutic challenges in amyloidosis. Can everybody see my screens? Yeah, I think it's okay. So we are just going to talk a little bit about the subtypes and pathophysiology of amyloidosis, just a recap. A few updates on diagnostics. I'm just going to talk about one interesting case, just as some teaching points and some take-home points, and an update on the therapeutic options. So as we all know, amyloidosis is a relatively rare but probably underdiagnosed disorder. It is debilitating and if not managed properly, often fatal illness. Unfortunately, there are no specific symptoms of amyloidosis and it can present in a variety of forms. Nephrotic syndrome, heart failure, arrhythmias, neuropathy, all these are possible, symptoms of amyloidosis. So to broadly understand what is common to all different kinds of amyloidosis, it's a disorder of protein misfolding. There is some precursor protein, which can be transthyretin, it can be immunoglobulin light chains in case of AL amyloidosis, it can be ATTR in certain hereditary disorders and subtypes of amyloidosis. But what is common is that there is a precursor protein, and because of misfolding, the amyloid fibrils are formed and they get deposited into organs. And these fibrils are extremely toxic and cause organ dysfunction in whatever organ they are involved in. At one point of time, the broad definition was primary and secondary amyloidosis. Now we know that over 50 kinds of amyloids have been described, but still the most common, I think, for this audience is the AL kind of amyloidosis, which is often the most sinister form, also known as primary amyloidosis, AAs, or what is commonly called secondary amyloidosis, which can be associated with chronic inflammatory conditions, and chronic hemodialysis associated amyloidosis, in which the precursor protein is the beta-2 microglobulin. And then, a few other smaller ones. Transthyretin, not such a big issue in India, but in Europe, it's a bigger problem. So for AL amyloidosis, the commonest organ that is involved is the kidney. Around 46% patients will have renal involvement. Heart is a second one. 30% people will have cardiac involvement at presentation. And then a few will have liver, GI, peripheral nervous system, and soft tissue involvement. In certain hereditary forms, neuropathy is the dominant form. And in transthyretin, cardiac is the dominant form, and it often spares the kidneys. So the diagnostic, the way we can suspect amyloidosis, in a number of cases, but the only way to be absolutely sure is to have a biopsy and to demonstrate amyloid deposition on biopsy. And it is the yield is highest if the biopsy is done of the involved organ. That is where, so if you are suspecting renal amyloidosis, then a renal biopsy is the one that is going to give you the best chance of getting the response. But in some situations, it is not possible, or it is too high risk to do the biopsy of the involved organ. For example, in cardiac amyloidosis, doing an endomyocardial biopsy can be logistically challenging and also involve significant risks. So, for practical purposes, sometimes surrogate sites can also be used. The most common surrogate site is a fat pad, either an aspirate, just a fat aspirate of abdominal fat pad aspirate, or biopsy can, studies have shown sensitivity anywhere between 50 to 80%. And I think this very, easy to do methodology is grossly underutilized in amyloidosis. I think if more people, plasma cell disorder treating people get just comfortable with doing it, and their labs get comfortable with analyzing it, this is a very low cost, low risk intervention, thing which can support or negate the diagnosis of amyloidosis. And it's been shown that if you do biopsies from two sites, fat pad and bone marrow, it is 80% sensitivity. So if you are suspecting amyloidosis and you cannot demonstrate deposition of amyloid either by fat pad as well as by bone marrow, then the chances that it is actually amyloid or systemic amyloid become less. So, in situations where heart involvement is suspected, or for some reason kidney biopsy cannot be done, if you're able to do both, you can still pick up and confirm amyloidosis. But it's very, very important that it is sent to the correct lab, or the lab over time develops the experience of processing these samples. How the fat is processed, the amount can be very little sometimes. The technique of Congo red staining, these are very basic, but I have seen that, these things being missed if the eye is not trained to see these things. So, any organization or group which is seeing this, I think if they, develop the skills of seeing Congo red more, you will start picking up more amyloids potentially. In addition to Congo red staining, immunohistochemistry can sometimes be helpful for, there are antibodies which are available against ATTR and AA. And we are seeing in reports, that pathologists are using these antibodies and adding to the diagnosis of amyloidosis. Electron microscopy sometimes comes in handy. Very early amyloid can be a little bit difficult to distinguish, and what makes it NGRS versus what makes it amyloid. So in these situations, the demonstration of microfibrils on EM can also be useful. The most sophisticated way of knowing for sure what the amyloid subtype is actually to doing proteomics. But in order to do proteomics, you have to dissect the amyloid fibril very, very accurately from the tissue, and it can only be done by laser capture microdissection. There are labs worldwide, amyloid specialized labs, which do this technique, and they've worked on it and they've, got it right. In India, it's not quite ready for prime time. I think a few places are sort of doing these things at a research level, but we have sometimes had to, in situations where the conflict on the subtype of amyloid can come in handy. But beyond, the problem I think is actually getting down to, the monoclonal gammopathy part of it. We know various tests that can be used, all the alphabet soup, SPE, UPEP, IFE, serum free light chain assay, and we get all of these. But how to do it in a reliable fashion and how to interpret. Again, we have to remember what it is that we are trying to do. What is common to MGRS and amyloidosis, AL amyloidosis, is that there is some clonal basis, there is some cellular clonal basis, there is a clonal protein, and there is end organ damage. And connecting these dots of what is the cellular problem, what is the clonal protein, and what is the end organ damage is where the diagnostic challenge lies. And it becomes even more tricky in the situation where patients have chronic kidney disease, because light chains are excreted by the kidney, and whenever there is a drop in the GFR, the kappa and lambda light chains do not necessarily change in the same proportion, because one of them is a monomer, the other is a dimer. So the clearance of the free light chains from a normal kidney versus that of a CKD kidney is different. So, the parameters for defining abnormal ratios in CKD are different. It can be tricky in two situations where a polyclonal population of light chains can look clonal because the kappa looks like it is higher, whereas it's not clonal. And the second problem is that there can be an abnormal lambda which hides and it looks like the ratio is normal, but it's actually a clonal protein, but the ratios and the proportions have been distorted because of chronic kidney disease. So coming to the imaging part of it, it can provide good supportive evidence. There are radioisotopes which are specifically designed for amyloid, but currently not available in India. Echocardiograms done in trained hands can be very, very helpful. We should not just be looking at ejection fractions, but more. Cardiac MRI and cardiac PET is being deployed more and more. And there are certain specific isotopes which are not yet available in India, but cardiac MRI is available and can be utilized when cardiac amyloidosis is suspected. Just to take you through a case, so there was a 60-year-old female presents with diabetes, 15-year duration. And this is a very common scenario with 30% of our country being diabetic, that, diabetic nephropathy or diabetic anything becomes a possible diagnosis for any problem. So she presents with new onset pedal edema. She's been treated with furosemide, but the edema persists. She's evaluated for the edema, and she's found to have a significant proteinuria, an 8-gram proteinuria, and an albumin of 2.4. So she has a nephrotic-like picture. And the question is, how do you proceed? So is this diabetic nephropathy or is this something else? So the key here is that this patient did not have any retinopathy. And there was a urine analysis that was done 2 years ago in the context of a cholecystectomy, which was completely normal. So it is, unusual for diabetes to go, with no eye involvement, no retina involvement, yet have advanced, nephrotic range proteinuria, and to grow from absolutely 0 proteinuria to 8-gram proteinuria within 2 years. So there are certain, small clues which can help and tell us that this is not your average diabetic nephropathy and something is off. So now we do, a typical myeloma profile for this patient. And this is a combination of, serum protein electrophoresis, and you can see the light chains here. So the bands here are generally not big. Remember, in amyloidosis, you don't have to have very large amounts of abnormal M protein or large amounts of light chain to cause toxicity. That is something more typical of myeloma. In amyloidosis, the clone size is generally small, but there is something wrong with the clone, that it is amyloidogenic because of the protein misfolding of the light chains. So here we are seeing, a very small IgG lambda band. But if you go down and look at just the light chain ratio, it will look like the light chain ratio is normal. This is because, the patient has some degree of CKD, but the lambda is actually approaching kappa. So, if you interpret it in totality, even though the ratio is normal, this patient most likely has an abnormal lambda clone, which is hiding within normal values. So, all of these investigations have to be interpreted in context, especially in cases of MGRS and amyloidosis, where the magnitude or amount of protein can be very, very small. So it can hide within normal values also at times. Now, if we just look at, the interpretation of echocardiography, this patient underwent an echocardiography. These are two, echo reports from two different patients. If you just look at the ejection fraction, both these patients are showing an ejection fraction of 60%. Both these patients were diagnosed, biopsy-proven amyloidosis. But if you look a little bit beyond EF, the interventricular septal thickness is 20 millimeter in one and 13 in the other. So this completely changes the cardiac staging of the amyloidosis and completely changes the prognosis. Obviously, the patient with even with the preserved ejection fraction, but very advanced cardiac amyloid, did not survive the initial hospitalization, where the second patient is alive even 4 years after his initial presentation. So very important to look at that. Now, coming to treatment, the goal of treatment in amyloidosis is twofold. You want to deploy therapies which can decrease further deposition of the abnormal amyloid in the organs. In some cases of ATTR, stabilization of transthyretin, and then related complications, nephrotic arrhythmia, heart failure, to treat those. And this can be tricky because the general principles of treating nephrotic or arrhythmia sometimes do not apply. For example, in patients with amyloid-related proteinuria who also have cardiac involvement, a lot of times they will not tolerate ACE inhibitors or ARBs. They will have orthostatic hypotension, and the mechanism of their proteinuria is different. So the ACE inhibitors may not be as helpful as in a typical diabetic nephropathy. So that has to be recognized because they can be exquisitely sensitive. So bortezomib has been a backbone treatment option for AL amyloidosis for a long time. It is cheap, generics are available, subcutaneous administration can be done on an outpatient basis. And good thing is that renal dose modifications are not required. So we end up using this as the workhorse for treatment of AL amyloidosis with renal involvement. Lenalidomide is an active plasma cell, directed therapy, but it's a little bit challenging because it has a lot of hypersensitivity, and sometimes we can have a component of interstitial nephritis from lenalidomide, which makes the organ response a little tricky to interpret, and it requires significant dose modifications when GFR is reduced. So even though it's very widely used in myeloma, we tend to not use it as much in amyloidosis. So that is where there is a difference. Carfilzomib again has some kidney issues, because of which the enthusiasm for using it in amyloid patients is less. The only drug which is actually approved for amyloidosis, everything else has been a copycat from myeloma, because there were no dedicated studies for amyloid. But daratumumab, which is an anti-CD38 antibody, there was a large study, the Andromeda study, which was directed only for amyloidosis patients, which compared Cybody, which is a standard backbone comprising of endoxin, bortezomib, and dexamethasone, versus Cybody in combination with daratumumab in patients with AL amyloidosis. And it showed improvement, almost doubling of both the hematological response, and because the hematological response came fast, the organ responses were also better, because you are, eliminating the toxic clone very, very quickly. So more and more for patients who can afford, we are advising them to incorporate daratumumab upfront. Other than AL, where plasma cell-directed therapy for AA, we all know treatment of underlying disorder, sometimes tocilizumab can be deployed, and sometimes organ transplant. And ATTR, the hereditary forms liver transplant, is the treatment of choice. There are certain investigational agents, antifibril monoclonal antibodies, which can degrade preformed amyloid fibrils. These are all in research right now. And there are other investigational approaches such as RNA silencing. Gene editing is being tested for ATTR. Nano antibodies, the Alzheimer's variety of amyloid is being tested. Immunotherapy, I talked about a little bit. Doxycycline has shown some role in perhaps disrupting amyloid fibrils of any form. And, when we have nothing else and we have nothing to lose, sometimes with whatever we are giving, we add a lot of doxycycline, for some anti-myeloid or disruption of fibril activity. So to conclude, high index of suspicion is required for timely diagnosis. The prognosis is very, significantly depends on the cardiac staging upfront. Correct interpretation of serological tests done for amyloid is very important. It can be tricky because of the small size of the clone. Abdominal fat pad is very easy, and I think it's underutilized, and we can use it more frequently. Accurate subtyping, best effort should be made to subtype the amyloid accurately. Because sometimes patients can just have an isolated bystander clone and that may not be the actual amyloid type in their organ. And the treatment, both the protein-directed therapy in case of AL amyloidosis and anti-plasma cell therapy and good supportive care are equally important for best outcomes. So with that, I'll conclude and thank you for your attention. I hand it back to the chairpersons.
Thanks, Isha. And if there are any questions.
Congrats, ma'am, for that good talk. I have one question. Just wanted to ask, I think, have you referred any patient who got clinical remission because of the hematological remission, but renal involvement with creatinine of around 5 or 6 end-stage renal disease? Have you referred or given clearance for renal transplant to the concomitant or to the nephrologist when the patient has been asked to go for transplant?
So this question is relatively easy to answer in amyloid. I think the challenge is more in cases of myeloma. But in amyloid, if you're confident that you can control the underlying plasma cell clone, then our threshold for giving clearance for amyloidosis is very, very high. So a lot of times patients, for example, who are in deep remission, they're serologically in deep remission, they can have, remissions of up to 5 years, 10 years. So it really depends on whether your underlying disease is under control. If it is under control, sure. Patients who've undergone an autologous stem cell transplant, they are sometimes nearly cured of amyloidosis. They can have 10, 15-year remissions, which is operationally a cure. So it absolutely makes sense for them to also undergo a kidney transplant. Patients have undergone cardiac transplants also with amyloidosis. So I think in amyloid, as long as your underlying disease is under control, which is the longevity of the remission can be very, very long. It's easy for amyloid to give clearance. The challenge is more with myeloma, where sometimes the disease can come back within a couple of years, and then the question becomes a little tricky.
Thanks, Isha. So we will now, for the want of time, we'll go on to the next talk. That is Professor Dr. N. Gopalakrishnan, who would speak on MGRS.
Before he comes up, so out of curiosity, we have done abdominal fat pad aspiration for a few patients, a significant number of patients, and we did not find a single patient being positive. Maybe the site which we choose us may be wrong, actually. I don't know, maybe the methodology also may be wrong. But as you said clearly, that the person should be, doing the procedure must be knowing how to do, and how to stain also is very important. Yes, out of curiosity, we have done. Sir, Dr. Gopalakrishnan, sir, please.
Very good afternoon. Thanks very much for the organizing team, Professor Umesh Khanna and Professor Mayuri Trivedi, and a whole lot of organizing team. The topic for discussion is MGRS, monoclonal gammopathy of renal significance. A vague topic, sometimes difficult to understand, and very heterogeneous in nature, in all aspects, pathogenesis, pathology, or understanding the pathogenetic process, and very vague therapeutic options. And it is very easy to misdiagnose, as well as miss the diagnosis. Yeah. So this is the definition that has been given for MGRS. A group of disorders, heterogeneous disorders, where there is renal dysfunction, evidence for kidney dysfunction, secondary to the production of monoclonal immunoglobulin by a clone of B cell or plasma cell, which have not assumed the characteristics of being a malignancy. So this is the consensus of the International Kidney and Monoclonal Gammopathy Research Group in 2017. They emphasize that the underlying B cell or plasma cell clones do not cause tumor complications or do not meet any current hematology criteria for specific treatment. So this is the definition. So you need to have an understanding of these three categories, the terminology. On the one side, the frank paraproteinemia, that is like, for instance, a myeloma. There is no doubt about the diagnosis. We have the CRAP criteria in the plasma cells, more than 10% in the bone marrow, and so on. On the other side, there is evidence for the presence of a clone of B cell or a plasma cell, but there is no organ dysfunction. It pretends as if it is just benign, so it does not warrant any therapy. That we call it as MGUS, of unknown significance. In between these two is this MGRS, where there is a clone of B cell or a clone of plasma cell that is producing an immunoglobulin, and that is toxic to the kidney. There is evidence pathologically for that. So this is the understanding. A quick run through of the MGRS associated kidney lesions. It's a nice classification published in one of the articles in KI. On the one side, the organized deposits or inclusions. So there is a toxicity of this, the monoclonal protein, right? On the other side, non-organized deposits. The organized deposits are fibrils. The pathology will be like IgG-related amyloid, just now we heard, or it can be microtubules. The classical example is your immunotactoid glomerulonephritis and type 1 cryoglobulinemia here, and the crystals, the light chain proximal tubulopathy, and the crystal storing histiocytosis. On the other side, the non-organized deposits of the protein, the LCDD, low chain, LCDD and long and heavy chain deposition disease and heavy chain deposition disease and so on. Here comes one very interesting, another vague entity, that is a PGN-MID, the proliferative gene with monoclonal immunoglobulin deposits. And of course, the current interest is that C3 glomerulopathy. Whenever we do come across a C3 glomerulopathy, we need to think there can be an underlying paraproteinemia. We'll discuss about that later. So this is a beautiful picture of whatever I have said, beautifully depicted the different parts of the nephron, particularly the glomerulus and the tubule, describing the pathology. The one more pathology that has not been included in the previous slide, the thrombotic microangiopathy. As you can see here, some of these paraproteinemias or even MGRS can induce a thrombotic microangiopathy, that is it. About 10 years ago, when we came to know that immunoglobulins, apart from causing kidney injury by direct toxicity and by other mechanisms, like inducing proliferation of the cells or activation of the complement, all those things are there. But we never knew that it can undergo crystallization, because in the crystals and kidney, we have very specific causes and etiologies, like drugs and certain substances and so on. By specific pathophysiological mechanisms, in some people, it undergoes a crystallization, and that by itself causes a couple of pathologies. The crystal storing histiocytosis, crystal globulin nephropathy, and the crystal-induced proximal tubulopathy. So this is the plethora of kidney pathology. So this picture nicely describes the pathophysiology of each pathology associated with MGRS, right? So why crystallization happens? As you can see here, light chain proximal tubulopathy. What happens is that these light chains, some of them, they have some mutation in them, certain components of it, that makes these mutations make them resistant to proteolysis. So that gets stored up within the tubules, undergo crystallization. So like that, for each pathology, for each entity, there is a pathophysiology here. Look at the down, that is PGN-MID. There is entrapment of the monoclonal protein in the glomeruli that causes complement activation, and that results in proliferative pathology. These paraproteinemias, they cause kidney injury not just by these pathophysiological mechanisms, Look at on the right-hand side, a host of drugs which are being used in treatment of paraproteinemias as well as MGRS. Each one of them have their own renal syndrome. That is entirely different topic. So the renal lesions associated with MGRS doesn't stop with the disease process per se. Also treatment-related issues also can happen. So how to go about? Whenever you come across a kidney biopsy, where you detect a light chain restriction or a heavy chain restriction, you start suspecting a monoclonal gammopathy. What is the next step? Next step is that serum and urine monoclonal studies like protein electrophoresis and immunofixation, that is superior, and free light chain assay. And subsequently, you are supposed to confirm, you have to go for bone marrow aspirate and biopsy also in certain situations. In situation, if bone marrow is negative and there is a high index of suspicion of lymphoma, then you have to go for lymph node biopsy. On the other hand, if your kidney biopsy reveals a C3 dominance, you have to go for further workup for C3 glomerulopathy. So this is our experience. It is not just MGRS, it's a total experience of paraproteinemias published in international reports, Madras Medical College, the host of pathologies. As you can see here, we had 19 MGRS. The pathologies associated with MGRS were light chain deposition disease, that tops the list with 7. And this mortality analysis is not, it's overall, I mean, both MGRS as well as myeloma related. It is not a study confined to MGRS alone. Let me go through a case vignette, which we recently treated a couple of months ago. A 45-year-old gentleman, a known hypertensive, he was doing fine. It is a short history of edema and proteinuria. Evaluation revealed a nephrotic range of proteinuria. Only 2 to 3 RBCs, I wouldn't call it as a kind of a classical nephritic sediment. There was evidence for nephrotic process, hypercholesterolemia, hypoalbuminemia. We sincerely believe that it would be yet another case of idiopathic membranous nephropathy. But this is the kidney biopsy. It was a bit surprising. As you can see here, very florid proliferative pathology. It was a diffuse, not just diffuse, almost all glomeruli showed proliferation. And it's a kind of a global proliferation involving endocapillary and mesangial proliferation, a classical proliferative glomerulonephritis. Immunofluorescence was a surprise again. There was only IgG positive, strongly positive. A and M were negative. And there was a light chain restriction. Lambda was negative, kappa was significantly positive. So now you have, of course, we couldn't do electron for this patient. We have a very virulent, robust proliferative pathology in the light microscopy. Immunofluorescence reveals immunofluorescence reveals restriction. So there is every reason for us to conclude that it is PGN-MID. Actually, what you are supposed to do whenever you come across only IgG, you are supposed to do IgG isotype also, subtype also, the G1G. Then only you can prove the monoclonality. That could not be done here. So we thought it is PGN-MID, proliferative glomerulonephritis with monoclonal immunoglobulin deposits disease. PGN-MID, it is not just confined to one particular clinical scenario, one clinical associate. It can happen in multiple diverse clinical settings. On the one hand, a frank paraproteinemia like myeloma can be associated with this. MGRS, it's one of the favorite pathologies. You can have PGN-MID in myelodysplastic syndrome. It can happen as a paraneoplastic phenomena in certain solid tumors like CA lung and so on. There are a host of infections which cause this kind of a pathology where it is only transient and temporary, and once that infection goes off, successful reversal of pathology of PGN-MID. Recently also there was a case report, parvovirus causing PGN-MID like picture. So whenever you come across this kind of a clinical picture of PGN-MID, you need to, and of course one thing I have missed out, it can happen along with certain autoimmune diseases as well. So you need to go through the panel, complete clinical and laboratory investigations to rule out systematically all these associations before calling it as MGRS. So this is the diagnostic criteria given for PGN-MID. The light microscopy, the proliferative pathology, immunofluorescence, a single immunoglobulin class, a single isotype of IgG, but more common is IgG3 most of the situations, and light chain restriction. Electron microscopy, you need to have a granular deposits in the mesangial, subendothelial, and or subepithelial locations, and absence of clinical and laboratory evidence of cryo. It's mandatory before calling it as MGRS. Keeping all that in mind, we did all these investigations. There was no hypocomplementemia. C4 was slightly on the lower end of the normal range. The autoimmune profile was negative. Cryo was negative. CT chest and CT abdomen, everything was negative. There was nothing to suggest a solid tumor. There was no cardiac dysfunction. And serum protein electrophoresis, no M band. Serum immune electrophoresis, again, normal. Serum free light chain assay was normal. There was no altered ratio. And the bone marrow revealed only 3% of plasma cells. So here we have just only the restriction of the immunoglobulin, but nothing else to prove the presence of clone. In general, how does PGN MID features? Most of them have nephrotic range of proteinuria, about 50% of them. 50% of them have renal failure at presentation itself. And hypertension, varying range up to 70%. Hematuria, you can have up to 3/4 of the patient. And hypocomplementemia can happen in up to 40% of the patients. And as noted in the literature, the positivity for picking up M band in serum protein or urine protein electrophoresis, immunofixation, all this is very, very minimal. Abnormality in the serum free light chain is also only 20% of the patients. That's what happens. And association of PGN MID most often is MGRS, very rare with myeloma, and rarely with lymphoma also it happens. This is a general description in the literature, published literature. There are certain situations, there are instances, now more and more of our hematologists encourages us to go ahead with further testing to pick up a missed clone or a hiding clone. Normally, conventionally, we do only serum protein electrophoresis, immunofixation, and pre-light chain. The newer investigations are from the marrow specimen, you are supposed to run a flow cytometry, even in the peripheral blood flow cytometry, and FISH, fluorescent in situ hybridization. There are instances by these advanced techniques picking up a clone, right? So this is a flow chart as to how to go about. You have to classify clinically and then plan your therapy. Whether there is any detectable clone or M protein in the blood system consistent with renal deposition. If it is yes, you have to go for whether it meets the criteria for hematological malignancy and requires treatment, like your CRAP criteria and so on. If it is yes, it is malignancy associated PGN MID, you have to go for chemotherapy, no confusion. If it does not meet the criteria to be branded as a malignancy, it is MGRS related PGN MID. What do you do? How do you treat? Of course, you have to give supportive treatment, empirical treatment. Whether you have to just stop short with conservative treatment or you have to go for chemotherapy, there is a big confusion. I'll talk about that. On the other hand, when there is no detectable clone, like in our patient, whether there are factors contributing to the immune disorder, like infections and autoimmune diseases, all those things, if it is yes, identify, treat them. If it is not there, you call it as an unclassified PGN MID. There also, you have to just give supportive treatment. Whether to go for a definitive therapy is a big question mark. Why we are talking like that? The prognosis is not that good. 20% progress to ESRD in less than 1 year. So this is one meta-analysis. It is not a very well-powered study because very few patients in each study. In this study, it was not a kind of a randomized one thing. No, it's only meta-analysis observation. The cohort of 40 patients who received clone-directed therapy, they fared better compared to 35 patients who were receiving only supportive therapy. Right. So if therapy means, what is the therapeutic option? If it is a B-cell clone, you have to go for rituximab. If it is a plasma cell clone, it's a bortezomib therapy. And recently we heard about the daratumumab. It is suggested by more of the others. Anti-CD38 antibody is supposed to be superior in PGN MID as well. And if no clone is identified, like in our patient, how to go about? You don't know whether it is a B cell or plasma cell. If the biopsy reveals IgG, go for bortezomib. Rarely you can have IgM. In that case only rituximab. So essentially it is bortezomib-based therapy. So this is a nice guideline, a very nice very summary of how to go about in treatment. See, the white boxes you don't treat, meaning specific therapy is not there. The black boxes, in that situations, you have to go for clone-directed therapy. The patients have to be classified into A, B, C, D cohorts. A is Proteinuria less than 1 gram and no evidence for progressive disease. You just observe with supportive care, don't do anything. B, proteinuria more than 1 gram and there is a progressive disease, go for clone-directed therapy. And C, patients, candidates are in advanced CKD and you are contemplating kidney transplant very seriously, you must treat this category. And D, advanced stage of kidney failure, you are not contemplating kidney transplant, don't treat. Why is it so? So with this, where do our patients stand? Nephrotic range of proteinuria, no renal failure. So A, so we have to treat. Sorry, B, we have to treat. So chemotherapy was initiated with VTD regimen, bortezomib, thalidomide, and dexamethasone. And 6 months after the disease onset, he had completed 4 cycles already. And what we have achieved is the serum creatinine remains the same. There was reduction in the proteinuria. Clinically, patient is stable. We can just say that the patient's condition is stabilized and the reduction in the proteinuria has been achieved. Why, even in the advanced stage of kidney failure, suppose somebody wants to go for transplant, why we have to treat? Because PGN-MID is one condition where there is a very high recurrence rate post-transplant, as high as 90%, and that way it happens very early, within months after transplant, and the graft loss happens more than 50% of the graft loss within 3 years. So it is important that you have to give targeted chemotherapy. And finally, an interesting observation, it is not PGN-MID. There was one article, nice article, actually 5 patients with DDD and C3 glomerulopathy who received eculizumab. As per protocol of that institution, 1 year after eculizumab therapy, they do a kidney biopsy to see what's happening. The initial C3 glomerulopathy's proliferation was very prominent. At 1 year, still some element of mesangial proliferation was there in the light microscopy. In the immunofluorescence, there was a kind of a MIDD, like single heavy chain and single light chain restriction. So the authors were confused whether an MIDD was missed out or C3GN evolves into MIDD. Nothing has happened because we know eculizumab is an engineered molecule. It is engineered in such a way that it has only kappa chain and it is a kind of a chimeric IgG1, IgG2 and IgG4. So it's a kind of an artificially engineered a monoclonal immunoglobulin. So can we call it as pseudo PGN-MID? With this, I end my lecture.
So our next talk is Dr. P.S. Wali, who is going to talk on renal transplantation in a patient with multiple myeloma.
So which one is that?
उसमें दिखाई ना मुझे.
I think one comment till they fix up the technicalities, one comment from the audience or from the chairpersons.
Dr. Wali is a consultant nephrologist at Asian Institute of Nephrology Urology, Hyderabad. Formerly was associate professor at Usmania Medical College and General Hospital. He'll be speaking on renal transplantation patient with myeloma.
Good afternoon, respected teachers, seniors, chairpersons, and my dear friends. The concept of contemplating renal transplantation in multiple myeloma is a much debated topic, and in the literature, to the best of my knowledge, less than 70 cases have been reported. So, in this lecture, I am going to talk about these 8 key points in a bite-sized format. The first question is, why are we discussing about this? We are discussing about this because multiple myeloma is the most common non-urological malignancy leading to ESRD. Renal impairment is presentation is noted in 25%, whereas 50% of individuals over a period of time can develop renal impairment, at any time. As we all know, the most common presentation is caste nephropathy, followed by MIDD, followed by renal amyloidosis. To note, the survival was very dismal way back in 1990s with 29 months, whereas in the year of 2019 or current era, the survival has exceeded more than 8 years or to 10 years. The second question is, what does the history taught us? History was not kind to us in this regard, and majority of the case reports reported disencouraging outcomes. In this paper published in 2004, in this study, wherein transplantation results in light chain deposition disease was studied, 7 out of 7 patients demonstrated histological recurrence, whereas 5 out of 7 patients lost their graft within a span of 33 months. The same results were replicated in other case reports, wherein the transplant was contemplated before the year 2006. Therefore, basing on this report, the conclusion was that it is better not to contemplate kidney transplantation in myeloma patients. Therefore, are we justified in contemplating kidney transplantation in myeloma in this era? To answer this question, we should know 2 data sets. The first data set is, what was the survival before 2010? In those patients of ESRD with myeloma, the survival was hardly 9 months, whereas the mortality used to be 2.8-fold higher than other non-myeloma patients. And the most common cause of death was disease progression or relapse. Whereas the trends started changing after 2006. It is not because of the fact that 2006 was a year where I entered general medicine or nephrology, but it is because of a robust fact that from 2004 onwards, bortezomib has been introduced. Along with it, 11 other promising and revolutionary time-tested drugs were introduced. So these are the various drugs which changed the face of myeloma treatment and therefore has shown enormous improvement in the lives of multiple myeloma patients. Therefore, 11 new agents. Now the standard of care is 2. First of all, we should try to decrease the clonal proliferation by using robust induction agents with the newer agents. In those patients who are fit enough, who survive the first phase, are the candidates to go for autologous stem cell transplantation. Therefore, the most common induction regimen is the triple drug regimen, known as VRD regimen, popularly all across the globe, consisting of bortezomib, lenalidomide, and then dexamethasone. And in those patients who are fit, that means those who achieve complete remission or VGR, or very good partial response, they can be contemplated for autologous stem cell transplantation. Therefore, on this background, we need to examine whether current data is encouraging or not. The current data is very sparse, but still it is encouraging. In this paper, which has been published from my group, wherein 11 patients undergoing 12 transplantation has been examined, it has demonstrated pretty good results, stating that the 1-year survival was 82% and 5-year survival was 61%. Moreover, the graft survival was 83% within 1 year and 66% by the end of 5 years. Now, with this encouraging data, let us know who are the eligible candidates. Before thinking about eligibility, we need to rule out those people who are not candidates. There are patients with high LDH, that means more than 2.2 times than the baseline, extramedullary disease, poor performance status, are those patients who continue to have persistent disease despite undergoing stem cell transplant. The second question we need to ask before contemplating the decision of transplantation is, did the patient undergo both induction and autologous stem cell transplantation? The patients who undergo induction only can never be contemplated. Those patients who undergo both induction and achieve decent hematological remission after stem cell transplantation need to be contemplated. But that is not the end. After undergoing this second step also, in consultation with our oncology colleagues, we should sit back and ask ourselves whether the patient belongs to high-risk strata or standard risk strata. Of course, it is based on few complex cytological issues, especially by FISH studies. And more important thing is the concept of looking at MRD, the minimal residual disease. It is nothing but looking for the minimal quantity of residual disease in those patients of myeloma who were declared to achieve complete remission. That means we are going to look at the bottomest strata of a submerged iceberg. Therefore, this minimal residual disease can be known with the help of the recent gadgets of next generation sequencing. And the patients who continue to have MRD, the minimal residual disease, are the candidates who are going to show relapse within a span of next 2.5 years. Therefore, in this category of patients, probably we should wait and watch. Therefore, the MRD to the tune of 10 to the power of 5 should be our target. It is desirable, whereas 10 to the power of -6 is preferable. Now, this is the most important conceptual tool, which states that those patients of standard risk with MRD negative, they are the candidates who are going to do extremely well. Whereas high-risk individuals with MRD negative, still we can contemplate. Standard risk patients who fail to achieve MRD, still you can contemplate. Rather, the dynamites are the high-risk patients with MRD, they are the candidates who are going to recur within a span of 6 months after transplantation because of the profound immunosuppression which we are going to give. Then how much time to wait? In case of the first strata, that means standard risk patients with MRD negative, you need to wait for 6 months. Whereas the second strata, that means high risk with MRD negative, or standard risk with MRD positive, we need to wait for 12 months. Whereas the first strata, probably they are never the candidates for transplantation, unfortunately. Now the question is, how do you do maintenance of post-transplant patients in this scenario? We need to offer maintenance of twofold. The first fold is for the allograft. The second is fold for myeloma, because myeloma is such a cancer. In contrast to other solid cell tumors, even though the patient has been in complete remission for 20 years, he can show or demonstrate relapse on 21st year. Therefore, despite achieving the deepest possible hematological responses, multiple myeloma patients are going to relapse, and that is the template of myeloma patients. Therefore, they are the individuals who need to be on some form of maintenance. But only issue is we should avoid immunomodulated groups, because clear-cut case reports have been demonstrated that the drug lenalidomide has been established, has been associated with steroid-resistant and multi-drug-resistant reactions. Therefore, the best agent is bortezomib along with other proteasome inhibitors. The next question is, how do you monitor them post-transplant? We need to look at free light chain assay, and ELCRO-4 is at least once in 3 months. And relapse is the most common, but we should not get feared with every relapse, because every relapse does not translate into graft loss. Infections are most anticipated, most feared, but surprisingly they are less common. And almost all the review articles quoted that probably there should be some amount of publication bias or lack of granularity of the data in coming to this inference. And cardiovascular complications are well known, along with drug toxicities. And then, how to move forward? What is the template? Template doesn't exist because it's a very rare scenario. However, the template takes the form of take-home message. The key takeaways are, myeloma is the most common non-neurological cancer leading to ESRD. Transplant done in olden era disappointing. Renal transplant is possible in the current era who undergo both induction therapy along with stem cell transplant. And current era's case reports, albeit limited, are very encouraging. Those who are eligible are those patients who undergo both induction chemo, stem cell transplant, along with MRD negative status. And myeloma needs maintenance of twofold, one for allograft, one for myeloma. And second thing is, infections of post-transplant are not common, but relapse of myeloma is common, and every relapse doesn't translate into graft loss. Of course, positive attitude and negative awareness, this applies to every facet of life, including this scenario. Thank you.
You said minimal residual disease, but the literature also mentions about near complete remission or partial remission. So whether those patients can be taken for transplant?
Probably, I think oncologists can answer this question very well, sir, but whatever literature I have reviewed, every paper has established that in the current era, we need to look at MRD. MRD is very much available even in India also, probably because it looks much beyond complete remission.
No, you can ask 1 or 2 questions, yeah.
Any more questions?
Yeah, I think Dr. Gopal Krishnan is
Dr.
around,
Gopal
yeah.
Krishnan
He's also here,
actually,
yeah.
We probably did not invite questions from, you can actually question Dr. Gopal Krishnan, sir. No problem.
We have a patient who has membranous nephropathy on biopsy, PLA2R negative, and I can call it MID. So, yeah. So how many, there's no clone seen, and it's membranous nephropathy.
Exactly.
Without any PLA2R positive.
No, it's not membranous.
It is membranous, sir.
You have.
Yes.
You have a patient.
We have a patient.
Membranous nephropathy?
Is presented as nephrotic syndrome.
Okay.
Over time, RPGA, I mean the rapidly progressive renal failure, creatinine went from 2 to 4. And elderly, 55-year-old. Sir, there's no clone seen. So how do you manage this patient?
But immunofluorescence shows restriction.
Yes, sorry. It shows restriction kappa.
So okay. So almost our case scenario is almost like that only.
There is no proliferations like we are using PGA.
Yeah, exactly. The light microscopy, the pathology of MGRS varies. I mean, it can be a proliferative pathology, mesangial proliferative pathology, or it can be membranoproliferative pathology. Very rarely atypical membranous nephropathy as well. It is very rarely. And also there is one more entity called membranous nephropathy, membranous-like nephropathy with masked immune deposits.
Yes.
So we have to subject the tissue specimen for pronase digestion, and you pick up testing also. And there is a controversy whether to call it that, to be incorporated, that entity has to be incorporated as MGRS or it is a different entity. But almost the treatment guidelines are the same.
So Dr. Baumix.
Yeah, I'll just mention here that we had done one case 6 years back, multiple myeloma, and that time she was, I think, around 30, 35 years old. And she has now completed 6 years. And during the 6 years of multiple myeloma, following your hematologous stem cell transplant, she's completed 6 years, did not have any issues regarding renal function or any infection or relapse of the disease. Very recently, she had one pneumonitis, went outside, and the physician prescribed Claribate for 3 weeks. And then she came to the creatinine of 1.9. And as you can expect, that the CNI levels are very high. And after that was sorted out, the creatinine has come back to 1. So that's the only one case that, at least we have done, and it has been published.
Simultaneous or is it sequential?
No. We waited for 2 years.
He was into complete remission as far as myeloma
we
is
went into
concerned.
MRD. I'm sorry, MRD was not done, but it was in complete remission, and we waited for 2 years just to be sure. After 2 years, we had done the transplant. Post-renal transplant is now another 6 years now.
Okay.
So congratulations, sir. Your patient is one among those.
It's so difficult in our country to get a myeloma patient getting into renal transplantation.
But see, after that,
he has to come out from that particular department to our department totally. It's not so easy.
It's not easy, and till then we're not done anymore, So we've done only one actually so far. And just to complete what they were discussing, sir showed beautifully, all the lesions of MGRS. Membranous is not mentioned in that. In fact, it's very uncommon, but recently we also had a similar case of membranous with kappa restrictions. So that also very rarely can present as MGRS. Yes. Thank you.
One practical question about amyloidosis secondary, which nowadays we have patients on long-lasting dialysis. So with high microglobulin, beta-2 microglobulin, many patients. So what, any change of dialyzer or any experience and what type of dialysis they should be taken?
Okay, thank you for that. And thank you, chairpersons and speakers. So we'll move on to the next session, which is basically case vignettes in onconephrology. The moderator will be Dr. Sanjeev Nair. The panelists are Dr. Gagan Prakash and Dr. Rajiva and Dr. Mayuri Trivedi. The chairpersons are Dr. Manish Rathi from Chandigarh, Dr. Dipinka Bhaumik from Delhi, Dr. Anand Chalapan from Nagpur, and Dr. Dhananjay from Nagpur, and Dr. Ambike from Pune. Dr. Dhananjay Ukalkar.
Shut up. Wait for the chairs to get to the chairs. Good evening, everyone. So before we start off this session, I have a couple of caveats that I'd like to point out. One, when we set this panel discussion up, one of the reasons that we did it was not because all of us have a lot of expertise in onconephrology, it's just that we found ourselves working in oncology and oncology-related cases and faced a lot of difficulty, and then realized that this is a topic that's not really discussed and covered in our conferences and meetings. And we think that this kind of a panel might help trigger future conferences, especially society conferences, from taking this up in a much bigger way, one. Two, when we planned it, we had planned for, to address one of the things that Professor Sribhushan Raju was just saying, that patients in oncology should leave oncology and come to us. We were hoping at least, that we could set off a conversation here where Oncology and nephrology don't need to be existing in silos, and effectively going forward they probably will not be. And there'll be a lot more crosstalk between the two specialties. And we wanted to set it up in a way where we had a medical oncologist, a surgical oncologist, and two nephrologists sharing their experience. Unfortunately, Dr. Vashisht Maniar had a medical emergency and is not available. So we will not be giving you an onco-nephro facet of the discussion, but there will be a nephro-onco definitely to whatever extent that we can. The last is that to the chairpersons, the two of these panelists are waiting to finish and run away. So time management is of utmost importance. That said, let's start off. So we have, what we thought we'd do is have some case vignettes which will highlight challenges that we faced in management, and we'll go through the cases. There are no diagnostic difficulties here, it's just the management and what takeaway points we wanted to highlight. So case one was a 62-year-old diabetic salesman who presented with a history of gross painless hematuria since 4 months and had these CT images done elsewhere 3 days back. We can clearly see that there are, there's bilateral HUN and there is a bladder mass. So the urine cytology was positive for a high-grade urothelial malignancy. Renal functions were raised, and there was borderline hyperkalemia. Now, this patient may have obviously an obstructive nephropathy, but there is also a contrast-induced nephropathy. An initial diagnosis of muscle-invasive bladder cancer with obstructive uropathy was made. So my first question for Dr. Mayuri is, how do you decide the choice of imaging in cancer patients with borderline GFR?
Here, the imaging is not only going to be necessary for the diagnosis, but it is also going to be necessary for planning the further treatment. So the patient right now does have an element of acute kidney injury. So what we can do is we can calculate the Mehran score, though that is not the best for the CT because the Mehran score is essentially for the PCI. And if the imaging is what is going to decide what the further treatment is, I think we may have to bite the bullet and go ahead with a contrast enhanced CT scan. I'm not too sure, maybe the surgeon amongst us, Dr. Gagan, can enlighten us whether a plain MRI could kind of replace CT there.
Yeah. So essentially we are more interested to see that with this kind of a apparently locally advanced mass and hydronephrosis, the moment there is hydronephrosis, we know that this kind of a tumor has the potential to have a metastatic disease. And what we very often in practice do is do an FDG PET without contrast, because many of these patients actually present with obstructive uropathy and we are not able to give contrast. And plain MRI, yes, is an option. That option is more so reserved if we have concerns about the technicality of safety of doing the resection, as in the local planes with the rectum and whether this patient is going to land up into a pelvic exentration instead of a cystectomy. Those information are better met with the local MRI.
So that is precisely what was done. An FDG PET was done in this patient and it confirmed the absence of metastatic disease. So to Gagan, what is the choice then of urinary reversion that you prefer generally?
Yeah, so typically there are ileal conduits and neobladders which are offered to the patients after a cystectomy. There used to be a lot of other diversions using the large bowel and fancy pouches which have been given way. It's just that the types of neobladders today are at least 3 or 4, and an ileal conduit is a very standard one. In this patient, which has already presented with a raised creatinine and possibly a borderline, possibly a baseline CKD, one would want to avoid the neobladder because of the various known ill effects and consequences on the renal function. It's almost like a contraindication beyond certain GFR that we would not want to do and a neobladder. So probably ileal conduit in this patient would be the suitable choice. Yeah.
Right. So this patient had bilateral PCN placed and then the creatinine dropped down to 1.8 after around 2 weeks. So Gagan, again, this was actually, we were planning to direct it to Dr. Vashisht, but Gagan, do you have any comments on what the concerns are in giving chemotherapy to a patient who has PCN and DJ stents in situ?
Yes, Sanjeev. So this is a day-to-day problem that we are facing without a solution, and the problem got all the more prominent during the COVID, when close to 50% of our patients with muscle-invasive bladder cancer were actually presenting with obstructive uropathy. I mean, that was a global phenomenon during the pandemic, and we saw it all the more in Tata. Now, whereas a nephrostomy would be the fastest way to get these kidney unobstructed, deobstructed, and also the more easier or more definitive diversions, because with that tumor sitting over there, a retrograde DJ stenting is almost never possible in these patients. One could think of doing a nephrostomy and starting the chemotherapy on that, or one could think of doing a nephrostomy, doing an antegrade stenting, removing the PCNs, and then continuing the chemotherapy on the DJ stents. Now, what we've seen practically in Tata very often is that the patients who've been internalized, the stents have been internalized and have DJ stents, more chances, they have more chances of landing into UTIs and urosepsis and the whole febrile neutropenia cycle when they are on chemotherapy. So we generally prefer to have an external drainage when these patients are to be receiving chemotherapy. But of course, the external drainage have their own set of problems, and a lot of times nephrostomies would dislodge and you have to reinsert them, and those issues are there. Interestingly, we actually looked at the set of patients who went through this pathway of some kind of a diversion and then tried to give chemotherapy, because neoadjuvant chemotherapy is the standard of care, versus the set of patients in which we said that let's not do all this, let's get the bladder out first, because that will be the best way to deobstruct these ureters, and maybe then give adjuvant chemotherapy to these set of patients. And what we found, which is now a published literature, is that those receiving adjuvant chemotherapy after an upfront cystectomy were faring equally well, actually. So that might be a pathway to be explored in our scenarios, our kind of patients where we see a lot of obstructive uropathy.
Do you have any comment on what the cutoff for cisplatin ineligibility in these patients are?
Yeah, so different actually, but there are various criteria for cisplatin eligibility, including sensory hearing loss and the age, and but in terms of the GFR, I think it's 40 is what is being considered for cisplatin, and of course for carboplatin it is more liberal. So it's just that the carboplatin efficiency in the neoadjuvant setting has not been found to be as good as cisplatin, so it is generally not given. There are a lot of institutes who would never consider carboplatin, but there are some centers who would want to give something rather than not giving any form of chemotherapy.
I know that the cisplatin-carboplatin debate was held in the morning when Dr. Shruti Gupta spoke, but what is your experience, Mayuri, using carboplatin with regards to renal damage?
So definitely when it comes to choosing between cisplatin and carboplatin, it isn't that it does not have an element of AKI, but it's definitely lesser than cisplatin.
All right. So again, like Dr. Gagan just discussed, there was an upfront radical cystectomy with an ileal conduit done for this patient. Surgery was uneventful, and the patient, after some time, post-surgery had a rise in creatinine. So it went up from 2.1 on post-op day 1 to 2.6 on post-op day 2, with a slight decrease in urine output. So Mayuri, what do you think is happening here, and how do we approach this?
One is definitely the creat started worsening post-operatively, so we need to look for the whatever was the insult that was intraoperatively. The fluid balance would be one thing that I would really want to look at. How much was the blood loss? How much was replaced? Were there any hypotensive episodes during intraoperatively or post? I would want to look for sepsis here, and drug dosing, absolutely we need to know what so these are drugs beyond the chemo drugs, whatever the antibiotics, the analgesics, whatever is required. So we need to know what the ongoing GFR at that point of time is, and then dose accordingly. And fluid therapy, I don't think it would be really different for somebody who is having a malignancy as compared to someone who's not. But if we require a large volume fluid resuscitation, again, our rules where, you know, you look out for hyperchloremic metabolic acidosis, and if it's going to be large volume resuscitation, you know, prefer balanced salt solutions as compared to a normal saline. And these would be the broad, the outline for fluid management here.
Okay, so this patient was finally discharged on post-op day 13 with a creatinine of 1.8 and had an output of 1.4 liters per day. So this is a patient with now some degree of renal insufficiency, and ileal conduit in place. And Rajiva, what are the diet modifications during this period, and considering that this patient now has to undergo chemotherapy, what do you think would be the diet modifications?
Yeah, so this is a patient with now CKD, probably CKD stage 3 to 4, because this is a patient with malignancy with probably a very low muscle mass, and also has an ileal conduit in place. Not working. And also an ileal conduit in place. So one of the challenges that we face in these patients is, with an ileal conduit in place, is diarrhea. So diarrhea can be a serious and a very irritating issue in these patients. And they have a multiple abnormalities. Some metabolic abnormalities like hypokalemia, severe metabolic acidosis, much more than the level of CKD that they are in. Vitamin deficiencies, like vitamin B12 deficiency. Also, the bile salts, etc., are not absorbed. So they have a chronic diarrhea which is continuing. So they can be chronically dehydrated, and they come with multiple episodes of AKI on a pre-existing CKD. And with the ileal conduit place, again, urinary infection is the other aspect we have to consider when we prescribe a diet to these patients. So the first thing is correcting the acidosis, which can be challenging in most of these cases. Correction of hypokalemia. So the diarrhea may also have to be controlled with a fiber-rich diet. Sometimes cholestyramine can be prescribed up to a certain extent. Again, a certain amount of flatulence and inability to eat is present in these patients. Considering this, the other is the protein. So in these patients with a fairly catabolic state, so they may require a slightly higher amount of protein. So actually there are, when I dug into a bit of reading, there's actually not much guidelines in managing such patients with AKI in oncological scenarios, because these are definitely more challenging than a simple or just CKD alone. So this is one of the things. So around 1 to 1.2 gram per kg per day of protein may be required. At the same time, balancing the diarrhea and other things may be actually a challenge.
Sanjeev, can I just add something? So, from a practical point of view, actually, this is a huge concern for us in the surgical side, because these are patients who've been having this obstructive uropathy, probably urosepsis, malnourished. They've had a surgery which has required 3 kinds of anastomosis: the bowel anastomosis, the ureteric anastomosis, and then we have our concerns of all the anastomotic leaps in the post-operative period. And that is where, somebody with a borderline GFR and, what kinds of protein restriction, we feel that probably a nephrologist's role in this scenario would be crucial, actually.
So again, we are actually now advocating a higher protein intake than what we would normally prescribe a CKD patient. So this is one of the things that we'll have to unlearn when we're treating these patients. Follow-up after 2 years with the bilateral, he presented again with the bilateral HUN and a creatinine of 6.2. The bilateral PCN internalization was done, and added creatinine was 3.2. On USG liver, there was a 3 into 2 centimeter lesion, which is a query METS. Gagan, what's happening here? What's the cause of a new onset hydronephrosis at this point?
So typically it's time based. So most of the hydronephrosis, either worsening or a new onset hydronephrosis that develops after a urinary diversion within the first 18 months, like 12 months to 18 months or so, are because of a surgical cause. So there's been an ischemia of the ureter which has been anastomosed, and there's a stenosis which has gradually led to the worsening of these. In fact, there are actually centers, and what happens is that these patients are often on 3 or 6 monthly follow-ups after their diversion has been done. So there is a possibility that you might miss that surgically created obstruction and you might realize it by the time the GFR is already significantly fallen. So there are actually centers which routinely perform a renogram at baseline before a cystectomy and at the first follow-up so as to pick up a very early obstructive component which is there. Otherwise, you might end up losing one of these kidneys. Typically, if the hydronephrosis is seen after 18 months or around 2 years or more than that, or essentially long-term follow-up hydronephrosis, one should very strongly suspect that there is a recurrence over there. And in this patient, it kind of fits because he's probably had a recurrence at the ureteroileal junction. Urothelial cancers, as we know, has a field change, so they can recur in any part of the urothelium. And they would, sometimes recur at these ureteric anastomosis and often have a distant metastasis, like in this patient.
So this case should ideally highlight the degree of coordination that goes on between urology, uro-oncology, nephrology, medical oncology, and probably radiation oncology as well to manage a patient like this. Obviously, this case will go on for some time, but this patient's ordeal will go on for some time, but we'll move on to our next case. Case 2 is a 34-year-old male with a history of hypothyroidism who presented in November 2013 with a right flank pain for the last 3 months. There was a CT abdomen, and the CT abdomen showed this heterogeneous mass, hyperdense mass, involving the upper and mid region of the right kidney. And there was no evidence of hydronephrosis or hydroureter. The lung bases are clear. So a diagnosis of RCC was made. This patient underwent a right radical nephrectomy, and it was staged surgically as T4N0M0. So Gagan, is there a role for nephron sparing surgery in this case?
Technically, so the things that I would want to know is his age, the split function of the other kidney, and a very, very detailed imaging study actually. To the extent that now we've started doing 3D models of these tumors. Just because we have moved from a point where partial nephrectomies were limited to T1As or T1Bs, or as we call very laddu kind of tumors, which can be really easily resected. Very, very complex partial nephrectomies can be performed if this is a younger patient, or if this patient has a borderline GFR or risk factors, or if the other kidney is at risk. So by the description of the CT scan, I think it will be difficult. Also, by a T4 stage, oncologically, it may not be very safe to do a partial nephrectomy in this patient. But if the need arises, then these are the things that one would want to consider for the, the technical aspect of, or the feasibility of having a partial nephrectomy.
Yeah, so I think the take.
Right. So what has happened is that there is a concept called as the contact surface area now. Now, imagine a 5 centimeter tumor which is totally endophytic, right bang into the hilum, versus a 11 centimeter tumor, or maybe a Bosniak 4 kind of a tumor, which is just attached to the kidney at the lower pole. So that is where the contact surface area comes. So if this is like the second scenario where there's an 11 centimeter masses which is small contact surface area, irrespective of the 11 centimeter size, should be a very straightforward partial nephrectomy, whereas the 4 centimeter endophytic tumor might be a problem because the contact surface area is like a 360 degrees for that one.
I think the takeaway from that is that we don't need to do we shouldn't automatically go for a full nephrectomy and talk to maybe somebody at TMH before. Okay, so the histopathology here came back as this high-grade renal cell carcinoma with a high chance of recurrence. So they've added a G3, which is a high chance of recurrence. And in follow-up in March 2015, this patient presented with what is effectively METs to D9 and L3, and he received received palliative radiotherapy. So the patient was thereafter started on multikinase inhibitor sorafenib between April 15 and December 2022. Sorafenib was stopped in December 2022 because he had a CT scan which showed a new onset skeletal retroperitoneal and common iliac adenopathy and stable skeletal mets. And he was planned for changing sorafenib to sunitinib. At this point, a routine workup showed that he had an adult onset proper nephrotic syndrome with 24-hour proteinuria revealing 7 grams of protein with hyperlipidemia. So what can be the causes of proteinuria at this stage, Rajiva?
So this is a high-risk RCC which has progressed to a metastatic disease which has failed one TKI and gone on to the second TKI. So I think one of the things which I would put top on the list is it a secondary sort of a nephrotic syndrome where we're seeing something like a membranous or a FSGS or a minimal change disease. The second would be a TKI-induced proteinuria, which I mean, through the talks through the day, we have seen is very common, and does, and as one of the panelists had said, can resolve with the stoppage of the drug, which would be actually quite difficult in this patient who is already in a metastatic stage. And the third probably would be that this person has had a nephrectomy. So is it like a a hyperfiltration injury? Little less likely because the proteinuria is nephrotic range. And the fourth would be probably a paraneoplastic manifestation of the cancer itself because of recurrence.
So all of these things to be considered. Mayuri, what is the role of renal biopsy in this case and what are the challenges given that there's just the one kidney? Mike, you working? Doctor?
Obviously, the challenge being that it is a single kidney and we are going to be a little more careful about biopsying these patients. Though maybe we wouldn't be wrong if we actually ask for an open wedge biopsy because it's a kidney biopsy. But I think with the current advances in the USG and the safety of the device that we use, maybe we can go with a guarded, a normal sono-guided biopsy also. Now, the renal biopsy, as we see here, that the differential of proteinuria here is very vast. Less likely, in this particular case, less likely for it to be hyperfiltration causing this, this amount of proteinuria. But again, we cannot deny the presence of an underlying hyperfiltration injury because, he has a single kidney from 2013. For the last 10 years, he has a single kidney. So there would be some amount of that. But so if I had to just put it in a nutshell, it is not only for diagnosis, but also for prognosis of proteinuria for this patient who has a single kidney.
So the renal biopsy was done. It showed 12 gloms with mild increase in glomerular size, no glomerular sclerosis or focal sclerosis. The tubule showed hyperfiltration injury and the vessels show minimal intimal hyperplasia. The IF was negative. Is this enough for you, Mayuri?
Sanjeev, can I just interrupt? So when we are operating on these patients with a borderline GFR, with an aggressive tumor, which we often know based on the radiology and other things, do you think it will make sense that the nephrectomy specimen biopsy is also sent as like a baseline, or we would only want it when the progression happens?
So for that, I mean, I think all nephrologists would be pleased if there is a GFR which is borderline and you are giving us a histopath diagnosis at that point of time. I think it makes sense because we would then come to know what the native kidney disease is and why the patient to begin with has a low GFR, and we would be able to prognosticate him better because henceforth he's going to be on a single kidney. So definitely if that specimen can go for a renal biopsy would make sense. Now here again, as you said, the renal biopsy for me, we would expect hyperfiltration injury because he's been with a single kidney for so long, but this does not make me wiser. So this picture could be just a picture of MCD because the gloms appear to be normal and it is, there is 7 grams of proteinuria. We are missing the underlying podocytopathy over here, which could be either a paraneoplastic glomerular disease or so we definitely need a EM here.
So the EM was suggestive of moderate food process effacement involving 50% of the area and hyperfiltration injury with lipid droplets.
Can I just center up?
Yeah.
So to answer Dr. Gagan's question, so we had a patient who had underlying diabetes who developed RCC and there was a nephrectomy done and actually the entire specimen was sent. So obviously when we do look at a report in a malignancy, we only look at what is the staging. But then when we read the report more carefully, the pathologist had actually reported on the non-malignant area as a diabetic nephropathy. So after this, the patient has a proteinuria, we still know that there is an underlying renal disease.
So yeah, so it makes sense for you to send the whole Mayuri will be very
And tell
happy
them
at
to
your
look beyond the malignancy.
Yeah, beyond the malignancy.
Yeah, do an IF probably.
How do you manage this proteinuria now?
Whom are you asking?
Mayuri.
So here again, with the EF showing the hyperfiltration injury in the background and the podocytopathy, again, we are not wiser whether this is just a de novo minimal change disease or is it a neoplastic glomerular disease, because the patient does have a recurrence also on the PET scan. We won't be very wrong in giving this patient steroids because that is going to treat both a primary as well as a secondary, the cause of the secondary nephrotic syndrome. There is no way that I know, and I would keep this question open to my audience, is there any way at this point of time whether we can predict whether this is a paraneoplastic glomerular disease or it is an MCD which is de novo? I am not too sure. We have biomarkers that are going to make us, maybe anti-nephrin to an extent once it's available commercially. So Manish, or if you want to.
I think the effacement was not more than 80%, it was just 50%. Possibly it's just an FSGS which was, the effacement of food processes was just 50%. So I doubt it's MCD. So it could just be a FSGS which is secondary to the, I doubt it's an MCD kind of pattern. Which
Okay, so not even the MCD, let's say it's a paraneoplastic FSGS.
That's what I think we can judge from the EM and in the absence of any other marker.
Yeah, so that's it's
I think you are right. It is very difficult to say whether it is primary or secondary. There is food process effacement, which classically speaking should not happen in secondary. There is hypoalbuminemia, which is again classically speaking should not happen in secondary FSGS. These are the two things which point toward that this is something primary. Now primary, whether it is paraneoplastic kind of thing, again that will come not typically in a secondary FSGS, which is a kind of hyperfiltration secondary FSGS. And I would personally agree that we may try to give him steroids to decrease his
proteinuria. The other thing here is that the patient was on sorafenib. So sorafenib does inhibit VEGF, and VEGF itself can cause a podocytopathy kind of picture on the biopsy. And again, we may not be able to give him this sunitinib.
Yeah, so the proteinuria here would effectively be multifactorial.
Multifactorial.
Yeah. Treatment options for this malignancy, Gagan, do you want to take that?
Yeah, so I think in the last half a decade, there's been like so many options, but broadly they are like TKIs, immunotherapy, and a combination of dual TKIs, TKI with immunotherapy, a combination of dual immunotherapies as well. I think it would largely depend on how deep the patient's pockets are and what kind of malignancy they are. But yeah, we have at least like second and third line both for clear cells and non-clear cells, which would be there.
All right. Rajiva, which are the cancer drugs, treatment armamentarium which can contribute to proteinuria?
So I think
Just use the one mic that seems to be working.
So I think the range of all the drugs which can cause the proteinuria is, so it can, all the possible known classes of drugs, if you could just show the slide. So all the possible known classes of drugs can cause proteinuria. I think in our particular case, we were, I think, discussing TKIs, which are known to cause both MCD as well as FSGS. We have the even the dasatinib, imatinib group of drugs, again known to cause CKD as well as FSGS, MCD type of lesions. Again, very difficult, as Mayuri said, to differentiate between a primary versus a drug-induced versus a tubulointerstitial disease. Many of the mechanisms for the proteinuria in these groups of drugs is actually quite unknown. Almost when I look through literature, almost everything can actually cause proteinuria.
All right. I think on that note, we can move on to the third case and hopefully last case that we'll discuss today. So this is a 29-year-old female, non-diabetic, non-hypertensive, had a biopsy-proven CTIN and was on peritoneal dialysis for 2 years, and underwent a live-related kidney transplant in April 2019. Her mother was the donor. The CMV status was D+, R+, and the EBV status was D+, R-. A pre-op CT chest and abdomen was normal. The CTC cross-match was negative. DSA single antigen bead was negative. Patient received basiliximab as induction. The immediate post-transplant timeline looked like this. There was a good graft function, and the patient was discharged with a creatinine of 0.8. Standard triple immunosuppression with prednisolone, MMF, and tacrolimus. A month later, there was a steroid-resistant acute cellular rejection, which was treated with thymoglobulin at 2 milligrams per kg, single dose. The creatinine returned to 0.6. 2 months later, there was an obstructive lymphocyte which was drained, and the patient was doing fairly okay after the second month post-transplant with a creatinine of around 0.8, 0.9. 9 months after this, the patient complains of unexplained fatigue, anger, and behavioral issues, on and off vertigo lasting a few minutes. The physical examination was normal BP, normal heart rate. Fundus was normal. The labs were relatively normal. Chest X-ray, ENT consult was normal. CT brain without a contrast was normal. A week later, because the patient kept worsening, an MRI was done. Axial and coronal imaging and T-weighted post-contrast image shows multifocal periventricular ring-enhancing lesion in the bilateral frontal lobes. Serum EBV, DNA, and toxoplasma were negative. Okay. So the further investigation showed that a patient had a CD20 positive monomorphic B-cell post-transplant lymphoproliferative disorder with the presence of EBV. A CSF analysis was done which showed EBV viral load of around 44,000 copies per ml, whereas the repeat PCR on the peripheral blood remained negative. A PET CT showed no other foci of metabolically active disease anywhere else in the body, with uptake only in the periventricular lesions. So, what are the risk factors for PTLD, Mayuri?
So my slide. So obviously, I mean, all of us sitting here know that viral positivity, most commonly the virus that's been defined is the EBV. Apart from the EBV, there have been increased chances of PTLD in patients with a CMV as well as HHV8. Immunosuppression regimen that is intense, especially the T-cell depleting agents, belatacept, and even MMF to a large extent has been known to be associated with a higher incidence of PTLD. It is seen more commonly in males and in the racially in the Caucasians at extremes of age. So children and the elderly are the ones who are most commonly affected by PTLD. If I may put it that way, thankfully for us, kidney transplant is a low risk for PTLD as compared to the other solid organ transplants. And higher the degree of an HLA mismatch, higher is the chances that this patient may develop PTLD in future. And essentially there have been case reports and anecdotal data that a certain type of HLA positivity in the recipient may predispose him to a higher chance of developing this disorder later in the soft transplant.
So our patient clearly had two of these risk factors, EBV naive status as well as she's received thymoglobulin. So like Mayuri just said, more than 80% of PTLD is EBV related. Rajiva, you want to talk about the pathophysiology of what contributes to?
So to some extent, we know the pathophysiology, EBV naive recipients. So basically, EBV becomes immortalized in the B cells, and in an immunocompetent patient, it basically does not cause much harm. But once we immunosuppress the patient, the cytotoxic T cell also gets suppressed, and therefore there's an unchecked proliferation of the B cells. And this is essentially leads to the malignant transformation of these cells and leads to PTLD. In EBV negative PTLD, however, we don't have that much of data about the pathogenesis, and most likely it is due to the chronic antigenic stimulation and infection with other viruses. In fact, CMV D plus R minus status are 7 times higher and more likely to have PTLD than the
EBV negative PTLD.
Yeah, EBV negative PTLD when compared to the CMV D plus R plus group of patients.
Okay, so what we did after this, we discontinued the MMF and tacrolimus. We started her on a regimen consisting of rituximab, zidovudine, ganciclovir, and dexamethasone. This was given for 6 months. The PET CT at 3 months showed no new evidence of lesions. The CSF at 6 months was EBV negative, and a PET CT after 1 year is also negative for malignancy. So what happened next? The patient is back on dialysis because we stopped all the immunosuppression. There was an enterohemorrhagic E. coli sepsis in late 2020 and a severe COVID infection after that in 2021 requiring ventilation, steroids and remdesivir. An AV fistula thrombosis and stenosis then followed, which was successfully managed with thrombolysis and balloon dilatation in 21. And right now she's on thrice weekly dialysis, but a PET CT even in the last month was normal. Rajiva, what are the treatment strategies for EBV positive and EBV negative PTLD?
So in this particular lady, when we encountered her, first of all, her symptoms were pretty very difficult to diagnose the PTLD itself. Even though we knew she was EBV naive, the only thing that she came with, or rather the family complaint, was that she was getting angry more often, which on retrospect, looking at the frontal lobe CNS restricted disease, was fairly explainable. After this, the other problem that we had was, so we sent her to the medical oncologist, and there was kind of a debate whether we should irradiate, that is CNS irradiation, versus any other therapy. So in this case, actually, CNS radiation, we were a little worried. She was in her late 20s, and we were worried about memory loss and other issues. So actually, in fact, she went for more of a kind of a experimental regimen where she was only treated with the antivirals along with rituximab. She in fact contacted the person who did the trial on CNS restricted lymphomas, and then she started this treatment. So in this process, one of the first things we did in this patient was to hold, decrease the immunosuppression and stop MMF, tacrolimus. We came down on the steroids to a very low dose. So that was the first thing we did, because obviously the extra immunosuppression she had already received in the last 1 year had probably contributed to her risk of developing the malignancy. The second thing we did was start her on this immunosuppressive regimen. She did develop severe infections post this, and some of the problems we faced while she was getting valganciclovir and other things was a very low count, which we were facing for a long time. So we kept having to adjust these things, and by I wouldn't call it luck, but essentially she became negative, and now she is free of malignancy.
Can she be retransplanted? What do you think?
So she does want to be retransplanted, and I think there is enough data to say that we can retransplant patients who have been treated with PTLD. So one of the things, in fact, when I was also going through literature for this particular panel, there is a case report even from India where they have transplanted a patient post PTLD. So the first question is, when do we transplant these patients? So that's actually quite unclear. So the British transplant guidelines say that at least 1 year after they become negative for malignancy. Sometimes up to around 90 months is acceptable to retransplant these patients. The second is EBV negative status at the time of the second transplant generally helps to avoid a recurrence. The third is, what type of induction agent are we going to use? So I think the largest kind of center studies which were done, they basically used basiliximab, but also in thymo-naive patients in the first transplant, they actually re-challenged them with thymo, and there was not much of a recurrence in the second transplant. The other is the antiviral prophylaxis which we have to give, which basically reduces the risk by more than 80%. And anecdotally, even a nephrectomy gives a better chance of not having EBV, not having PTLD post-transplant.
I have done one transplant, a patient who recovered from PTLD 1 year after she was in remission. And she has finished more than 3 years. She's doing well. There is no recurrence. I am yet to write it.
So before I hand over to the chairpersons, I just want to do a quick poll. In the audience, how many of you are seeing more than, let's say, 5 cases per week of oncology consults for nephro? I saw Kaya in the audience, that's why I'm saying for nephro. So 1, 2, 2. So that gives you an indication of how relatively new this field is for all of us. Where the chairpersons, you want to? Anand, you're there, okay.
All of us. Yeah, we do get a lot of consults, predominantly for the contrast CT scans. But what I generally feel is nowadays we have a low threshold to agree for a contrast CT. In fact, we have a very low threshold to accept for a CT scan compared to what discussion we have had earlier in the panel discussion. So some of this concept of contrast-induced nephropathy, it's believed to be something like a ghost kind of thing, which really doesn't exist these days. So if the benefit is more out of doing the investigations, we do clear and go ahead with it. Because many a times we find neurologists are also not comfortable with the MRI findings, or maybe it's not, the anatomy is not well delineated for that. I think the surgeons should be able to comment on that.
I think I'll just add to that, and then in a nutshell, it's risk versus benefit, and you are dealing with a patient who's having a malignancy which is life-threatening. So I think contrast-induced nephropathy
should be the least
of our worries at that point of time, because a lot is going to depend on that imaging. So I agree with you on this.
So contrast nephropathy more of a fear for the non-nephrologist. Hardly any nephrologist fears a contrast.
It's the radiologist who's more concerned.
Yeah.
But if I had to extend Dr. Sanjeev's, poll or the survey, with the rising number of dedicated oncology centers across the country, both in the private as well as the government setup, would you think that there is either a need to have an onconephrology training during dedicated onconephrology training, either during the nephrology training or maybe after that as a fellowship? I mean, is that going to be a good preparedness for the future, or you think that is too much? Maybe we can have a raise of hands on that as well.
Yes, much more enthusiastic
Looks
response.
like
Much more enthusiastic response. So you wanted to say something?
Sir.
One common area of interface between oncology and nephrology is carcinoma cervix. We have obstructive uropathy. What is your take on managing these patients who come with advanced malignancy, obstructions, renal failure? What is the approach that you have? Once upon a time that we were taught that it's all pessimism. You don't even offer them dialysis. And advanced malignancy was considered as a ethical contraindication to starting dialysis, maintenance dialysis. So what is the modern perspective that you have?
So, one thing is, sir, that the treatment modality, the primary treatment modality for carcinoma cervix predominantly is a combination of chemotherapy and radiation therapy now. We have moved from surgery. It has not shown to be oncologically better. And you're right, majority of these patients come with obstructive uropathy. The typical pathway is that we would deobstruct them with nephrostomies. We will let them undergo the treatment and at some point of time internalize these nephrostomies. But these obstructive uropathies keep bothering later on also, because now there is probably a radiation related stricture also that these patients have to battle. So yes, it is a problem. Interestingly, the role of the urologist in these patients can go decades beyond, because they also happen to be the commonest set of patients presenting with radiation cystitis and hematuria, which is refractory to various things. In Tata, we have a huge pool of these patients from all pelvic malignancies, largely from CA cervix, which present with even decades after. So they're like free of cancer for 10 years, 11 years, and now they have landed up into a situation where they need a salvage cystectomy because the hematuria is refractory. So that's another big, and generally they would present with hematuria and obstructive uropathy together.
Just a couple of comments. You mentioned regarding doing a routine renogram. So, when the creatinine is around 2 or more, renogram is of no use actually, DTP renogram. So I think a simple routine ultrasound every 4 to 6 months would have helped in the first case. Talking of the first case. So renogram would not help in any case, because it doesn't show anything when the creatinine is more than 2. The routine renogram. Secondly, the third case, most of the PTLDs are B-cell PTLDs, but very small percentage, maybe about 10% are T-cell as well. And we reported recently one T-cell PTLD, so which obviously would have the different treatment options would change. Yeah. So, thank you.
Yeah, can you make...
Now, we discussed about the radio contrast, which is used for CT scans and all that. But now, last week only I had a patient who was having neurological problems, something. The new lesion was seen on the MRI, the routine MRI. But they wanted a contrast MRI, gadolinium contrast. The best creatine was 2.5 for this patient. He's an 80-year gentleman. And they needed a contrast so that they can prognosticate this patient.
80.
So at GFR of 22,
I was just confirm the age. Okay.
Age 80 years. So now at age of 80 years, when the GFR is 22 ml, gadolinium is indicated for prognostication. So what should we do?
So I think regarding contrast-induced voice, regarding contrast-induced, I think as everybody has pointed out, it is more of a fear as far as contrast for CT is concerned, is more of a fear. And you will be surprised in PJ, even these days we are getting referral for clearance in a dialysis, like patient who is already end-stage renal disease on dialysis, going for CT, and radiologist is simply sending for nephrology clearance. So one reason is that they are overburdened and they just want to shunt the patient off, and another reason is obviously the ignorance. So I think this is more of a fear, and I think this should be more discussed in radiology community rather than a nephrology community, that whether contrast-induced nephropathy exists or not. But regarding gadolinium, I think nobody doubts that gadolinium-induced toxicity does exist, and any GFR of less than 30 is a contraindication as far as the guidelines are concerned. But as was discussed earlier, you have to weigh risk versus benefit, and if you think that you are short requiring this thing, and without that you can't even manage your patient, then I'm not sure.
So, but
because
also
if you go by
specific to that
guidelines, it is
patient,
30 GFR.
Specific to 80 years, even if he gets NSF, we are talking about what, 8-9 years down the road. I mean, the evaluation and prognostication now versus NSF 9 years down the road.
But if you see the literature in this patient...
The only thing I think you should be worried about is medical legally just informing them that this is the risk and it's down the road, and go ahead and do it.
I think there is some debate regarding this in the many recent conferences with the newer agents, which have MRI contrast agents. It's probably a myth now. Even that's what
even
saying.
That is
so
also there.
One can balance the risk. Yeah.
I think there is too much of fear, and
it's too much of fear.
Real life issues which we have encountered with GADO. But medical legal, yes, that problem.
I also wanted to share one interesting, because somebody has asked about CA service. We had a lupus nephritis patient, and this patient was managed with immunosuppression, was a refractory disease, and then she was like 60 years with refractory disease, and suddenly she had bleeding per vaginum and diagnosed to have CA cervix. Without any obstructive uropathy or so renal biopsy proven lupus nephritis. So this patient was managed with radiation oncology people and given radiation, and by giving radiation this lupus nephritis went into remission. And this patient is off immunosuppression since last 5 years. We have actually published this case also. Very interesting, like just by giving radiation, the lupus was also taken care of. So this is also one of the interaction which you can find between oncologists and nephrologists. It is not one-way road, it can be both ways.
Given that we've moved from onconephrology to contrast-induced nephropathy, I think we should close this session now. And sir, 10 minutes ahead of time.
Yeah, thank you so much, which is why we made you the moderator.
Thank you.
I think we are now approaching the last session of this Goa conclave, and to chair this session, may I invite Dr. Sandhya Suresh from Chennai, Dr. Vineet Behera from Mumbai, Dr. Ravindra Prabhu from Manipal, and Dr. Sri Lata from Calicut. The session is a panel discussion on pre-transplant cardiac screening of recipients. How far do we go? And it will be moderated by Dr. Zahir Virani. May I invite the panelists for today, Dr. Sharad Sheth from Mumbai, Dr. Subhashri, and Dr. Kayan Siodia. Dr. Kayan is the cardiologist and would be the center of attraction today in this panel discussion. Is Dr. Suhas Bhavikar around? I think he had to leave. Over to Zahir. We have 30 minutes of panel discussion, 10 minutes of chairperson's interaction.
So we are going to start and end on time because we don't want anybody else to miss out on the evening beach. Also, we're going to just do a little bit of a modification. So said we're going to give 10 minutes to the chairpersons, but we're going to give all the time to the panelists and the chairpersons because this is basically an area where everybody is always fighting with the cardiologist or the anesthetist for fitness for their patients. So let's hear what everybody has to say about their practices in their hospital instead of me just going on a monotonous journey down this road. So, yeah, the slides are up. A 50-year-old male, Mr. Left main, diabetic for 20 years, hypertensive since 20 years, chronic kidney disease since the last 10 years. On maintenance hemodialysis for 7 years, thrice a week, no symptoms during dialysis. Was planned for a kidney transplant. The wife was a donor. Being the wife, obviously, there was no match. The ECG was within normal limits. The 2D echo showed a grade 1 diastolic dysfunction with preserved left ventricular ejection fraction and no regional wall motion abnormality. Now, when this sort of case comes up for a transplant, we obviously have to get anesthesia and cardiology fitness. And these are the various tests available to us. So first I'd like Dr. Sharad Sheth, sir. So what are the practices in your hospital if you come across a diabetic hypertensive patient with no history? How would your team evaluate him?
He's 55 years?
Yes, sir. So this is the case, sir.
I am in a corporate hospital.
Right.
Wherein the fitness is a big issue. And I have to refer to anesthetists and cardiologists as a protocol before transplant. So this is a must for me.
Right, sir.
And also I feel because there are traditional and non-traditional risk factors. I've been diabetic hypertensive for more than 10 years. And as to say that all diabetics essentially have to have angiography before transplant.
Right.
Especially why do we doing transplant? To give him a good life for at least 10 years post-transplant. If we have not assessed his cardiac status properly, and if we were to develop a cardiac event just within a couple of months after transplant, successful transplant, it would be a disaster. So I think this is a must, this case, for a cardiac evaluation. Angiography. Straight away. No, straight away angiography. Yes, with a diabetic with multivessel disease.
No. I will reply to that. I have been doing myocardial perfusion scan for more than 26 years. So 25 years back, whenever those patients on dialysis, we refer to cardiologist, he'll always do angiogram. But those patients in angiogram, he showed triple vessel coronary disease. Those who were asymptomatic, I referred an outside hospital for myocardial perfusion scan. And more than 20 patients who had triple vessel disease, more than 90% stenosis, when myocardial perfusion was negative, I did not allow him to do cosmetic angioplasty or cosmetic bypass. And not one of them got MI in next 1 year. So we are doing a myocardial perfusion scan for all asymptomatic patient dialysis for last 20 years once it came to our hospital. Angiography only if cardiologist strongly feels, in spite of a negative myocardial perfusion, this patient does require angiography, or symptomatic patient, history of MI, you know he's got angina, that is different. But asymptomatic patient protocols are different, because even if normal society, we start doing angiography everybody, so many fellows have blocks. So just cosmetic angioplasty or cosmetic bypass may not help.
So we'll let everybody else speak first, and then we'll let Kayan, who's the cardiologist, speak, so that we know how diversified and how different everybody approaches their patients. So Kayan, I'm sorry I took the mic away from you.
We have a cardiologist also, and also a nephrologist who is working in a government setup. We'll take a view, and then we'll throw the question to the audience.
Oh, you want to go that way? Okay, so but Kayan will give you the answer then.
Yeah.
Because he's a guidelines-driven guy.
Yeah, Kayan.
Go ahead, Kayan.
Can I just, I just had a comment here.
Go ahead.
So there was this landmark trial called the ischemia CKD trial,
right,
published by Charles Herzog. It's an international trial.
Right.
I happen to be the lead author from India, and we looked at all our patients, and it clearly showed that if you are placing these patients on the wait list for transplant, pre-transplant cardiac evaluation did not have any benefit in the mortality outcomes. But the problem is, I also work in a corporate hospital. Our cardiologists refuse to give us. So we are literally hounded into getting these angiographies done. So that's
right. So I will just interrupt.
But I've just given you the literature support for this trial.
No, you're right, sir. And the AHA guideline, which came out in 2022 in November, which I was also made to read after Dr. Umesh Khanna sir gave me this opportunity. So that's what Kayan is going to update
November
you on.
22.
Yeah. Yes.
In circulation.
Right.
For CKD, ischemia CKD. But that is for disease donor wait listing. Here we have a live related donor.
We were a part of the trial, and we had the live-related transplants are very much a part of this study. Okay, there's another paper on disease. There was
77 patients, and that is for disease donor.
No. There were two arms. We were part of the live-related this thing, and
I think you all are quoting two different trials.
Yes.
No, so now we'll let Kayan take it. Yeah, Kayan.
Actually, sir, Journal of American College of Cardiology, if somebody is interested, July 2021 issue.
Well, sir, I absolutely agree with the ischemia CKD trial. It actually very specifically states, it's the 2019 which came out, which specifically states anything less than moderate disease, revascularization will not help, GDMT will help. But it is moderate. Please be advised, it is written very clearly. So that caveat still remains. The other caveat in that was the arm, the endpoint was mortality. At no point in time did they ever state that pre-operative or intraoperative or post-op there were any differences seen in revascularized and non-revascularized group. Coming to the 2022 November guidelines of the AHA, they did a very wonderful thing which actually brings out, as Sir very specifically put, cosmetic angioplasty. So they changed the term coronary artery disease into coronary heart disease. So at no point in that guidelines will you see CAD written, it is CHD written. Why did they do that? As Sir said, what you see on a coronary angiogram is the epicardial vessels. You do not see the microvascular circulation. So you cannot comment on that only by an angiogram, number one. As for this case, I would actually advise a dobutamine stress echo rather than any other, modality as step number one. In this 2022 guidelines, one more thing was very specifically added, which was different from the 2020 guidelines, which actually states that risk factors which are ubiquitous to CKD, that is your hypertension, diabetes, peripheral vascular disease, should not be considered additional risk factors. That is very important for us to understand. So these are not taken as additional risk factors. So this patient, I would not put through an angiogram. First and foremost, I'll put through a dobutamine stress echo. When I talk about dobutamine stress echo, these tests are physiological basis. When I do a CT coronary or an angiogram, these are anatomical basis. So even if I find that the anatomy is clean or the anatomy is disease, it will never give me the idea of a physiological disease in the patient. So that is actually two differences that we very well need to understand. And as Sir said, myocardial perfusion scans, there is a very big problem with that because the pre-test probability should be very high in these individuals. So if you feel, then the MPS will do, while a DSC has a better sensitivity and a specificity than an MPS. So that is something that I would like to state.
Why not just straight away a treadmill? Why do you want to go to the, you said dobutamine. Do a treadmill, and if it is positive...
I'll get back to you. So treadmill... No.
Pardon?
No, treadmill can be done. I agree.
Treadmill.
I absolutely give Sir that. But a treadmill, again, the sensitivity and specificity is very poor, number one. Number two, false positive, I would rather put it as it is observer variation is very, very high. So there is something called the treadmill test index, which can differ from the same cardiologist seeing the same TMT at different point in time. As you're going for a transplant, I would rather not take that 2% chance of inter-variability and put the patient through a DSC which is more specific.
Other way around, rather than TMT, those asymptomatic patients with the myocardial perfusion scan, it showed ischemia. It was confirmed by coronary angiogram. We did not find it negative. Coronary angiogram also showed a hidden disease which required angioplasty or bypass surgery. I'm talking of only of asymptomatic patients. TMT can be false positive, false negative, but myopulmonary was very sensitive.
So DSC and MPS, yes, I agree with you. Where this is concerned, that changes substantially. But even if you do a coronary angiogram, for example, you find a circ lesion which is 90%, would you revascularize or would you not revascularize is the question which comes. So you again go into a dobutamine stress echo or a myocardial perfusion scan, see whether this is moderately high, low risk, and then go ahead even with a 90% circ lesion. I have given fitness for a 90% circ lesion and the patient's doing wonderfully well.
And I was in a government institution what Sanjay was talking, and we went through a spell when we were very liberal in doing angiographies. Whether the patient was symptomatic or not symptomatic, if he was diabetic, if he was older, angiography was done. And then it was stopped because we realized that we were reaching nowhere. But I would like to tell you that it's not that simple. These patients are having a sedentary lifestyle. Many times they are not symptomatic. At present, I am in a corporate hospital. All these patients go for, recipients go for cardiac clearance. And as you are mentioning, dobutamine stress echo is a standard test which is done on all these patients. Besides a clinical assessment, the problem with the myocardial perfusion nuclear scan, which we used to do when I was in Sanjay Gandhi PGI, we found that it was difficult to interpret. Many times when they used to say that it's not significant, we thought the patient is symptomatic and he has significant problems. I think if a patient has symptoms, if there is a history of coronary artery disease, these patients must be subjected to coronary angiography. Recently, we had burnt fingers with 2 patients in just 3 months' time. The first was a young patient who was cleared after the standard test which you are mentioning. He was going for surgery, and just when the intensivist was inserting the central line, he had pain. And when he had pain, we found that he has had actually acute MI. And the surgery was postponed. Before that, he was given clearance after undergoing angiography because the cardiologist deferred, as you are mentioning, 90%, 89%, 70% stenosis. So what I am trying to say that these patients are a different type of patients where we have to be careful. Another patient who had undergone angioplasty, he was cleared after the dobutamine stress test. Within a month of transplant, he had an acute MI. And he has had a coronary angioplasty. And within 2 weeks, he has had second acute MI.
So they will always...
So I'm trying to say that you have to be more careful.
Yeah, you have to individualize. The guidelines are a rough guideline.
Even the guidelines will not be...
Yeah, that's true. But we have to have a book which... Sorry,
just going in a little into technicality, when we talk about, there is another component of myocardial infarction called myocardial infarction in non-obstructive coronary artery disease, which you will see generally, I'm putting this forward because you see this generally in young CKD patients who have Prince metal angina, who have severe vasospasm of the left main, which can actually lead to an MI. And when you do an angiogram, it's absolutely clean. So it's actually classified in the universal definition of MI type 2. And this is a known phenomenon. So that's what I'm just coming to.
Okay. So Kayan, you're going to have to spend some time on tea with Sir. Yeah, so that we can finish this. The chairpersons have a comment, or should we go on to...
So I think we should go ahead, and as he told that we should do a stress test, and if it comes positive, so we do a coronary angiogram. So how would you go further? So if we...
so which lesions do you revascularize, Kayan? You almost answered that in the last one.
Exactly. So I would not go back the anatomy basis because then as you...
Right. So now
actually
what...
take these questions so that...
Right. So let's talk about the duration of dual antiplatelets. Now you've stented this guy with the drug-eluting stent because that's what you normally do. So how long after a stenting would you allow us to go in for a transplant?
There are beautiful new stents which have come into the market, especially by the Medtronic. I hate to name it, but they actually have come out with a trial where you use dual antiplatelets only for 1 month. After 1 month, you can stop dual antiplatelets and keep them on a single antiplatelet, plain EcoSprint, and do your surgery even after a month and a half. So 1 month is all that's required for dual antiplatelets. Go ahead and then finish off your transplant.
Okay, and the normal stents which you use?
It's normal, it's available.
The CKD patient rather than...
Right. Absolutely, sir. Onyx stent is proven in CKD patients. They've done a multicentric trial of 29,742 patients.
So
what
Kayan...
in one month of dual antiplatelets, then you can put back the patient on single antiplatelets.
So what Kayan is saying is the same thing that I read in the guideline.
It's available. It's available. The Medtronic stents are available.
It's coated, sir. It's a newer generation of everolimus coated stents, if I'm not mistaken.
Severolimus.
Similar, yeah. Severolimus.
Our cardiologist...
Sirolimus, my mistake.
Sir, ideal. So we have this guidelines where actually requirement is 1 year, but if the patient requires any surgery, dual antiplatelets can be stopped as early as 1 month. Put the patient on a single antiplatelet and go ahead and do it.
Yeah, I think our cardiologist perhaps use the same. I don't remember the name of the stent, but we are using only for 3 months, avoiding the stents which require for 1 year. Otherwise, patient will die of money on dialysis. He will not be having a transplant after 1 year.
So you're absolutely right. So I'm sorry.
After 6 weeks of dual antiplatelet, we have done transplant, we have stopped, and after the transplant is done, they are back on dual.
6 weeks. So 1 month
the
is...
November guideline answer this?
Yes. The November guidelines says exactly what he's saying, the AHA one. That should be one thing that everybody should read and then quote it to their cardiologist. So now, can we operate on EcoSprint, clopidogrel, ticagrelor, prasugrel? Which one is it safe? And how long do they need to be off these drugs so that we can operate?
So the last two are irreversible ADP inhibitors. I would absolutely avoid ticagrelor. Prasugrel is an absolute no-no. Clopidogrel and EcoSprint, there has been debates. So the only thing is that EcoSprint has been studied for much longer than clopidogrel. So keep the patient on a single EcoSprint. Go ahead and do it. Number 2, where clopidogrel is concerned, Indians have been found to be fast metabolizers. So the chance of antiplatelet failures are high with them.
So you would say that best drug would be EcoSprint. Just keep the EcoSprint and go ahead with the transplant.
Absolutely.
Great.
Okay. When to stop antiplatelets before kidney transplant, you almost answered that question. When to restart the antiplatelets after transplant? Now, like Sir said, that in his cases that after 6 weeks, they go ahead, they do the transplant, and then how many days after surgery would be absolutely essential to start? Or if there's no bleeding, you start after 48 hours?
As soon as hemostasis is achieved.
Possible. Okay. Are there any reversible agents for antiplatelets? So suppose now, just for example's sake, it's a disease donor transplant. And this guy is already about 6 months post a coronary angiogram, didn't come for follow-up, an angioplasty. Would you still take him up or would he be denied?
I'm sorry, I didn't get to.
Okay, let me go again. This gentleman got a disease donor program and he got a transplant in the middle of the night. We haven't had chance to stop his dual antiplatelets. So he's already on EcoSprint and clopidogrel. Would you still be brave enough to give us permission to operate or no?
Absolutely, go ahead. The only thing, just going a little ahead of it, now we have IV antiplatelets available on the shelf, IV cangrelor. Okay, the T-half of that drug is 3.5 minutes. So if you feel that you have to transplant the patient, you can stop clopidogrel, EcoSprint like 5 days ago, put the patient on IV cangrelor as an infusion, stop 2.5 hours before surgery, and put him back post-op. So if that's available, then everything's sorted. You don't even need to take care of that.
Go ahead.
The surgeons might have a problem.
They'll ask for his fitness.
So
T-half is 3.5 minutes, sir.
No, the patient is on EcoSprint and Clopid. So the transplant has to be done in the next 2 hours. So I'll ask both the panelists. So what would they do?
We'll do this program for all the cardiologists of the country.
Yeah. So before answering that question, I actually would like to ask this question to the cardiologist. How do you assess what is the bleeding risk in a patient who is planned for transplant? What are the parameters that you look into? Because we do, like the 2020 guidelines of KDIGO actually is based on your HA 2012 guidelines on doing all the guidelines on non-cardiac surgery. After that we had the European best practice guidelines, and recently in 2020 we had all these questions actually have got very precise answers in your European Society of Cardiology, which has been endorsed by European Society of Anesthesiology also, when to stop and when to restart, at which hour to, and that particular guidelines, actually after reading that I kind of knew about the Cangrel or drug. But my question is, how do you assess this particular patient has got a high bleeding risk or high thrombotic risk during the surgery?
So the 2012 guidelines that you're talking about was adapted by Ravel et al., where everything was angiography. Everything was anatomical based. There was nothing physiological based, number one. Number two, coming to the question on the antiplatelets, it depends on, there are many, calculators, risk calculators for bleeding, has bled, your Lee score, your RCRI. So these risks are important. However, if you're getting a donor in the middle of the night and the scarcity of the organ, you're not going to stop a donation just because you're on dual antiplatelets. Give him platelet concentrates. That's fine. Because platelet concentrates half-life is 4.5 hours. So that's not going to change anything much about my stent. And then you can just immediately put him back on IV Cangrel or post-op. So that makes sense, So this was actually addressed, this same question was actually addressed by Lee et al. In 2021. He had a paper on this similar question which you asked, but it was for other non-cardiac surgery.
Because we are aware of all this Hasbled score and for CHADVAS score, but at least my perception was all these are applicable in patients who had AF. So
no, these are just bleeding. These are bleeding risks. These are not only specific to that. So CHADVAS is actually AF specific. Hasbled and other Lee score, RCRI and all are not specific for. And they're mostly for NOACs, but can be interpolated even for antiplatelets.
So we're going to move on a little bit, and again, these are the three drugs which cardiologists love, and there is some debate in our...
and SGLT2 also, no?
And SGLT2 also, yes. So, So SGLT2, most of the time, now it's coming that you can continue till dialysis, but otherwise you wouldn't see so many patients on SGLT2 when they're about to get transplanted. But statins is one thing because we've been seeing, because of the coronary angiograms and the angioplasties done, ACE-ARBs and now even the ARNIs, the netilirsin inhibitor and the valsartan combination and the beta blockers. So what's your practice in your institute regarding these three?
I'll just take one question at a time.
Yeah.
Question number one, statins. The LOAD trial actually says that if the patient is not on statins, you need not restart statins. They do not change the outcome of the surgery. Number one, they were very specific on this. So statins is more like a long-acting, the pleiotropic effect of statins, that is your anti-inflammatory action, is going to take time to act. So don't start preemptive statins, just pre-op. Number one. ACE-ARBs, if the patient is on ACE-ARBs, the pivotal trial actually says if the patient is on ACE-ARBs before your transplant, you can continue that. But I'm not the best judge. I'm not going to dwell into it much because everybody is well educated where ACE-ARBs are concerned, and probably I can know better.
So even our latest trial said that the stop ACE trial said don't stop the ACE-ARBs. So we agree with you unless there's refractory hyperkalemia. So then that's a different game altogether.
And the last point of beta...
Agree with you, sir. Agree with you, sir.
So you just don't want to be confused why there's allograft dysfunction. Bottom line, right? Okay. Right. Then you're confident. Then yeah, fair enough. Sorry.
And I think that has been also reiterated in the AHA scientific statement in 2022. Right. They do advise that the ACE-ARBs can be continued, but we should exercise caution, and preferably we can restart it once the renal function and the electrolytes have stabilized post-transplant.
So individualization.
Do you recommend initiation of statin
There is no data on that, madam, frankly.
After
If the
transplant for
patient,
cardiac protection, most of post-transplant
ma'am,
cause of
first
death
and
is cardiac.
foremost, cardiac statins, preemptive cardiac protection, there is no data. Let me be very clear on this. There is no preemptive data in a patient with normal lipids having any benefits by preemptively starting
But you recommend
statins.
statin for all diabetics beyond 50 years of age for primary prophylaxis.
There is no primary prophylaxis for statins, madam. If the patient's lipid profile is normal, lipoproteins are normal, you do not start primary statins because they themselves have their own risks and problems. So if you feel that there aren't any issues, I would not start statins preemptively for a 50-year-old at least. Getting to the point of beta blockers, beta blockers are wonderful because they decrease your sympathetic tone, but it is very clearly stated it should not be started within 24 hours prior to surgery. So if the patient is on beta blockers, you continue your beta blockers, but do not start them 1 day prior to the surgery. They can be started post-op immediately.
So I have one last case, and we're going to go through this very quickly. And this was only put up because this is another problem which we all come across. So it's a 25-year-old female, end-stage kidney disease secondary to acute, a mechanical aortic valve replacement secondary to infective endocarditis, preemptive kidney transplant, donor was the sister, patient was on warfarin. Okay. Basically, the ECG showed no ST segment depression, T-wave amplitude reduction, and LVH pattern. So I'll just get to the question scan so that we don't disappoint Dr. Umesh Khanna because we have only 4 minutes left. So what would you do next? Now, how the basic idea of this question is, what do you do when you're on an oral anticoagulant and a patient is for transplant? Sorry, my mistake. Do you want to go back and see the first part? Yeah. You got that? Okay.
Next, immediately measure your bleeding parameters, your PT-INR, get your PT-INR less than 1.5, till then put the patient on Clexane, overlap, keep the patient on Clexane, do your transplant, put the patient on Clexane again, overlap with warfarin, and after the INR is 1.5, stop the Clexane. Very important, very, very important, the overlap part.
And what is the role of newer oral anticoagulants in mechanical valves?
Absolutely zero. There is data which actually proves that NOACs used in mechanical valves actually increase the thrombogenicity of the valve. So NOACs, as of today, are not indicated in mechanical valves.
Clexane we avoid in dialysis patient, not use it. Not.
What I mean is, sir, dalteparin or something of that nature. What I mean is LMWH,
That's what we follow,
sir.
for 3 days before.
LMWH can be given, sir.
Or we can use unfractionated heparin, but there'll be lots of poking, yeah. And the drug interactions with immunosuppressive agents, I don't think we should push it to CAN, but anybody else in the chairpersons or the panelists, have you had any experience of any problems with using newer oral anticoagulants and immunosuppressive agents in any of your population? When I went through the literature, I didn't find any, at least with Apixaban, which is the one which is preferred among nephrologists. There is no interaction between tacrolimus and mycophenolate mofetil. We had this problem in the middle when there was a COVID pandemic, where everybody wanted to give anticoagulation, and like Sir said that we were challenged to give Clexane. So lots of people in our transplant population ended up being on Apixaban and tacrolimus and mycophenolate mofetil. So anybody's had any experience with that? Any bad experience? Because the literature says there's no interaction.
I think theoretically there is an interaction because Apixaban and rivaroxaban are substrates for CYP3A4 and also substrates, all of the newer anticoagulants are substrates for PGP. So theoretically there is an interaction, but they have graded it as a category B interaction, so there is no necessity to avoid the combination of these drugs. So in many patients in COVID especially, we have seen Apixaban being added for transplant patients, and we have preferred Apixaban because it has the lowest renal clearance of the 4 NOACs that we have.
So we're done, now it's your turn.
No, I think, yeah, I think anybody wants to add a comment, we still have about 5 minutes.
It's not a comment, just an impression in my mind from practicing nephrology for a long time. 1978, started doing transplants, and no cardiologist, physician will see, and the nephrologists also happened to be good physicians those days, and say
no, even
that...
Even these days, physicians are not called by nephrologists more often.
So, we'll give fitness for surgery. And it happened for about 10 12 years or so. The cardiologist, echocardiograms came in, and for another 10 to 12 years, the cardiologist gave consent on the basis of echocardiogram. 2005 or 2007, I started associating with the cardiologist who wanted treadmill angiogram. Before this association, we lost one patient immediately after the transplant due to myocardial infarction. Since the time we started associating with angiogram doing work, we have not lost any patient intra-surgery or immediately post-operative, but at least 30 to 40 patients have not had a transplant, have stayed on dialysis, left dialysis, or died during dialysis. I really do not know whether we need all these things.
I think any comments from the chairpersons about anything to do with this session?
What about cardiac CT? Because there's some, or combination of CT with perfusion scan.
CT sensitivity is only 52%. So if you find that there is a lesion in the CT, you will never be able to grade by the CT what the lesion is type. So if they give a 60 to 70% lesion on a CT coronary, I have to do a normal angiogram because I cannot know the. So as I said, if you want to put 200 cc of dye for a CT coronary, why not me go and do a 25 cc dye and finish it off in a CKD patient? So CT coronary is something which is left to last. It is only when your pre-test probability, like you have a 50-year-old lady as his example, where the chances of her having a coronary lesion is very less, then you may consider a CT coronary, doing a CT coronary. So once your CT coronary is clean, you don't even need a DSC actually. So
a diabetic who has already a CAD is awaiting transplant. Is coronary angio is a must? History of CAD is there.
If the patient is CAD, if the patient is stented, if it has been more than 1 year, still do only a physiological test. If the physiological test shows that there is a problem, then go do an anatomical test in form of an angio.
That's all what is required.
Absolutely, absolutely.
The AHA 2022 November issue, which everybody seems to have read, is basically got two tables in it. And it's very simplified. Patient with coronary heart disease, patient without coronary heart disease, history of coronary heart disease. And then they just simplified the whole discussion actually, like Dr. Umesh Khanna said, there should have been more cardiologists around. So Kayan's the exception to the rule.
KDIGO latest says that discuss case by case decision, discuss with your cardiologist.
That's why we got only one.
Dr. Kayan, can I ask a question from here in the audience?
I'm sorry, thank you.
Two things actually, two questions. So the first one is patients who are not getting sirolimus coated stents. How comfortable are you in those patients, and how many months after the stenting would you stop the second antiplatelet and go for transplantation? And the second question, I just want to clarify because you already mentioned it when you were telling that normally we just follow like a 3 to 5 days overlap with heparin and when we are shifting to warfarin. But you specifically mentioned we have to wait till the INR should be 1.5. So is that the current practice by cardiologists?
Absolutely, because when you give warfarin, they tend to act as a coagulant for the first part because of the protein C activation. That is very important. We generally tend to forget that. That's why you overlap with Clexane, or sorry, LMWH, dalteparin or something of that nature, till the INR is 1.5 and then stop the LMWH.
So we normally used to overlap for the 3 to 5 days, but
it's not 3 to 5 days, ma'am. It's till the INR is more than 1.5.
Okay. And what about the first part?
And the first part, now we have only drug-eluting stents. And we should not be looking on, the concept is different. We should not be looking at only the drug which is in the stent. So we have zotarolimus, we have everolimus, we have sirolimus. It is the stent strut size that is also very important and is thrombogenic. So the Medtronic stent which I spoke about, in 1 month you can stop, has only 100 micron stent size, which is very, very small. So that's why you can stop it in 1 month. The other stents have data on 6 months follow-up. So within 6 months, you can stop dual antiplatelets, put them on one. However, the ideal, as is actually written down, should be 12 months of dual antiplatelets.
Okay, thank you.
Replying to Dr. Ramlingam, if you look at the late 80s, figures of post-transplant patients all over the world, diabetic especially, I'm talking about recipients, the mortality was quite high, and I have seen that in the country also. Mortality significantly came down when cardiologists came to the picture intensively. Whether they did angiography or they did a myocardial scan, when the patients were properly evaluated, not only question of angioplasty, beta blockers, statins and ecosprin, the mortality did come down. Mortality was significant. One more caution, post-transplant patient, when they come with angina, acute coronary syndrome, I think ecosprin and clopidogrel is better than Brilinta or Prasugrel, because I have seen 4 TMA-like lesions last 1 year. Creatinine goes up, you have to stop it, continue with the ecosprin and clopidogrel, and the patients recover. So that's a caution for everybody whose patients require angioplasty or stenting post-transplant patients.
Well, I think, yeah.
I have a couple of questions. First is to you, sir. You touched upon the type 2 MI. So the type 1 MI, the plaque rupture, does any of these screening tests predict that?
Absolutely. That's why they have brought this into the guidelines, that you do not miss a left main. A patient may have a normal echogram. A left main, a 50 to 70% left main lesion can have a normal echo. That is something that we need to understand. That's why you have to put the heart through stress so that you can, reveal these left mains. So you should not miss these left mains, valvular lesions. That's why these echoes and dobutamine stress echoes have come into play. So that's important.
And another one for the general audience, like how many of us have cardiologists who attend our transplant meetings?
Hardly anybody.
No cardiologist attend any meeting.
He's right here.
So anyway, that just shows how popular Kayan has become. Yes, Manish.
Yeah, it's regarding the, we are discussing about the formal physiological testing of the heart before subjecting them for transplant. So now we are having, discussing about a subset of patient who is undergoing dialysis 3 times a week, who are tolerating 3 to 4 kgs of fluid overload during that 48 hours period, who are getting subjected to variations in the blood pressures during dialysis, hypotension or accelerated hypertension. So can we extrapolate this as an informal physiological test? Because we are thinking about the patient undergoing anesthesia for 3-4 hours. Or can we do anything, or can we stress heart during dialysis where monitors, everything is available, and we can have not a formal stress test or a dobutamine stress test, but something like that.
Getting a transplant kidney, very clearly it's written, it's a scarce organ. So you would not want to have a non-physiological or a proven data. As you said, wide fluctuations during dialysis is an indicator that there is some amount of coronary, because there is perfusion mismatch. So that can be taken as an informal, but cannot be substituted for a dobutamine stress echo. That is for sure.
You can do a trial and see. That's the only way to prove it.
Since we are discussing little off the track, what is your approach for patients having pulmonary hypertension? At what level you will recommend to be accepted? Many times cardiologists put it that the person has got severe pulmonary hypertension, 60 millimeter or 65 millimeter, we will not accept. Sometimes the moderate they accept. What should be the message?
Okay, so as per the new guidelines, a systolic pressure of 65, more than 65, should be treated before transplant. Now, a CKD patient, they have found data. There was a large Israeli trial in CKD patients where they found that there is some amount of dysfunction, endothelial dysfunction in the pulmonary vessels which take place, especially a patient who is long-standing CKD, which has been into, if I can use the term uremia, please forgive me if I'm being ignorant, but when the creatinine has been high for quite some time, then they have vascular changes where the pulmonary pressures are on the higher side. So a severe should be taken down to moderate. So there has to be one class difference before taking up for transplant. So you can
Is it you put them on sildenafil?
Sildenafil, tadalafil, ambrisentan, safe.
And how much time roughly it takes?
So
CV
the guidelines actually say put them on a combination of tadalafil plus ambrisentan, get them down by 1 degree, repeat echo after 3 weeks. If they come down, then go ahead for the transplant.
I think we'll have the last question from Manish.
Slightly off track, kidney biopsy on dual antiplatelets. It's a dilemma which we come across, all of us come across. A PTCA patient coming to you with AIN, or let's say AKI post PTCA, not recovering, and you suspect something other than contrast. Now this is 1 week or 10 days after a PTCA, and the patient has almost become dialysis dependent, and sometimes with normal renal function baseline. So how do you approach this? And a transjugular kidney biopsy is not favorite of any of nephrologists. So it has to be a percutaneous one. So how do you approach that?
Very good question, sir, because I got into a scuffle with a nephrologist who is sitting in the audience in the same matter. So with the invent of cangrelor, this is absolutely out of the picture. So even after PTCA, immediately, if you want to do it in 1 week, stop the antiplatelets, start IV cangrelor, take him up after 3 to 5 days, depending on what dual antiplatelet patient was on, do the biopsy, and put him back on dual antiplatelets.
Friends, you will all agree that this session seems to be winning the most popular session of this Goa conclave.
Well, like my DM exam actually, but that's okay.
So 3 cheers to the cardiologists and the entire team who brought this discussion to that level.
We should really congratulate the cardiologist for making all the doubts clear.
Yeah, but I would thank Zahir and the entire team for making this session very lively and entertaining. And please accept my congratulations that we are still sitting at 5 o'clock and we have to close the question answer session, not because the people are not enthusiastic, but because the time has come. So thank you everybody. It was really a learning experience for us and we really enjoyed this Goa conclave. I hope the same applies to you all, and maybe I hope all of you all will come back next year with Goa conclave.
I think we must give 3 cheers to Umesh, and like every year it has been a wonderful conference, very interactive, lively, and keep calling us.
General Saab, you realize that the general just gets the praise and the medal. The work is done by the foot soldiers, and I must thank my young team, Mayuri, Zahir, Vineet, Sanjeev Nair, Akash, and we have a team of about 8-10 youngsters who brings it together, and that's how I remain young, mainly in the combination. Yeah?
You are the leader. So you
no.
Going on time. I know you will be a few minutes here and there, but
yeah.
The most important thing is not giving any memento or bouquet and waste of time. I think that's the most.
So I am planning to give the memento in the form of this book, and please accept it as a token of appreciation from Mumbai Kidney Foundation. And before you leave, I have to thank ZYDUS for being very generous in giving us this educational grant. Without the help of ZYDUS and the organizational team of ZYDUS, this conference would not have been a success. They had just opened their hearts out and said, just make this conference as good as it can be. No, thank you ZYDUS, thank you everybody, thanks the audience for being such a great show.
Great show, very nice.
The format was very good.
No interactive, captive.